We are live now, ma'am.
Yes. Good morning to all. I welcome you all for the second day webinar of our Southern Federation. That is Tamil Nadu, Kerala, Karnataka, Andra and Telangana. Yesterday we had the full day webinar of fully covering the obstetrics. Today preferably we will be covering the gynec topic of all A to Z. Today I introduce Dr. Priya Kannappan and Dr. Kritika. Dr. Priya Kannappan is an active EC member of ObGyn and Dr. Kritika is also an EC member of ObGyn. They will be telling the recap of yesterday's program. Dr. Priya Kannappan will be recapping the yesterday's morning program and Dr. Kritika will be recapping the yesterday's afternoon program. And once again, I welcome you all the delegates and the faculties for this webinar. Dr. Priya, you can do the recap.
Thank you, madam. Thank you for the wonderful introduction. Is my slides visible?
Yes.
Thank you, madam. Thank you.
Go to slides. Yes.
Yes. So, thank you. So today we will be just giving a short recap of what all happened yesterday. So we started with the first session, which was COVID in pregnancy. And the most salient point which I found was experience with ISO KGH was shared. And they have found only a pregnancy loss of only 2.2%. And the most common problem which was encountered in the COVID pregnancy was preterm birth. The Delta wave or the second wave was the most serious form of the infections. There was increased hospital admissions, ICU stay, ECMO, increased death. And there was 5-time increase in ICU admission in the pregnant women compared to the non-pregnant population. So, and the other things we all know. So, and the second topic was obstetric outcome in COVID. And in that, we came across that there's increased preterm birth admission to the NICU. Though we documented that there's an increase in the stillbirth, it was not significantly high. There was no difference in the neonatal death rate. No elective sections was recommended for COVID per se. If there is refractory hypoxemia in the management, in consultation with the intensivist, if you feel that it is necessary for resuscitating the mother, then section may be decided. Termination after initial stabilization, breastfeeding can be given to all the babies. So appropriate use of remdesivir and steroids have been emphasized because in India, we know that steroids had been overused and we got that mucormycosis, which was not documented in any part of the world. So appropriate use whenever is necessary. And the scoring system, which is based on the CT score, that is CT is like, the cycle turnover. So if it is more than 35, it means that is negative for COVID. And if the CT scan score of more than 15, it says severe. And we know the other markers which has been there. So, and the third topic was COVID in the neonate. So, and it was like they said, the RT-PCR, if it is positive on day 1, then it is documented vertical transmission, which has been less than 1%. And the experience with the children's hospital has been shared. And they had experienced only 3 neonatal deaths. One was due to sepsis, one was due to the heart disease of the baby, and another baby had multiple anomalies needing multiple surgeries. So there was no death documented for COVID per se. And investigation which is usually done in the neonate was chest X-ray, CRP, ferritin, procalcitonin. CT chest has not been done for the neonate. So as far as neonate is concerned, most of the children had mild disease. So they didn't have any severe disease. And if at all they had hypoxemia, they were managed as per the normal hypoxia pathway. So then we came to the session 2. And in session 2, the first topic was RH iso immunization. So in that, we know that all the pregnant women were tested for blood grouping typing in the first prenatal visit. If they are RH negative, the partner is screened for the ABO RH typing. Then you do, there is a possibility to get the fetal blood group by the NIPT, that is a non-invasive testing of the cell-free DNAs, which is not routinely done, but if it is an iso-immunized pregnancy and you want to do it, that is also possible. Antibody is not given in an MTP, that is medical termination, which is less than 8 weeks. And if at all a patient is having threatened abortion, if she is having very much of heavy bleeding, we give antibody, but if it is just spotting, antibody is not given. Incidentally, finding a subchorionic hematoma on ultrasound, antibody is not given. And baseline ICT should be done in early pregnancy, and ICT is repeated every monthly. A racing titer, if it's seen, then you repeat it every 2 weekly till it reaches the critical titer. And once the critical titer, then you monitor with the MCA PSV. And once MCA PSV of more than 1.5 moms, it means it is moderate to severe anemia. And then you go to a fetal medicine therapist to decide on whether they need cordocentesis or intrauterine transfusions.
Priya, 8 more minutes.
Yes, ma'am. So next is peripartum cardiomyopathy. We all know that. So anemia correction, fever treatment, and through a second trimester 2D echogram should be done either in the second or third for all the women, though it may not help you to predict or prevent the peripartum cardiomyopathy, but it can rule out other cardiac diseases. So, and the diagnosis is based by echo and the brain natriuretic peptide, the N-terminal. Mortality can be documented even after 5 years from the peripartum cardiomyopathy. So the patient is kept for follow-up. So it's a multidisciplinary care. Lactation can be given, effective contraception, relapse of almost 20%, and subsequent pregnancy is discouraged, especially if the ejection fraction is less than 50%. So this is the follow-up. So in the subsequent pregnancy, you follow up very frequently with the multidisciplinary team. So then was the keynote address. It was excellent on the relevance of VBAC now. We know that the primary cesarean section rate is increased, especially in the south. And if we are going to do repeat section for all that, we will know that everybody is going to be queued up in the OT. So the factors for success was first is the desire of the patient. Patient should want the success. I mean, they want to try normal delivery. And if they've had vaginal birth, spontaneous labor, there is a non-recurrent indication and there's a supportive team, then it is very, very useful. And then contraindications, we already know if there is prior rupture, prior uterine surgery, prior classical T or J-shaped incision. So you have to know like what is the type of incision is given then. And causes of failure, if there is a short inter-pregnancy interval, if there is previous, like this pregnancy is a preterm or section was done for preterm labor and induced labor, BMI of 30, special precautions in short stature because the chance of failure is high. And if the onset of labor is more than 41 weeks, if it doesn't go into labor, that is one of the factors for failure, but that should not stop you from trying for the pregnancy. So this is the model calculators, which you can use it in your OPD. So you can just fill these calculators and then you can see the VBAC success rate as well. So now we know that the role of induction, you can put Foley's catheter, ARM can be done, oxytocin for augmentation have been tried. So session 3 we came and that was about gestosis screening. So we know that we have to do careful surveillance if the screens are positive. There is a role for low dose aspirin and calcium supplementation if they are screen positive. So the gestosis score is available in the Google Play free of cost. History taking should be given a priority. And if a score of more than 3, there is a very high risk of preeclampsia. So these are the scoring things which is based mainly on the history. This is available in the Google Play Store. We can go and download it there. And the next one was about PRESS syndrome. PRESS, we know the treatment is based on the prompt recognition and early treatment, supportive care, antihypertensive, control of seizure, correction of hydration, and prompt delivery. We know that MRI is the most significant test for that. We don't do angiography unless there is focal neurological deficit. And in MRI, we see these non-specific white matter lesions are seen, mainly in the parieto-occipital region. Visual impairment is the most common sequelae, and complete recovery occurs in 70% in 1 to 2 weeks. So the next we came across was the fetal growth restrictions or the IUGR. Now we don't call it IUGR, we call it fetal growth restriction. So there is no role for low dose aspirin or low molecular weight heparin unless you have hypercoagulability, that is the thrombophilias or APLA. There is no benefits from sildenafil, but it's been used. Gene therapy, that is VEGF into the uterine vessels, that is through the femoral vein. When you go and add this into the vessels, it is having a role, but it's still there in the research setting only. Timing of delivery is based on the individual risk approach, and the mode on delivery should be based on case-to-case basis. We all know the finding severity about Doppler. I'm not going to go into that. Then we come to the session 4. So this was the sessions which I'm going to cover the last. So we know that most of the circumstances were like, either intended or unintended. We know in our developing country, we know that we have people who get married in the early stage. So that's early marriage leading on to intended pregnancy as well. So definition for that is the UNICEF has defined this teenage is between 13 and 19 years. They have an increased risk of preterm birth, fetal restrictions, molar pregnancy, anemia, preeclampsia, sexually transmitted infections. And in the labor, they have prolonged or obstructed labor, birth injuries because the pelvis is not very well developed, and they have PPH and puerperal sepsis. And the primary prevention is that offer sex education, which should start from the schooling itself, effective contraception, making emergency contraception available, parental involvement. So the decision making and all these things should involve the parent, and also the parent should be told that the importance of the sex education as well. And in secondary prevention, you have to have proper counseling for these young mothers who are being pregnant, or for termination of pregnancy, especially if it's unintended or unwanted pregnancy as well. And even otherwise, that can be discussed, and the patient's choice should be given a priority. Safe abortion services, very, very important. We have to emphasize on that, because if we refuse abortion, then they are going to go to some untrained quacks, and we are going to lose those mothers. So safe abortion services, and definitely providing a post-abortal contraception and advice as well. So thank you for the opportunity. So I finished with my morning session, then will be followed by my other colleague who will be giving you in detail about what has happened in the afternoon. Thank you, madam, for the opportunity. Thank you,
Dr.
madam.
Very good, Priya. It's a comprehension of yesterday's activities.
Good morning, ma'am.
Kritika, you can.
Yes, ma'am. Sharing.
Share screen.
Down you'll have a green color. Put it as share screen.
Kritika, first you open and minimize it.
I'm not able to share. I'll try again, ma'am.
You zoom on you make it as like fully enlarged up here, and then you'll find it in the lowermost border. You'll get a share screen. Green color.
Share screen வருது ma'am. அதுக்கப்புறம் click பண்ணும்போது yeah, I got it.
You will see some tabs,
zoom on reduce பண்ணிட்டு go back. Yeah.
Yes.
Yes, ma'am. Is my screen visible, ma'am?
Yes. Screen is visible. Now you reduce this and go back and open your PPT. Minimize பண்ணிடுங்கப்பா.
Yes, ma'am.
Madhumita is
Kritika,
Karan's wife, ma.
Yes, I request you to please open the
MCH
PPT
in
first.
Ramachandra.
Yes, ma'am.
Oh, right. And you are the daughter-in-law of Chandra.
Kritika, first you open the presentation and minimize it.
உங்க PPT open பண்ணி minimize பண்ணிடுப்பா. Keep it down, somewhere down.
After that, you please click on share screen, and then you have to click on PPT tab, so that it will be directly visible, ma'am.
So, Deepika, if you have any difficulty, WhatsApp me, I will show.
Yes,
Yeah, the PPT you can just WhatsApp to the organizer. You can either send it to Priya or the Shield person, then we'll be sharing it.
Yes, ma'am. 2 minutes.
Yeah, மாத்தி சொன்னீங்கன்னா அவ கன்ஃபியூஸ் ஆயிடுவா.
இல்ல மேடம், அப்படியே ஒரு உள்ள இருந்து வருது தெரியாம. நீங்க பண்ண கூடாதுன்னு நினைக்கிறோம், ஆனாலும் தானா ஓவர்ஃப்ளோ ஆயிடுது.
Program evening, ma'am.
மினிமைஸ் பண்ணி ஸ்கிரீன் ஷேர் பண்ணு.
அந்த வரேன், எனக்கு அது ஸ்டக் அப் ஆயிடுச்சு.
Dr. Niranjan is not that, Kritika.
Ask him to at least forward it to Priya.
இருங்க மேடம், அவ கொஞ்சம் டென்ஷன் ஆயிடுச்சா ஏன்னு தெரியல. வரலடா, அப்பதான் நம்ம நார்மலா இருந்தா கூட டென்ஷன் ஆயிடுச்சு. சமயத்துல வரல.
தெரியும் மேடம். நான் ஒரு தடவை நானே அதே மாதிரி பேனிக் அட்டாக்ல ஓடி இருக்கேன் வெபினார்ல. அப்புறம் எல்லாரும் சொன்னாங்க நீங்க ஓடி கத்துனதெல்லாம் கேட்டுச்சு அப்படின்னு.
Priya, have you given a call to Dr. Tarun and Dr. Subhash? Sri Priya?
Madam, everybody is in already.
Madam, present.
Subhash is there. Dr. Tarun also is there.
Yes.
எனக்கு தலை கொஞ்சம் வலிக்குது பிறகு.
Angela மேடம் தலை வலிக்குது. ஆடியோ மூவ் பண்ணுங்க.
Sampath ma'am.
Hello madam.
Priya.
Madam.
Yes ma'am.
இல்ல ஸ்ரீ பிரியா கண்ணப்பன் அப்படியே இரு. ஸ்ரீ பிரியா.
Yes ma'am.
நீங்க அவங்க கிருத்திகாக்கு கால் பண்ணி உங்களுக்கு அனுப்ப சொல்லுங்க. பேனிக் ஆக வேணாம். அதுக்குள்ள நீங்க ஸ்கிரீன்ல வந்து இவங்க டாக்டர் தருணும் அடுத்த மாடரேட்டர் 2 பேருடைய சிவியும் போட்டீங்க. ஐ மீன் கோஆர்டினேட்டர் சிவி போட்டா பிரியா கண்ணப்பன்
இன்ட்ரோ듀ce பண்ணிக்கலாம்.
இன்ட்ரோ듀ce பண்ணிட்டு நீங்க பிரியா கண்ணப்பன் 2 பேரும் இன்ட்ரோ듀ce பண்ணட்டும். அதுக்குள்ள நீங்க அவங்கள்ட்ட இருந்து வாங்கி நீங்க ப்ரொஜெக்ட் பண்ண ரெடி ஆகுங்க. சோ லெட்ஸ் நாட் வேஸ்ட் டைம். சம்பத் மேடம் சொல்லலாம்னு பார்த்தேன், அவங்க வேற ஏதோ ஃபோன்ல இருக்காங்க.
ஓகே சாயித்யா ஜஸ்ட்
ஓகே கோஆர்டினேட்டர் அப்ப இன்ட்ரோ듀ce பண்ணுங்க. ஓகே அதுக்குள்ள பிரியா கண்ணப்பன் நீங்க அவங்களை கால் பண்ணுங்க.
Sure ma'am.
Dr. Priya Kannappan, you can introduce. I will call Dr. Kritika.
Yeah, can you put the CV please? It's a great pleasure to introduce Dr. Madhumita. She's a consultant reproductive medicine. She's been treasurer of the Salem chapter of TAPISAR and the member of the FOXY. And she has done her UG from Madras Medical College and PG MS from Mysore JSS College. And she's done a fellowship in reproductive medicine from Manipal. And she's been member of many other societies, and a field of interest is PCO. So over to you, Madhumita, and she'll be the coordinator for you today.
Thank you, Priya ma'am, for your kind introduction.
Madhumita, only 1 minute. First, you invite Dr. Mandakini Mek, madam. Yes, she will introduce Dr. Tarun and Dr. Subhash Malaya. Can you call Dr. Mandakini Mek for introduction of moderators, and you can introduce the panelists. Okay?
Yes, ma'am. So it's my pleasure and privilege to call upon Dr. Mandakini Mek, who needs no introduction. Ma'am?
Yes, Priya, you put the CV of Joseph and Tarun madam and Subhash. Mandakini Mek madam, are you there? Mandakini Mek madam? Don't think so.
She has put a message in WhatsApp. She is there, I think.
She wanted to introduce. Anyway, you proceed.
Join பண்ணல அதுல.
Yes, Madhumita, you start.
Yes, ma'am.
She left, I think.
So we now move on to our first session, which is a very interesting panel discussion on endoscopy in myomas. So we have two very enthusiastic moderators, Dr. Tarun Joseph and Dr. Subhash Malaya. Dr. Tarun Joseph, he's a consultant in Joseph Hospitals and a labor in charge at Joseph Hospitals. He's a high-risk obstetrician and he's done his fellowship in minimal access surgery. He's currently the assistant professor in SRM Medical College. Next. Our next moderator is Dr. Subhash Malaya. He's the chairperson-elect FOXY Endoscopy Committee in 2021 to 23. He's a zonal coordinator to FOXY President 2020. He was the secretary of Calicut Society 2020 Kerala chapter IAGE and managing committee member of IAGE 2019 to 2020. And he's organizing secretary of National Yuva IAGE 2018. And he's published numerous papers and chapters.
Right. Okay. Thank you, Madhumita, for that.
Yes.
But do you want to introduce the panelists or Madhumita can do it?
No, Madhumita can do, ma'am. Madhumita can do that, ma'am.
Madhumita, you introduce the panelists also.
Yes. So we have our panelist, Dr. Prabha Desai. She's a consultant in LYDM Sparsh Multi-Specialty Hospital in Gadag, and she's won the Golden Jubilee Award and in Mumbai for the best thesis. She's won the best poster award in KISA 2019 and the best academician award of Gadag OG Society in 2015 to 2018. Our next panelist is Dr. Jnanashankar Natesan. He's a consultant, minimal access surgery, gynec oncology and reconstructive surgery in SKS Multispecialty Hospital and PG Institute and Manipal Hospital, Salem. He's done specialized work in advanced gynec endoscopy and pelvic reconstructive surgeries. He's the first title winner of Indian Idol of Gynec Endoscopy in 2020. His work on cervical thesis was published in BJOG. He's an operating faculty, live laparoscopy and colposcopic workshops, and organizer of Salem Express Highlight Lab and Modus Operandi workshop. Our next panelist is Dr. Guru Prasad Hosmani. He's assistant professor, Raichur Institute of Medical Sciences. He's a consultant laparoscopic and pelvic surgeon, Hosmani Hospital in Raichur, and secretary in Raichur ObGyn Society. Our next panelist is Dr. Niraj Yanamandra. He's done his training in advanced gynec endoscopy from St. Peter's Hospital in Chertsey, UK, and hands-on training in robotic surgery from North Texas Hospital in US. He's an ex-consultant from Kingston Hospital, London. Our next panelist is Dr. Reggie Mohan. Who's an assistant professor, Department of Reproductive Medicine and Surgery in SAT Hospital and Government Medical College in Trivandrum. He's a chairperson, Academic Committee of KFOG and State Coordinator of Sexual Medicine Committee, Food and Drug Committee, FOXY, and former editor of KFOG Journal. Academician Award of Gadag OG Society in 2015 to 2018. So I hand over to the moderators, Dr. Tarun Joseph and Dr. Subhash Mallya.
Subhash?
Yes, ma'am. Good morning, ma'am. Good morning,
Subhash, can you wait for 10 minutes? That recap session, second session is
please,
not over, I think. I was not aware.
Please, madam. Please, madam.
10 minutes she will finish. Kritika,
no,
can you tell the recap of yesterday's afternoon session? Kritika, are you there?
Kritika, unmute yourself and
she shared her presentation, madam. So, Shri Priya, can you just share that and Kritika can speak?
Kritika, unmute yourself.
Yes, Kritika, proceed.
Kritika,
10 minutes, you can finish it.
Dr. Kritika, you just tell me next, I can go.
Kritika, unmute yourself.
Is she there? Huh?
She's there. Kritika?
Yes, ma'am.
Please proceed with the recap.
Are you able to see the screen?
No, Priya is presenting that. You just
Shri Priya will share it, Amma. You just start talking.
Shri Priya, share. Yes, Kritika, you start.
Good morning. Good morning, everyone. Thank you, Sambat Kumari Madam, Anjali Lakshmi Madam, and the entire team of TNFOG for giving me the opportunity to give the recap. Yesterday was a wonderful session, and each and every speaker did a wonderful job, and I'm very happy to do the recap of the same. So, Hema ma'am, as usual, was a wonderful talk. First 1,000 days of life. So we will start about nutrition first. So the important first 1,000 days starts from 730 days after month, that is from 0 to 23 months plus 270 days in utero. So this is a very important period to build a best opportunity to build a healthier and equitable future for children, families, and societies. It is very important because for the neurological development and also the intelligent quotient. So the maternal diet play an important role in epigenetic gene modification, which include the fetal gene, placental gene expression, so that the nutritional programming of the fetus.
It's possible to increase the volume.
Yes, ma'am.
Proceed.
Yes. So the growing evidence of proper nutritional status before and during pregnancy is the key to maintain maternal and offspring fetal for long life. So in India, we can see that 48% of stunted growth is seen in the first 5 years. This can be corrected by proper nutrition to mother as well as during the infant and neonate period. So this starts from patient counseling about obesity and diet management.
Next
slide. Yes, so this starts from the adolescent period, your pre-pregnancy, pregnancy, neonate, infant and child phase. So this includes maternal micronutrient supplementation, delayed cord camping, etc. So here in FIGO, there is an initiative called as ONI. We know it as Pregnancy, Obesity and Nutrition Initiative. So this thinks about nutrition and weight first at every contact. We need to address them so that nutrition should be corrected pre-pregnancy and during pregnancy. We can achieve it through guidelines, practice resources, advocacy and training. So this is the best gift we will be giving to the children, so to be free from the non-communicable diseases. So for that, FIGO has extended a nutritional checklist to every woman before and in early pregnancy. So this education should be extended not only to the mother, should be extended to the male partners and also to the community health workers. By providing proper nutrition, we can achieve healthy mother and also the healthy children. Second topic was an ultrasound in the early twins. So this is by Dr. Chinmay Madam. Here the focus was given to the identification of chorionicity and zygosity in early twins. So the main thing in early scan to identify, to exclude the coexisting twin and also any intrauterine or extrauterine pregnancy, since heterotropic pregnancies are increasing nowadays. Here lambda sign and T sign can be used to identify chorionicity. This is done best between 9 to 14 weeks. So when there is a disparity between the gestational age, we will be using the crown rump length of the larger fetus to determine the gestational age. And second, there is a systematic labeling of the twins, so that to identify the twins and for treatment of any twins, this can be used. So this will be done using the placental position, membrane direction, proximity, and cord insertion. We need to identify the number of fetuses, location, chorionicity, amnioticity, placental tissues, and unique complications. This will be the use of ultrasound in early twins. In case of nuchal translucency, the risk will be individualized in case of DCDA, but in case of MCDA, it will be average of both the twins. Next. In the management of the twins, MCMA is a very high risk with high perinatal loss less than 24 weeks. So the aim is to prevent iatrogenic preterm, fetal growth restriction, and fetal trauma during labor. So our care during pregnancy is being focused towards that. So ultrasound monitoring in DCDA twins will be every 4th weekly, and from 28 weeks, it should be every 2 weekly. And MCDA twins, you should start 4 weekly from 16 weeks and then 2 weekly. So vanishing twin, usually it will not be causing any complication. Mild bleeding or cramping will be there. In case of twin death, in the single fetal demise in the 2nd or 3rd trimester, there will be neurologically sequelae causing death of the co-twin. So if there is a death of the co-twin, we need to monitor weekly fibrinogen, platelet, and clotting profile should be done. MCMA delivery should be done by around 28 weeks. So TTTS, so 1/3 of monochorionic twins vascular anastomosis are quite common. Angioarchitecture of the vascular anastomosis need to be
3 more minutes, little faster.
Yes. Yes. So because unequal hemodynamic fluid imbalance is there, so pathophysiology is net transfer of fluid. So from 16 weeks, we need to do it every 2 weeks. Cunnilingus staging, we all know, it can be identified in the 1st trimester. Stage 2 can be treated with fetoscopic laser ablation. Madam did a wonderful video presentation of laser ablation, and it was done with the Cylindinger technique. Women or twins with TTTS should be delivered by 34 weeks. Next slide. Next, yeah. Immunization is very crucial. Rubella and chickenpox should be given pre-pregnancy, and we need to avoid pregnancy for 1 month. During pregnancy, we can give influenza, TD, and Tdap. So Tdap should be given between 28 to 32 weeks. And in special conditions, we can give pneumococcal and meningococcal vaccines. Next. So there's a wonderful panel discussion on LSCS. So incidence is 15%. Prerequisites are very important. So they discussed around 6 to 7 cases, and a non-engaged head, a floating head, we need to be very careful, slow the draining of the liquor and stabilizing with the left lateral position, with the lateral support should be given, and deliver the baby with flexion. And deeply engaged head, new technique of fetal pillow can be used. We should avoid vaginal incision and assess the anatomy and use either pull or push technique. In dry delivery, when there is nil liquor, the myometrium will be thick. So gentle delivery of the baby should be done to prevent any injury to the fetus. And when there is an incision extension, uterine artery ligation should be done. If it is severe or heavy, we need to do with internal iliac artery ligation. Crash cesarean mini checklist to be used. Next slide. So CTG assessment of competence. So usually it contains of 3 components. 1 is pattern recognition, 2 is pathophysiology, and 3 is situation analysis. So the decision should be made combining both the CTG, clinical features, and the clinical picture. Next slide. So each and every scenarios have been presented. If there is persistent deceleration, we need to classify as normal, suspicious as pathological. Previous cesarean on oxytocin, sudden bradycardia, we need to rule out scar rupture. A CTG was presented and we need to do an category 1 cesarean section. So a very important point is that whenever there is a tachycardia or acceleration during second stage coinciding with contraction, we need to check whether it is a maternal heart rate or fetal heart rate, so that we need to know the fetal heart rate again. Second, next. Hypothyroidism in pregnancy is quite common, around 0.3 to 4.8. So risk factors need to be identified. So the elevated TSH beyond 2.5 in preconception need to be addressed and given medicines accordingly. Whenever there is elevated TSH, TPO antibody testing need to be done depending upon the risk factor evaluation. If the patient is already on hypothyroid, taking the medicine, 30 to 50% increase need to be done. Postpartum readjustment of thyroxine should be done to pre-pregnancy dose. Next slide. Artificial intelligence was a wonderful topic. It is the newer horizon nowadays. So the applications are many. We use automated reasoning, knowledge representation, and automated planning. Next slide. It is used in male infertility, in computer analysis. It is also used to reduce the ICSI workload, and we are using it for oocyte grading to improve the precision in IVF, embryo selection. Embryo ranking intelligent classification algorithm is also used. It is also used in assessment of antral follicular count, follicular tracking, and also used in gonadotropin calculation. And implantation prediction and success rate is used, but it carries some disadvantage, like it uses multiple platforms, lack of standardization, data bias, and fake news. These are the problems with artificial intelligence. It needs to be used with caution in the future. Next. Last will be the magnesium sulfate in obstetrics. So timing of magnesium is once given, once the decision to delivery is made. MACPIT will prove that magnesium sulfate is the best drug in reducing the risk of preeclampsia in women with preeclampsia. Routine magnesium monitoring is not recommended, and mortality is reduced by 46%, and eclampsia is reduced by 50% in women. And it is the better alternate for compared to other anticonvulsants. It usually acts by cerebral vasodilatation, reducing the inflammation, and it inhibits the platelet activation. So it will not affect the breastfeeding, and it is also used in neuroprotection in preventing preterm birth, regardless of the reason. It also prevents the cerebral palsy and also the motor dysfunction. So it is ideally used, RCOG recommends before around 24 to 29 plus 6 weeks. Next slide.
Thank you, Kritika. Wonderful presentation. Subhash, you can proceed. Thank you.
Thank you.
Thank you, Subhash.
Sorry for the delay, ma'am.
No problem. Wonderful presentation. Priya and Kritika, thank you. Dr. Subhash?
Yes, ma'am. Yes, ma'am.
Yes, you can start.
Tarun, yeah. At the outset, ma'am, myself and Tarun, we are really grateful to Sampath madam and Revati madam, Anjalakshi madam, the whole team for this wonderful idea. Again, ma'am, it's been at your core area that you want to unify all of us. It's very good. I think we have our own small little differences, but I think all of us should come forward and be one. If all of us grow forward, only then the association also grows forward. Right. Anyway, it's a wonderful opportunity. I'm looking forward for all the positives from this particular year onwards, ma'am. Again, ma'am, let me take this opportunity to welcome all of you for the South Zone UFOXY, which will be held in the month of March 10th, 11th, and 12th at Calicut under Dr. Sampath Kumari Madam and Dr. Rishikesh Pai sir. So, Madam, Madhuri Madam also. So please do find this wonderful opportunity. Come down to Calicut. Let's have a lot of academics. Let's have some very good entertainment also along with that and academics. Please do block your dates. That's from 10th, 11th, and 12th of March 23. So please do remember this. Right. Now, coming down to this particular topic about Nadu in myoma, as Tarun has rightly put it across. Again, I am really grateful to Tarun for all the logistic supports and for all the videos, also good videos. I would like to welcome all my panelists here. Dr. Prabha Madam. She just called me. Yeah, she's here. Right. Now, anybody can take any of the questions. I don't see Jnanashankar, sir.
Hey, I'm very much there.
Yes, sir. Yes, sir. Okay. Jnanashankar, sir. Then, of course. Hi, Neeraj, sir. Dr. Reggie, sir. Hi. Guru, hi.
Hi, Subhash.
So, this question is open to all of us. Like, she's a case of Miss X, 30 years, paraben living 1 with an LCD of 2 years. She's complaining of mild menorrhagia and dysmenorrhea, and it's controlled with tranexamic acid. She's also planning for pregnancy. Now, on an ultrasound, it's about 6 centimeters intramural myoma. Now, we have Dr. Reggie, who is from the infertility section in Trivandrum Medical College. We have Dr. Jnanashankar and Dr. Neeraj, who are from the RCOG side. And we have Dr. Guru, who is also working in the medical college. So we have I wanted 2 different conflicting views. So that's why I've got 2 sides on one. Now, Dr. Reggie, how would you go about this case?
Good morning, Subhash. Thank you for the question. And for us, she's a para 1 live 1. Was it a previous CS or a normal delivery?
Okay, sir. We'll make it normal delivery, sir.
Okay, normal delivery, and she was not treated for infertility. Was she treated for infertility? So, okay, intramural 6 centimeter myoma. My take is, 2 years. Okay, thank you. So my take is usually as an infertility specialist, all subserous myomas usually we don't for this.
This is an intramural, sir. I have made it more complicated for you. I have made it 6 centimeters and intramural.
Okay. Did you map do you have an ultrasound picture or anything?
No, we have done an MRI. We have an MRI also. This is the MRI picture, sir.
Okay. So bulky uterus. Yeah, fundal submucosal myoma is there, and 2 fundal subserous fibroids. Subserous fibroids I'm not bothered, but the submucous fibroid, which is 3 into 3, is bothersome and it can hamper the fertility. So I would like to do a sonosalpingogram, or whether it is distorting the cavity. That is the main thing, and she is symptomatic also. Definitely, I would like to.
Sir, may I interrupt, sir? May I interrupt here, sir?
Yeah.
Sir, you said about sonosalpingography, sir. In this case, now I find that you have a submucosal fibroid 3 to 3 centimeters. Do you really feel that whether 50% or whether it matters, sir?
Yeah, I would like to know whether it's a type 0, type 1, or a type 2 fibroid. So the approach to the fibroid can be decided whether you can go for a laparoscopic route or a hysteroscopic route.
May I request Omana Madam to please mute? Omana Madam, can you please mute?
Yeah,
please.
All of you know about the classification by SFIGO. So I would like to type it in whether it is a type 0 or a type 1 or a type 2, so that I can decide on the surgery, that is whether I have to go for the hysteroscopic route or a laparoscopic route. Another thing is whether I can do it. Suppose if I am doing it in a hysteroscopic route, whether it's a complex surgery or a simple surgery.
Okay, from my side, I am a bit surprised with the difference we find in ultrasound and MRI. Just makes you suspect the quality of ultrasound that we have got here. But I think for me, this MRI would suffice to plan my procedure. When they say it is less than 50% in the cavity, I would say she needs surgery, and I will definitely take her up for a histolab, then plan my procedure on table. Subhash, what is it that you want us to know?
Sorry.
No, sir. I'm just trying to bring out a difference of opinion, because this is what happens, sir, unfortunately, in the private practice. Now, what I would like to convey, sir, I think there is no doubt about that. Since we're dealing with whether we want infertility related to fertility, whether do or not. I think submucous myoma, I think there is no doubt about this, whether it is 50%, because more than 50%, of course, whether we do it lab or via history, I'll come down to that. There's no doubt that submucous myomas do need removal, irrespective of whatever be the size. It's again, infertility fibroids, it's very, very clearly said about this particular practice that submucous fibroid of any size would impair fertility. I think there's no doubt about it. And excision of the submucous myoma seems to restore the fertility with pregnancy rates after surgery. Now, my question to all three of you, to Neeraj sir, to Prabha madam, and to Guru right now is, now, as Jnanashankar sir was telling, he would plan an histro lab, and Raji sir was about saying that histros. Now, you have more than 50%. Suppose you have more than 50% which is inside the cavity, I mean, less than 50% is inside the cavity. Would you like to do it hysteroscopically, or whether you would like to do it laparoscopically?
Can I come in, Subhash?
Yes, sir. Yes, sir.
Yeah. Now, as Dr. Jnanashankar said very correctly, to me, it looked like two different patients you're talking about. One with intramural fibroid and the other one with submucous and subserous. Anyway, that leave aside. Now, what are the symptoms? Is this lady actually trying for pregnancy, or are we assuming that it is causing infertility? Did she have fibroid before previous pregnancy as well?
No. So she was. No, this is an hypothetical one. She was absolutely a very normal patient, but now she's trying for conception, but then she has this.
Yeah, and if you see her preconception, obviously that is what we're doing. Then with this kind of picture, I think laparoscopy is something which I would do, and do a laparoscopic myomectomy, because even the submucous fibroid, it's more than 50% is in the myometrium, and to make sure that we remove the total myoma which is submucous, laparoscopy, when you're doing it, you might as well do laparoscopically. So I would probably not do this hysteroscopically, but I would go laparoscopy. SOS hysteroscopy, but I'm sure I'll remove.
I think I concur with your view, but again, are we in unison with this, or do we have any other difference of opinion in this? Prabha madam, Tarun, yourself?
Yeah, usually I agree with Dr. Neeraj. Usually, if it is less than 50% of myoma is in the cavity, it's better to go for laparoscopy. Hysteroscopy, we can evaluate the cavity, how much is the size, we can evaluate the ostia, as it's a case of infertility. So it's better we can go for myomectomy through laparoscopy.
Subhash, I think it is looking like one atop of another.
Yeah.
So I think once you make a fundal incision, you take out one, the other one is adjusted. That's why in ultrasound they gave it as one fibroid, I think.
One more doubt that I have is, now, subserous fibroid, 4 centimeters, Raji sir was very, very adamant that no, we will not do anything. Now, if we are doing laparoscopically and we see that 4 centimeters, shall we remove or not, sir?
Definitely, we will take it off.
That's right. So, if it is a simple subserous fibroid, we will not go for that, but there is no doubt about
anyway,
that.
You're going for a procedure.
Doing a concomitant hysterolaparoscopy, I think once we see that, removal of that does make it. We'll come down to that next.
Hello.
Prabha madam?
Doctor, I differ for this subserous. Hello.
Prabha madam, we can hear you, but there is some disturbance, madam.
Yeah. See, I differ for your subserous fibroids. If they are large enough.
I request everyone other than the panelists and the moderators to please mute.
Hello. See, if the subserous fibroid is big, the recent current theory says that fibroid itself secretes some prolactin, and they are having the interleukin factors, and those are all things which hinder the endometrial receptivity. Okay, so if your patient is a case of secondary infertility, and if she is not responding to the your regular treatment, your other factors has been evaluated, then better to go ahead and take out the fibroid, because fibroid itself may secrete some endocrine hormones and will cause infertility. If it's such a 6 centimeter big fibroid, I will prefer to go and take out the fibroid, even if it is
Madam, as an exception, I will accept it, but I think on the whole, if you have to give a take-home point, I think subserous fibroids. I think we would concur that we would try to avoid if it's a case of fertility aspect. Of course, as you rightly said, in cases in which all other factors have been ruled out, we are not able to find out anything. So obviously, for such a case, it may be accepted. But otherwise, Tarun, we have the next slide. As I think what I was trying to say is in the next slide. Subserous fibroids usually do not affect the fertility or spontaneous abortion. This is from the fertility and sterility, which I've actually quoted now. Now, of course, yes. Now, the next part of the question is, Jnanashankar sir, to you, yes. What has been said is removing them does not confer any benefit. Now, I would like to take the opinion of all five of you in this aspect. Subserous fibroid, whether removal, would you agree? Not as an exception. Routinely, would you agree, or you'll find out that there is some reason for that? Yes.
Okay. See, from
it's a tricky question. I know it's a tricky question.
From a surgeon viewpoint, no, I got something to just add. See, if it is already 5 centimeter, 6 centimeter, it is subserous fibroid. Now, removing it, operating and resecting and then retrieval of the fibroid all becomes an easier affair. I am only thinking what happens. You wait for 2 years and 3 years and then see the fibroid grow 8 centimeter. The whole thing changes. So from the surgeon viewpoint, if I find anything more than 5 centimeter subserous, if I am already inside, I would rather remove it.
True, sir. No, absolutely. So I have to concur with that. But again, audience, please don't go back with the notion that for all subserous fibroid we need not remove it. Yes. Now, this is something which I think Dr. Neeraj and Dr. Guru, there's an intramural fibroid. Okay, in this case, if it was, and it's impinging the cavity, what would be your route of option in case of fertility aspect for this case? Tarun, please feel free to add. Tarun, please feel free to add.
What's the size of this fibroid you're saying?
So this is about 5 centimeters, sir.
Yeah, 5 centimeters. I would imagine if she's impinging on the cavity, she may as well have menstrual symptoms in terms of menorrhagia, if at all. And if she is trying for a pregnancy and is unsuccessful, then I think removing the myoma is the answer, and it can be done laparoscopically.
Fine. Sir, if it were to be about 2.5 centimeters, what would be your take on it?
Then depends upon what she has presented to me with. If it is a 2 centimeter fibroid intramural and she is not having any symptoms, I'd just leave it.
Dr. Reggie, do you feel that anything which is impinging the cavity would definitely create some sort of symptoms? You would like to remove that or not?
If she is
symptomatic, this is now the second part. It's 2.5 centimeters. I've made it even more controversial now. 2.5 centimeters.
Yeah, 2.5 centimeters intramural fibroid, and if she's worried about if she's having menorrhagia, that is you have to think of any other causes for menorrhagia. But as such, 2.5 centimeter intramural, if it is not impinging the cavity or not disturbing the endometrial architecture. And I would like to
No.
I would like to
let's confine to one which is impinging the cavity. I'll come down to the next part. One which is impinging the cavity.
Para 1, live 1. I would like to go for infertility treatment before considering it removing. Before trying for removal, I will definitely try for ovulation induction and other factors.
So you would not remove that fibroid,
2.5
which is impinging the cavity.
Yeah, just 2 years, and she didn't take any treatment for infertility.
Dr. Guru, your take on that?
Suppose if it is impinging cavity, then it's better to remove, as it may hinder with the implantation during pregnancy, or there are also chances of abortion during pregnancy if it is distorting the cavity. That's what I feel.
Dr. Reggie, your take, your rebuttal to that?
2.5 centimeters, I think I will give her a chance. So many patients are delivering with 2.5 centimeters, and why you give her a chance before putting your knife into the uterus?
Right. Okay. So now what we can
is always a tricky situation, no? Type 3. This is type 3. Yeah, it's in the intramural, just contacting the. But I think anything which comes close to the transformation zone has got. The junctional zone has got an impact on fertility and then pregnancy. But you really put 2.5 centimeter, it makes me think.
Sir, Jnanashankar sir, that the reason why I put it was, I first laid the trap for 4 and then I put the trap for 2.5. That is why, sir. So now, the reason for that being, let's be very clear.
Woman whom you are telling, whom she has just delivered 2 years back, and he just started planning her pregnancy, I would rather wait for some time, see whether she conceives and then goes fine. Yeah.
So let me take the opinion of the house. All of us are concurrent that if we are about more than 4 centimeters, it's impinging on the cavity, we would definitely need to have some sort of, if she's symptomatic, then yes, surgery is an option. But again, if she's about 2.5 centimeters and she's not very symptomatic, I think we may give her the benefit of doubt. We can wait for about 6 months. Of course, though my mind, though I would be more inclined towards what Guru said, towards surgery for 2.5, but still, we can wait here. Now, the next question is open. It's an open one. I want every one of you to please. Now, we have an intramural myoma, which is not distorting the cavity. Now, this is the problem that we have in most of the cases, and most of the fibroids or the surgeons go into disrepute because of this. Now, somebody say they will operate, somebody say that. Let's have some very clear concepts about this. Now, in this case, what we do is, please understand that as Dr. Prabha Madam was saying, that all fibroids have some effect on fertility. That do have. Yeah. Does the presence of non-cavity distorting fibroids have any deleterious effect on fertility? And the next question is, does removing it improve the fertility? So that is the most important point in today's context, So now, next slide, please. Yes. So please understand that women with small intramural fibroid, less than 5 centimeters, discovered on pelvic sonographic studies in IVF were matched by age and everything. But when you go back and see, what happens is, all these patients, let's agree that all these patients have lower pregnancy rates, lower implantation rates and everything. But then just by saying that, are we justified in doing a surgery is the question. I'm sure the answer is very obvious. Dr. Reggie and Dr. Neeraj, what is your take on it?
You have to individualize each case.
Yes, absolutely. Dr. Neeraj, please carry on.
We can quote submitted papers justifying removing and justifying not removing as well. But there is enough evidence, and I have seen good papers. I mean, as early as 1995 and early 2000.
Next slide, please.
They have clearly shown that there is inflammation at the level of the endometrium overlying the fibroid, submucous or intramural fibroid as well. And that inflammatory endometrium and the presence of the fibroid, which may distort the blood supply to the endometrium, if the embryo is implanted on that area, can either lead to miscarriage or implantation failure if you're doing IVF. So there are enough number of high quality papers as well, which suggest that removing the fibroids, even if it is intramural, on the hypothesis that it is interfering with the blood supply to the embryo, if it is implanted on the area where the fibroid is underlying. So therefore justifying removing these fibroids. So no matter the size, I mean 2 to 4 centimeters also needs removing if there is infertility, or if you want to enhance your chances of IVF if she is going to have embryo implantation.
Yeah, I agree.
Dr. Guru?
I go with Dr. Neeraj. As he rightly pointed, any size, if a patient has presented with infertility, and better we have to remove the fibroid.
See, if you tell that fibroid is the cause for infertility and you remove the fibroid, and if she doesn't conceive,
no, we're not saying it's cause for infertility. No, sorry. We're not saying it is cause for infertility. We are saying it enhances the chances of success of IVF treatment. It does not mean it is cause. And also, we all know that we have grown up with the concept that in the absence of any other obvious reason for infertility, presence of fibroid has to be assumed as the contributing factor or the causative factor.
True, sir. True.
So that is Dr. Prabha, madam. Dr. Prabha. Dr. Prabha Desai, madam.
Yeah. See, this is, sorry, I was in between my airport line, so I got...
No, we can see you.
This is, see, intramural fibroid, intramural fibroid, if it is distorting, means according to FIGO type 3, okay, so I will prefer to take out, okay. If it is type 4, then we have to decide and individualize the patient, any other cause and all. But type 3, more than 2 centimeter, definitely I would like to take out those fibroids.
In conclusion, let me ask Dr. Jnana Shankar, so what is his take before I...
See, so we are actually visiting surgeons of a lot of IVF centers. So in practice, none of the IVF specialists want to continue doing a transfer with such fibroids around there. So in practice, I think we go ahead and then remove. Because not just by mere presence, but there are a lot of chemical mediation by which it goes against pregnancy implantation and continuation. So we do go ahead and then remove.
See, not
So I
only
think
for
treading a very cautious path. Yeah, I think all of us like treading a very cautious path. What I can suggest is, based on this, is any fibroid which is less than 4 centimeters, not encroaching on the cavity, they have their IVF and ICSI outcomes which are compatible with the patients. So I think such patients, we can give the benefit out of not operating on such patients. But of course, as Jnanashankar sir says, there is a lot of difference between the reality and the theory aspect of it. Now again, for more than 4 centimeters, and if such patients are submitted for treatment before they enroll for IVF technique, we may think of myomectomy, as Dr. Jnanashankar sir has rightly put it across. So that is something which, but these are not take-home point. This is something which is suggestive, because in fibroids always there's a lot of gray area in everything. Now the next part of it, before I think we'll just finish because I need Tarun also to take over this. Then I think let's understand either the location or the size are important. The fibroids are more likely to be present in patients with increasing age. So definitely, as we said, age is something which also we have to look out to before we take it into consideration. Next one, please. We just push up the next 2 slides. We just run through that because we need time to give for your case also. That's one. Next. Yeah. Next. Now we are all in concurrence with it that non-cavity dystonic fibroids do have lesser one. Now definitely yes. Now the problem with this is now Tarun, take over the next case.
Yes, sir. Yes, sir. Can you hear me? Am I audible?
Yes, Tarun.
Yes.
Yeah. Okay. So I just wanted to ask, coming back to this same case, this is the case that Subhash sir was talking about. Would anyone think about doing just a removal of the submucous myoma, leaving the subserous myoma behind?
I wouldn't. For the simple reason that she's having an anesthetic procedure. I mean, that fibroid may eventually be contributing or not contributing, we're not sure. But what if tomorrow you realize that you should have removed it because it is contributing either in infertility way or a miscarriage way, or even having complication during pregnancy with the fibroid.
Okay.
So I don't, and even if nothing of these kinds happens, the fibroid is eventually going to grow. Maybe you're just postponing the surgery, which she may need 2 years down the line. So I would rather remove it in the same sitting.
So this was the case we did. As you could see, the histoscopic picture showed just a small indentation on the fundus. I just want to comment that the ultrasound picture that we first received was from outside. And the reason I put it, I wanted everybody to understand that it is important that you'll do your own ultrasounds or an MRI in this case, to identify your picture if you are not sure of where the ultrasound has been done. So this patient, she had, I think Jnanashankar sir had already come up with a diagnosis, 2 fibroids sitting on top of each other. So as you can see, the first one we're removing. If any of you would like to comment on the procedure being done. How many of you use a monopolar for cutting open the fibroid now, or does everybody prefer harmonic? And please.
I prefer the Caesar.
Okay.
Preferably Caesar and sometimes harmonic if it is quite vascular, but not a monopolar.
Not a monopolar. Anybody else?
Both Caesars as well as monopolar, depending upon. So it's not one thing which I use. Depending on the surgery, I use the monopolar or Caesar.
Okay.
What about endo knife? Tarun? Have you used a scalpel?
Yeah, endo knife. I have not used a scalpel personally, so no, sir. Have you? Any opinion, sir?
Endo bag. If you want to morcellate the fibroid, it has
endo
to be
knife, madam. Endo knife. Endo knife.
That's a theory. We have to morcellate end bag.
Okay. So as you can see below that, we found the other myoma. Now, suturing a fibroid like this, are we worried about entering the cavity or not? Does that change your management or how you would change your suturing?
Definitely, we have to plan for suturing differently for the cavities which has been opened and for not. I usually prefer to take a separate closure for the cavity and then for remaining myometrial bed.
And how many layers do you prefer, madam?
See, I take for myometrial one, endometrial one, then I approximate by box stitcher and then serosa.
Anybody else? Regisa? Any other opinions on how you would suture?
Endometrium, usually I won't close usually. I will just go above the endometrium.
Okay.
If advancedly, if we can open, then we have to do, but better to not.
Anybody else will close the endometrium separately?
No, if it is try to avoid taking sutures inside on the endometrium because it will lead to, or it may lead to intrauterine adhesions later.
Guru sir, any?
And I avoid to take endometrium.
Okay.
Usually we take
So I think everybody consensus is to suture maybe in 1 or 2 layers. Endometrium, most people don't take, but I suppose if it is your thing, you can go ahead with that.
See,
So
if
here
it
we
is
viewed
better to take endometrium separately.
All right, madam.
No, is it with the same suture material or different? Literature says that you have to you don't have to. You have to go for a smaller one.
20.
Yeah,
20
for the endometrium. Yeah, 20 for the endometrium.
Endometrium. And one number one barb, which
Not the routine barb. Not the routine barb.
Yeah, so here we've ignored this thing. We're just taking the serosa now, and we finished our procedure. When I was doing my research for this talk, I found more and more cases of doctors presenting cases where they've done hysteroscopies with 6, 7, 8 centimeters. There was even a case from Delhi of a 15 centimeter submucous myoma being done in a single sitting. Now, I'm not advocating it anyway. I'm not telling anybody to do it. We still use our 4 centimeter rule. I just wanted the panel's opinion on what you would think. Do you think there is a possibility where you would attempt a larger myoma hysteroscopically? Let's say a type 0 or type 1. Let's keep it simple.
See,
That's okay.
see, for patient safety kind of view, I always prefer to be type 0 and type 1 to be hysteroscopically. Anything bigger than 2-3 centimeters, better to do laparoscopy, because there is not only concern how expert you are to take out the fibroid hysteroscopically, but we have to think about the patient safety kind of view.
Okay. Anybody else?
And you're damaging the endometrium. You're damaging the endometrium with your whatever energy source you use. You are damaging the endometrium, and it can lead on to adhesions and Ashermans later. So if it's a big fibroid, and if it's a type 1.
I don't believe that there should be a rule. Rule word probably is not in there, simply because it depends upon individual skills. Someone may beautifully demonstrate in a workshop, or you can see the videos where you can see someone removing 4 centimeters very beautifully, but that person may be skilled to do that. I may not be. So therefore, it eventually comes down to how skilled you feel you are. So I don't believe in rules. But yes, I mean, anything like this 4 centimeter, I would not attempt hysteroscopy. I would rather go laparoscopy.
I think everybody.
4 centimeter is wrong.
Yes, and Gnanashekar sir?
Yeah, Tarun, see that particular case which you showed, no, I was thinking if somebody had attempted by hysteroscopy, the amount of raw area will be leaving inside the endometrium, I think it will be very big.
It's too much.
Yes, yeah, so I don't think we as a further we know the importance of endometrium. This small patch is valuable. So,
yes, sir. No, sir, this is just a question I put up because I kept reading a lot of cases where people are doing 7, 8 centimeters hysteroscopically. So I was just wondering if any of you all in the past. But anyway, in the laparoscopy, is there an upper limit of the size of the fibroid you would tackle when you do a laparoscopy? Not in this patient, let's say another patient is 15 centimeter, 20 centimeter. Is there a limit you would keep to your laparoscopy? Or is there any size fibroid you would be willing to tackle laparoscopically?
I wouldn't keep an upper limit because I've removed 32 week size fibroid as well, which I presented in ESG in Athens 2 years back. So there is no upper limit for this. If you read the literature, and most of it coming from European countries, they would have set a margin of 12 centimeter or 11 centimeter fibroid. Most papers would say that. But 15 centimeter removing also, again, it comes down to how much confident you are that you'll be able to remove it, and how skilled the whole team is around you to support you to do that kind of surgery.
So I will also agree with sir that we can't give the upper limit for the laparoscopic fibroid excision. It is their level of expertise. And say this thing you have to.
But do you think when we are doing morcellation and keeping a patient under anesthesia for 4 hours, 3 hours, 4 hours, and 5 hours, are we warranted? Is that all right? Instead of doing a half-an-hour procedure and taking out with a slightly bigger incision.
I'll tell you what. So sorry, I'm interrupting. Yeah. Because just to continue with that kind of size of fibroid you're talking about, if I'm talking about a 32-week size fibroid, we're talking about a big midline scar on a young lady. And if I'm doing a laparotomy and taking 2 hours or 2.5 hours, as opposed to taking 4 hours for laparoscopic surgery, eventually today that lady has minimal scars on her tummy as opposed to a midline scar. So giving her 1.5 hours of extra anesthesia at the time, I don't think really matters to me or to her.
Okay.
One more thing,
Reggie, sir?
In between that, completed the procedure, such a big fibroid like sir, what quoted 32 weeks. If you feel that it is going long, you can give a mini lap incision and then take out that.
That's what I was able to, I was
All right.
about to talk to you about the mini lap incision.
Purpose.
Yes, sir, register,
That
please.
option is still there, but we went
Yeah.
ahead with morcellation, and fortunately,
Yes, sir.
If
No,
it's a prolonged morcellation, then definitely you can go for a small mini lap incision and you can take the fibroid out of that. If it is very prolonged.
Remove the retrieval completely.
So I just want to bring that up, that a lot of people see mini lap as a failure of laparoscopy, and they see it as a failure of their procedure. So it's not. If required, no harm. Please go ahead and do the procedure. So proper pre-evaluation of the fibroid, 2 to 5 myomas, handle laparoscopically. When in doubt, assess cavity histoscopically also. Quickly
Just
coming to the
one-
second
just-
case.
Tarun,
Yes, sir,
Tarun,
please.
just 10 seconds. All I would like to say is when you have such cases, please do your hysteroscopy first, have an idea, clear, and only then you do the lab. Please don't do the lab and come down to the hysteroscopy first. First do a hysteroscopy, have an assessment, and then you go back. Thank you.
All fibroid uteruses, better to start with hysteroscopy, rule out, we may miss some submucous fibroids or small intracavitary fibroids. So better to start with hysteroscopy and go for laparoscopy. That is
Absolutely,
my,
absolutely.
Tarun, carry on, Tarun.
Yes, sir. Going to the next case, we have a 30-year-old para 1 live one with secondary infertility. She's been treated for 5 years outside. Male partners are parameters are normal. AFC was good. HSG showed spill on both sides. She had a fibroid 4 to 4 centimeters, not intending the endometrial cavity. Now, just for speed of time, I think we all agreed not intending. We can leave it alone for now. So we left her alone. We did a couple of cycles of IUI. She came back 6 months later, lost to follow-up. She came in menorrhea and dysmenorrhea. Now, when we did an ultrasound, we found a 6 and a 6 centimeter myoma pushing the cavity forward, intending the cavity. So, is everybody consensus that we could go for surgery for this patient?
yes.
Yes.
Okay.
We have adenomyoma as well.
Yeah, adenomyoma as well.
What was the size of fibroid? Just
6. It was 4 into 4, and the repeat scan showed a 6 and a 6 centimeter fibroid.
Okay.
So the larger fibroids, as we start to deal with it, are we worried about hemostasis? How many of y'all are for vasopressin? How many of y'all do a uterine artery occlusion, either temporary or permanent, for all your cases? Is there any cutoff y'all have?
See, for me, I usually, if it is a single and small fibroid, I prefer to go for vasopressin. If there are multiple fibroids and time taken is little more, then I go for temporary occlusion. That is 12, bilateral 12, and then I remove those like the ovarian. This that is a temporary occlusion. I will go.
Dr. Guru, any opinion about the vasopressin or uterine artery occlusion?
Suppose the fibroid is huge one, and where the time taken for surgery might be prolonged, I go for temporary uterine artery ligation. And if it's a small size, even if it is small size with more than 3 or 4, I usually prefer for vasopressin.
Okay. Any other opinions? Jnana Shankar, sir?
Yeah, I think most cases vasopressin suffice. We use
even large fibroids.
20 units in 200 ml. We don't in the first place only infiltrate everything. So as soon as you find a good blanching, we go ahead and reserve the rest if you ever require to reuse the rest of it.
Neeraj sir, do you put vasopressin a second time after the first injection? Do you repeat vasopressin ever?
No, never needed to. But the benefit of vasopressin as opposed to uterine artery is it also helps you enucleate the myoma more easily if your fluid goes in the right place.
Excuse me, sir. Sorry, sir. We have 5 more minutes to finish the panel.
Yeah, we'll finish. Yeah.
Yes.
So this was the case that we did for this patient. Would any of you like to comment on the fibroid and the nucleation that's happening? So okay. So as you can see, we had a tough time getting the planes. We were not able to get the planes. She was not treated initially with any GnRH or anything like that. So we had a tough time getting the planes.
It might be associated with adenoma.
Also, we found the fibroid to look very, very hypervascular, very messy, very soft.
No, actually, in the description, you said the fibroid had grown from 4 centimeter to 6 centimeter in a matter of 6 months.
Yeah.
So I was a bit worried, but I thought her age was less. So, and you had done ultrasound or MRI, then I thought, okay, right. But that growth of 4 to 6 centimeters in 6 months was something I was thinking about.
Jnanashankar sir, that is the catch.
Yes.
I think
That may be different sonologists doing it. Different radiologists or whoever. 2 centimeter, you've seen how different they can be.
Yeah. So this came out as a low-grade spindle cell neoplasm. So how many of y'all, do y'all follow any criteria for pre-op evaluation of your fibroids? Do y'all do anything particular? Is there any? So this is just one of the many, this is what we follow in our hospital, but if there is something else that y'all would like to put on, do y'all think all fibroids require a severe myoma mapping by a proper sonologist who is trained in myoma mapping?
It is always helpful to have a good sonography report, and if you doubt or suspect that there are some fibroids which you may be missing, then doing an MRI may be helpful, but we do it very rarely. I mean, MRI is because when you're doing a laparoscopy, you're there and through our own hands. That kind of correlates well.
Okay. Fine.
Tarun,
yes.
how long does it take in Chennai for you to get LDH2?
LDH2 takes about 10 days in Chennai.
Yeah, so that is a problem which I want to highlight, that even if you do this mapping, please understand that it takes you at least about a week's time to get the LDH2 report. So please do remember this, and please do know about this also, that it takes about 1 week to 10 days. Okay, Tarun, please carry on, Tarun, please.
So let's say we have a patient we have done a myoma mapping for, and in that we are suspecting a malignancy, possible malignancy in a fibroid. Is there any role for laparoscopy in such patients? I put 4 options there. I would like each of you all to comment on which one you would like. Is there no role? Would you go straight for a myomectomy, or let's say just do a myomectomy and send for frozen? Or would you do a complete...
Jnanashankar is not going to fall into that trap. He would be the last to answer this.
Yeah.
See,
Opinions?
if you are on suspected basis, still I will go for laparoscopy, but I will take a special consent from the patient, and I will do compulsory end-bag modulation.
Okay.
Even though they are not suspicious of malignancy, I will prefer to go end-bag modulation only, because it is proved. It is proved that not your way of fibroid enucleation or manipulation of the uterus will, cause a spread of this leiomyosarcoma or this. It is
any opinions?
the insulation part which may cause the stage upgrading.
Can I just add a word here?
Yes, sir, please.
Most often we end up in a situation where we thought was benign when the final biopsy comes as malignancy, like in that last case. But if your MRI has given a suspicion of malignancy, you are on the right track. Leiomyosarcomas are very aggressive tumors with a 5-year survival of less than 70%. So trying out, experimenting in all these people for fertility's sake, we are only compromising her lifetime. So we need to be very cautious. If you have a report of suspicion of malignancy, not to meddle up with the patient. This is my take of being an onco-surgeon. Yes.
I agree with Jnanashankar. See, if I'm suspecting, it's very rare. You're talking about 3 in 1,000 myomas you suspect as malignancy. So if I'm suspecting malignancy, I would not do a laparoscopy. I would do a laparotomy. Even if it comes to doing a hysterectomy, it's an in toto specimen which I'm removing. And obviously no risk of upstaging the disease by removing it in toto, rather than doing laparoscopically and leaving that behind.
Reggie, sir?
Even I agree with Dr. Jnanashankar. If you're suspecting a malignancy, definitely you have to take into consideration. And
Guru, sir, any different?
It is a suspicion, we have to individualize. If you are a strong
Dr. Guru?
suspicion.
Yeah, if you're suspecting malignancy, better we go for complete surgery, like we have to get a laparotomy.
Okay. So I think most of the panelists want to go for laparoscopy, but I think, like Madam said, maybe if it's a patient with a low suspicion of malignancy, possibly trying a thing is there. But then, like she said, you have to be counseling the patient that there is a risk of upstaging. You have to do only in-bag modulation. What about spread during the myomectomy? Doing a myomectomy laparoscopically before the modulation? I'm just saying, while enucleating the fibroid, is there a spread of leiomyosarcoma or something at that point? Jnanashankar, sir?
Definitely. Even a Turkat biopsy or a wedge biopsy, anything you do with that, you are already upstaged. Considering the aggressive nature of the disease, we better play safe from our side. Nothing else.
Fine. Now, coming to a simple fibroid, where do we stand?
Sorry, sir, we're running short of time.
Okay, fine. So I think in-bag modulation, is one more topic. So we'll end the panel here. I'd like to thank Sampath Madam
Before
and
that,
Anjalakshmi
Tarun,
Madam.
before that, Tarun, may I
Yes, sir.
just, with the permission of Sampath Madam and Dr. Madhumita, may I just take 1 minute? May I just invite Dr. Kurian Joseph sir, since he's here. Since we have Dr. Kurian Joseph sir here as in this, may I just invite him to have the last word? Because he will summarize it very well for all of us. Sir, with all due permission, with respect to you, sir, please talk to us for a minute. That would be the icing of the cake.
Yes, Subhash. Yes. Subhash,
Kurian
you
sir?
can.
Kurian sir?
Subhash, thanks for the invitation, but I'm just a visitor here.
No, I understand, sir. This is just since I've seen you, that's the reason, sir. Because you would put it across very well, sir. Just 60 seconds of your wisdom. 60 seconds of your wisdom.
I just was wondering why nobody supported the story of giving GNRH, shrinking it, and trying for fertility. Am I creating confusion?
So this was a topic of endoscopy.
Endoscopy,
and
yeah.
fibroid.
Yeah, but even with endoscopy, you have a borderline myoma.
Probably,
There is no harm in shrinking it. So
we alter the
don't
plane
keep your
and
blinkers
make
on.
it
Always be prepared to change and alternate. Just because the panel is this, don't stick to that alone.
No,
That's
no,
my
sir.
suggestion.
GNRH
Okay.
prior to myomectomies will alter the planes of myoma and it will make a procedure more difficult. If you are
But if it-
planning for surgery, then why to give GNRH?
Why do surgery at all? Let her
No,
conceive
not
with a
for all fibroids.
2.5 centimeter myoma.
So not
Sorry,
for
I'm adding
all
to the
myoma.
confusion, but I think you guys answered all these things pretty well. Thank you, Subhash.
Thank you, sir.
Yes, sir.
Thank
Sir, no offense meant, but since I saw you, sir, I thought we will just take the final word from you, sir. That's the only intention, sir.
Thanks, Subhash.
Thank you very much. Tarun, please. Sorry for interrupting.
No, we're done, sir. We're done. Thank you, sir. I just want to say thank you to Sampath Madam, Anjalakshmi Madam, and the entire organizing team for this. I think it was a lovely panel, and thanks to all the
Thank you,
panelists.
Tarun. Thank you, Subhash.
Thank you very much, everyone.
Wonderful
Thank you, sir.
panel.
Thank you very
Thank
much.
you.
Thank you, ma'am.
Thank you, Dr. Sampath.
Prabha madam,
you,
being the
Tarun,
lone
as well.
lady, thank you very much for
Thank you.
contribution for your.
Sorry, I was, on the traveling for the airport.
Anyway, I'm very happy that you joined us in between your schedule, ma'am. Thank you, ma'am. Thanks a lot.
Thank you. Thank you, Subhash. Yeah, thank you.
Okay.
Thank you, Subhash. Thank you, Tarun.
Thank you, madam.
Thank you to all.
Thank you.
Yes. I thank the moderators, the panelists, and Dr. Kurian Joseph for such a wonderful panel. Moving on to the second session of the day, I invite our chairperson, Dr. Shanta Devi. CV slide, please. Can you make it full screen?
Yeah, it is full
Full
screen
screen
done, ma'am.
only, Madhumita.
Yes, ma'am. So Dr. Shanta Devi, she was former professor, Department of Obstetrics and Gynaecology from Government Medical College in Madurai. And she organized many live workshops at TENI. And also she presented many papers and as a faculty in many national and international conferences. I request you to please kindly introduce Dr. MC Patel, sir, ma'am.
You go walkie. Let me get my shoes.
Patel sir, CV please. Riya.
Good morning. Sampath Mari madam.
Madam,
Am I
yes,
audible? Good morning, all of you. I thank Sampath Mari madam for giving me this opportunity to participate in this wonderful webinar. I am very, very, very happy and proud to introduce MC Patel sir. He is known to every gynecologist, junior most to senior most. For the past 2 years, by happy learning, he made everyone to learn happily almost all the topics in ObGyn. And he a very good opportunity to meet and greet friends every week. And also whenever we have any medical legal problem also, sir will come to our mind. And he is the senior ObGyn consultant and medical legal counselor. He held many posts. He was a vice president, Foxy 2018, chairperson, ethics and medical legal committee 2011 to 13, and honorary joint secretary, state organization of ObGyn of Gujarat. And he is the honorary secretary elect for the same. And he was an honorary member of state supervisory board, PNDT committee, Gujarat state 2005 to 9. and is a President IMA Ahmedabad branch 2007 to 18, and he was the organizing secretary for AIC OG 2017 Ahmedabad. And sir is going to give a talk on POCSO Act. So we as gynecologists know the act like PCP NDT Act, and there are so many act against violence against women also. But this is that is the act against the sexual offences for children, so both boys and girls. So every one of us need to know what about this act. So welcome you, sir. We are expecting and very eagerly for this. What is there in the POCSO Act? Welcome you.
Thank you, madam, for kind words. And let me share my screen.
Yes, sir.
Can I have a few minutes to introduce the other chairpersons for the session?
Madhumita, you can introduce later. Let him finish.
Okay.
Yes, sir.
Yes. So, first of all, apology. I am at Rajkot, ObGyn Society for Physical Meeting, and there is some connectivity issue, rather poor connectivity. So if at all it disturbs, pardon me. And I will be very quick as far as my presentation is concerned, because to touch this subject within 15 minutes is very difficult. So greetings from Statue of Unity, tallest statue of world, and we are all proud of that statue. And so I invite you all on 45th SOGO conference, that is on 9th, 10th and 11th December at Statue of Unity. For 3 days, it will be academic extravaganza, and you all are welcome, invited to be a part of this conference. So warm welcome all the delegates and wishing you a litigation-free practice. At the outset, I would like to thank organizers and Dr. Sampath Kumar in particular for inviting me to share my views about the subject. Protection of Children from Sexual Offences Act, it was enacted in 2012 and there was amendment in 2019. So this act came into existence. Usually any of my talk, I start with this question: is it worth discussing? And if it is yes, then why? So as far as this act is concerned, we have to know our role, compulsory reporting, examination and treatment of victim, and some controversies related to this act. And ignorance of law is never an excuse, because as soon as any act, any ordinance, any law passes in government gazette, it is presumed by law that each and every citizen of India knows that law. And we obstetrician friends are just like this innocent bird, always at danger of cobra of law. Yes.
Patil, is there a PPT?
Yes, slide is not moving.
We are not seeing the slide, sir.
So in my computer it is moving.
No, sir, but we don't. Sampath, madam, are you able to see?
Okay, okay.
No problem. Not seen, ma'am. Vijayalakshmi.
Okay.
Screen not seen.
He sold some internet connection. No, I thought.
No problem. Let me go like this.
Sir, you can send the slides to Priya, sir.
No.
The court.
It will take time.
Tech person.
Only 1 minute. So is my screen seen?
Sir, not visible. Sir, you need to, yeah.
Is it seen? My screen?
Click it, sir. Only POCSO Act that.
Yes, sir, seen.
Screen is seen. You have to click that.
Folder is seen, sir.
So is it seen now?
No.
Yes, sir. You have to open the PPT, sir.
So in my computer, it is open.
Only the screen with the help of Balakrishna sent POCSO Act, but you have to click that POCSO Act, sir.
No, but I have clicked already, and in my screen it is seen.
No, it's not seen here.
So can you send a PPT, sir?
But it will take time, madam, and I have one lecture downstairs physically. So either we can switch over with this, and
Yes, sir,
after finishing my engagement at Rajkot, I may join again, and if you can accommodate. Because
Sir, without PPT, can you present it?
But I can, but I don't think it will be much more palatable to the delegates.
Sir, good morning, Pradesh. I am Priya here. Please stop.
Yes,
please
I
stop
have
sharing.
stopped sharing.
Yeah,
I am
please
trying
open
again.
the PPT.
I
Please
am
open the
trying
PPT.
again. Yes.
Yeah, please open the PPT.
I have opened.
Yeah. No, you have to open the PPT.
I have already
not
opened,
like
madam.
this.
I
It's
have
not
opened,
like that.
madam. I have opened PPT. I have minimized, and I am sharing the screen. In my computer, it is seen that you are.
Sir, before you
screen
share
sharing.
the screen, after you click on share screen, there is one more share button. After your presentation is seen there, that you have to click and then open your presentation.
Madam, in my screen, it is already seen you are screen sharing.
Then you share it with the organizers otherwise. Send a
Sir,
mail
just
to
minimize
them.
it, sir, or else just this same screen window, just minimize it, sir, since you are already open it.
That also I have already done.
Just minimize it.
Priya.
Yeah.
I have minimized. It is seen POXO Act and L Balakrishnan stand.
No, sir.
No,
Can you open the PPT again? Can you just open it again, so we are able to see your arrow mark?
No, stop sharing. I have done. I am going to share my screen again.
So while sharing, you will get some tabs. In that, you need to select the PPT tab, sir.
But I do not see like this.
There will be some tabs will be opening, sir. So you need to select PPT tab, sir.
Sorry.
Not this tab, sir.
Is now seen?
Sir, double click on
please
it, sir.
stop the
Can you
sharing.
double click on that POSCO Act, that PPT?
Now on my screen, full screen is seen. Is it seen there?
Yes, the full screen is seen. Only the PPT is not seen. PPT is not open. So can you just double click on that POSCO Act?
In my screen, PPT is open and my first slide is seen. Why it is not reflecting there? I don't know.
So the other window is open here. So can you just open this POSCO Act again?
So I should go back again?
Yes, so just see if you can just double click on that. We are able to see your
No,
arrow.
I have stopped sharing. Again, I am going to share my screen with this and my PowerPoint slideshow, and I am sharing again.
Sir, if I may request, before sharing now, close your PPT again, sir. Close the PPT totally.
Totally?
Yeah, close your PPT fully. Again, reopen the PPT and minimize it and keep, sir. Then you again start your share, sir. First close that PPT, sir.
Let me try that also. So I have stopped.
It's seen now, MC. Go ahead with it.
So, what?
Respected sir, I think has Dr. Tarun exited out of screen sharing from the earlier session?
Yeah. That and all is done, madam. Otherwise, we can't even see now. That is done now. No.
So I have stopped sharing.
Yeah.
I am totally out of my presentation.
Yes. Now open the presentation again.
Open the presentation, sir, and then keep the presentation open, and then with the same presentation open, just open this window.
Kanna, Madhumita, he has to minimize it. He has to minimize
at a time, one person, because
yes, sir. You open the presentation, minimize the presentation.
So again, I am trying to share my screen, and
yes, sir. Now we are seeing. Now you go to slideshow, sir.
So is it seen now full screen?
Yes, sir. Perfect.
Okay, thank you. So greetings from Statue of Unity, tallest statue of world, and we all are proud of that statue. And so I invite you on 45th SOGO conference, that is State Conference of Gujarat, on 9, 10th and 11th December, hosted by Ahmedabad ObGyn Society, but it is destination conference at Statue of Unity. And I invite you all to be part of that conference. So warm welcome all the delegates and wishing you a litigation-free practice. At the outset, I would like to thank organizers and Dr. Sampath Kumari in particular for inviting me to share my views about the subject. So POCSO Act, Protection of Children from Sexual Offences Act 2012, and it was amended in 2019. So usually any of my talk, I start like this: is it worth discussing? And if it is yes, then why? So know the role of our obstetrician friends as far as POCSO Act is concerned: compulsory reporting, examination and treatment of victim, and some controversies. And as far as law is concerned, ignorance of law is never an excuse, because as soon as any law, any act, any ordinance passes in government gazette, it is presumed by law that each and every citizen of India knows that law. And we gynecologists, friends, are just like this innocent bird, always at danger of cobra of law. And as far as this act is concerned, it was published on 20th June 2012, just I mentioned. And as far as this act is concerned, popularly it is referred as a POCSO Act and not POSCO. So it should be very clear as far as this act is concerned. And why this act is? It is to protect children from offenses of sexual assault, sexual harassment, and pornography, and provide establishment of special courts for trial of such offenses and matters concerned therewith and incidental thereto. So sexual harassment, sexual assault, and aggravated form of sexual assault. So aggravated form means when victim is under custody or in faith of some senior person or elders and incidents happen, then it is considered as a aggravated form. Say for elders in a family, in a school teacher or principal, in a hospital doctor and patient, in jail, jail superintendent and prisoner. So that way, if at all offense happens, then it is a aggravated form of sexual assault. Penetrative sexual assault is one more area. An aggravated form of penetrative sexual assault, just I mentioned, and using child as a pornographic purpose. These all areas are covered as far as POCSO Act is concerned. So new offenses, special courts, special public prosecution, mandatory reporting, punishment for false reporting, special procedures of recording of complaint, statement and evidence, and monitoring. National Commission for Protection of Children's Rights and State Commission. So this law is in addition of already laws in existence as far as children protections are concerned. And as far as compensation to the victim, it is also included in this particular act. So which child, as far as POCSO Act is concerned, any person below age of 18 years is a child, and this act is gender neutral. So it addresses both male and female. So as far as any of this part of sexual assault is concerned or harassment is concerned, here word sexual intent is very much important. So if at all in any activity, if there is a sexual intent, then it becomes a case of POCSO. And as far as this part is concerned, any question which involves sexual intent shall be question of fact as far as this part is concerned. And as far as this act is concerned, there is a stringent punishment, provision of punishment from 3 years to life imprisonment. And before this amendment, which happened in 2019, for penetrative sexual assault and aggravated form, punishment was 7 years and 10 years respectively. But with amendment, now punishment has gone to imprisonment for 20 years and maximum punishment may be awarded death penalty also. And fine which is awarded, the amount is paid to victim for medical expenses and rehabilitation of such victim. And use of child for pornography is also punishable offense under this act, and imprisonment up to 5 years, and it may go up to 7 years also. So abatement is also considered under POCSO Act. A person abets an offense who instigate, engages, or intentionally aids by any act or illegal omission of doing that offense. and it was also given in section 107 to 120 of Indian Penal Code also. So to instigate, to help, and to encourage. That means by instigating person to commit offense, by engaging a conspiracy to commit it, and intentionally aiding person to commit it, it becomes a amendment and it becomes a serious matter. But as far as our practice is concerned, ObGyn, how we should be well aware or vigilant of this act not to end up into any litigation. So let us see few of the situations. A 17 years old girl comes to you with her boyfriend and she asks that they are going to start that active sexual marriage life, active sexual life rather, and she asks for contraception advice. What will you do? Can you advise or will you advise? One side it is a moral duty and other side is law. As far as our moral duty is concerned, if we do not advise, then they may end up into unwanted pregnancy, and again they will come to us for termination of pregnancy. But as far as POXO Act is concerned, if we advise, then we are instigating or we are helping or we are aiding them to constitute crime. So it is a very typical situation. So in this type of situation, if one doesn't advise, then just I mentioned, so one can give them health education, but cannot prescribe contraceptive in this type of situation because it may invite litigation as far as POXO Act is concerned. Let us see one more situation. 16 years old girl is brought by her mother with complaint of vulvovaginitis with discharge per vagina. On examination, it is found a case of sexually transmitted disease, and on careful history, she gives history of sexual exposure with her husband, her boyfriend. So in this type of situation, it becomes a case of POXO, and we are under obligation to inform police. Of course, we have to treat this patient, but we are under obligation to inform to police. One more situation. 18 years, 6 months old married girl is brought by mother with pregnancy of 39 weeks and she is for LSCS. So in this type of situation, what will you do? Of course, we have to go for cesarean section, but at the same time, we will have to inform police because at the time of conception, she was less than 18, she was minor, so it becomes a case of POXO. So in this type of situation, of course, we can go for cesarean section, but we will have to inform police same time. So carry home message in this type of situation, one is under obligation to investigate properly with careful history about sexual assault, and if so, one has to inform police. Let us see one more situation. 17 years old girl with mother visit hospital with 6-week pregnancy for termination of pregnancy. Doctor explained that I will go for termination of pregnancy, but I will have to inform police. So patient and mother refuses for the same and absconded from the hospital. So in this type of situation also, even if you have not treated patient further, then also you are under obligation to inform police once you have come across that offense under POXO Act has happened. So inform police in this type of situation also. So as far as our duty as a obstetrician or gynecologist is concerned, we are first point reference in conferring this type of situation, whether abuse has happened or it is being abused. So with proper medical history, proper examination and findings and some evidences, we can form opinion about this act, whether it is happened or not.
Please mute.
So as far as our role is concerned, under this POXO Act, notwithstanding anything contained in Code of Criminal Procedure 1973, any person, including child, who has apprehension that an offense under this act is likely to be committed or has knowledge that such offense has happened, then he is under obligation to inform Special Juvenile Police Unit or police station. So it is very much mandatory to inform police in this type of situation, because children cannot stop child abuse, but adults, of course, can. So it is mandatory reporting under Section 19 and Section 20. And if we fail to report, then there is a provision of punishment of 6 months imprisonment. So we cannot afford not to inform police in this type of situation. As far as direction to media is concerned, under section 23 of this act, media not to disclose personal identity of child in this type of situation. And if at all they do like this, then media is also punishable with 6 months of imprisonment, and which may extend up to 1 year. Then how to inform? We should inform with acknowledgement, because many a times police may turn up that you never inform. So whenever you inform police, it should be informed with acknowledgement. Or you can dial 100 because it is recorded call. You can go with registered letter, by mail, by telephone with recording, and inform higher officers if lower officer is not complying with your complaint. And telephone with recording, whenever you do, then ask whom you are addressing this information, name of that particular person, buckle number of that police officer, and police station, and time and date is very much important to note. So as far as duty of doctor is concerned, when this type of patient is brought to you, either by police or by relative, when it is by relative, then you will inform police and you will start examination. But consent is very much required. If patient is more than 12 years, then she can give valid consent as far as examination is concerned. But if at all any treatment, whether surgical intervention is required, then consent of guardian will be required if she is less than 18 and more than 12 years. But if she is less than 12 years, then consent of guardian is required even for examination also. So document presence during conversation with child, document questions, which questions you have asked and what were the answer on part of child, and examine in a very sensitive manner. It should be painless, privacy, and least disturbing to the child. And in simple word, what happened, where, how. So your question should be very simple so that children can answer. No confusion on part of children and no uncomfortable question. And during examination, if child is not comfortable, then child may withdraw her consent for examination. Of course, you can explain to the child and relative, but they have all the right to withdraw their consent during examination also. So carefully, you are under obligation to have carefully collect clothing, underwear with positive stain, either blood, semen, or any other material. So you have to preserve, and it is to be handed over to the investigating officer, that is police. And child with physical disability, you are under obligation to help them as far as examination part is concerned. So proper counseling is also very much required as far as HIV is concerned and sexually transmitted disease are concerned. So you will also examine for any trauma. It may be wise to differ with the examination when patient is not comfortable, because many a times small child has a fear or anxiety. So you will explain and then you can start examination. Many a time, very small children, you can examine in lap of mother to have a comfort as far as child is concerned. And if child still refuses, then you will have to not to go for examination. No force as far as examination is concerned. Sedation.
Excuse me, sir. We're running short of time.
Only 1 minute.
Yes,
I
yes,
am finishing.
no. Okay,
So as far as sedation part is concerned, if at all you feel it necessary, then you may go with short general anesthesia with consent of guardian, and you can examine and treat patient accordingly. So presence of parents is very much required as per this POXO Act. But in few of the cases, it is observed that patient is not comfortable to be examined in presence of parents, because many a time relative or parents may be involved in this type of activity. So it is also incidents happen in so many of the questions. So all these questions we have to ask: when it last occur, when first time it occurs, whether threat was given or not, nature of assault, and any complaint of vaginal or anal pain. So all these information will be helpful to come to the conclusion. And as far as essential information to medical history is concerned, we have to go for history of all this, and height of patient, weight, injury mark, and all the sign. It is very much important. Whether patient is menstruating at the time of examination, it will be difficult to come to conclusion. So we have to mention in our case paper that also. And as an expert witness, it is our role to give opinion in a clear form whether this offense happened or not. So it is very much important. But court has liberty and court is not bound by an expert conclusion whenever you give any opinion. As far as treatment part is concerned, all the injury you have to treat. For exposure of sexually transmitted disease, you have to go for prophylaxis. For exposure to HIV, you have to go for prophylactic treatment. And possible pregnancy emergency contraceptive should also be considered in this type of situation. And whenever necessary, a referral or consultation to higher center or with psychological psychiatrist also to counsel patient for psychiatrist treatment. So to conclude my talk, when minor is brought for examination and treatment for complaint about sexual abuse, responsibility of medical profession being an expert increases manifold. Responsible medical practitioner is under obligation to report an appropriate authority about any child sexual abuse he comes to know during his professional medical duty. He has not only to examine and treat, he has to form opinion whether sexual abuse has happened, and he is a very important person to be helpful as far as an expert witness to prove a crime of child sexual abuse. So comply with the law of land, be vigilant in your practice in this type of situation, remain alert every time, otherwise be ready to face this type of situation. So take medical legal advice from point one if at all you are in a doubt. So this gentleman has so many staircases, but he doesn't know how to use them. So it doesn't matter how many resources you have. If you do not know how to use them, they will never be enough. So have some basic legal knowledge. Always obtain medical legal advice whenever you are in doubt. And if you want to sleep like this, take tender care of a patient in this type of situation. Pray your Almighty God before going to sleep and keep my visiting card below your pillow. I am always there to assist you in any given situation. And whenever you need, I am always round the corner. So if at all it works, nothing. So sorry. So all the best and God bless you. Have a litigation-free practice. With regard, salute to the organizers and again, Dr. Sampath Kumari. Thank you very much. Please do not assume. Please ask if any query question if time and chairpersons permit. Thank you very much.
Thank you very much, sir. It's an enlightening talk on POXO Act. It was a privilege to have you with us today.
Thank you, madam.
Thank you, sir. So,
Yes, sir.
So I will take leave to attend physical conference downstairs.
Yes, sir. Thank you, sir.
Apology. Thank you very much.
Thank you, sir.
Okay.
I would like to introduce our next chairperson of today's session. Slides, please. I request everyone to please mute. Yes, ma'am. So our next chairperson is Dr. Chandra Ponusamy, who's the founder, president, and patron of Namakkal OG Society and executive council member of TNFOG. And she was the vice president of Namakkal IMA and organizing chairperson of Namoxicon 18. And she received the Best Doctor Award in IMA and the Best Fertility Consultant Award in 2018. Our next chairperson is, next slide, please. Our next chairperson is Dr. Sneha Surendra Buyar, who's the chairperson, Breast Committee of FOXY from 2019 to 21. She is the governing council member of ICOG 2021 to 22 and chairperson, Medical Disorders Committee of AMOX 2022 to 24 and executive committee member of AMOX 2020 to 22. Next, I would like to introduce Dr. Omana Madhusudan, who's the founder, president, Wayanad ObGyn Society and president, Wayanad ObGyn Club for the last 15 years. She's the vice president of Kerala Federation of Obstetrics and Gynecologists and member of the Practical Obstetric Committee of FOXY. And she's the chief coordinator of Pradhan Mantri scheme. Next. Our next chairperson is Dr. Vijayalakshmi Jnanashekaran, who's the Associate Professor of Obstetrics and Gynecology in ACS Medical College and Hospital. She's an Executive Council member of OxY and Honorary Treasurer of TNFOG 2021. Next, moving on to the speakers, I request Dr. Chandra Ponusamy to introduce our Next speaker, Dr. Deepti.
Morning,
45 minutes ahead. I request all speakers to be strict to the time. Chandra, ma'am.
Shall I start?
The first speaker slide, please.
Good morning, everybody. At the outset, let me congratulate Dr. Anjalakshmi Madam, energetic and goal-oriented Dr. Sampath Kumari, Dr. Vijayalakshmi for your novel and unique idea of combined webinar of the 5 federations of Andhra Pradesh, Karnataka, Kerala, Telangana, and Tamil Nadu. It's a great opportunity. Am I audible?
Yes, ma. Yes, Chandra.
It's indeed a great opportunity and privilege to chair the session of talks by all stalwarts of our field, Dr. MC Patel, Dr. Sheila Mann, Dr. Madhuri Patel, Dr. Hepsiba, and Dr. Deepti. Now, let me introduce Dr. Deepti. She is consultant gynecologist from Sun Medical and Research Center, Thrissur, and she was the past secretary of TOGS, Thrissur, maybe. And she is going to talk on adolescent PCOS.
Telangana.
And we all know that adolescent PCOS, because of increasing overweight and obesity, incidence is increasing. And let me hear what she is going to give us today. The door is yours, Dr. Deepti.
Thank you, madam. Am I audible?
Yeah. Yes.
Hello.
Yes, ma'am, you're
yes,
audible. First of all, let us. Can I start my share screening?
Yes, ma'am, please do.
Let me thank Dr. Sampath Madam and the whole team for giving me this opportunity. Myself, Dr. Deepti, I'm a member of Kerala Federation of ONG, hailing from Thrissur. TALK stands for Thrissur ONG Society, the society from word of and I'm their student. Thanking you for this opportunity as well as giving me the topic of adolescent polycystic ovary.
Yeah, screen where am I? Dr. Deepti, are you sharing the screen?
Yes, ma'am. Dr. Shripriya, can you share my slides from there?
Yes, ma'am, I will be sharing them. 1 second.
Little faster.
Yeah, because I already. Yeah. But anyway, I'll start because as you know that adolescent polycystic ovary. I think somebody else is starting.
No, you proceed. We can have others. Please mute. Start DP.
Yeah. Okay. The magnitude. I don't have to stress because in every OPD we are seeing at least many people coming there with the. Can you have the previous slide, please? Previous slide. Previous slide, please. Okay. Because everybody will be having bundles of investigations in their hand, umpteen number of scan reports, as well as the first line of their consultation, they start with, I am a PCOD patient. That closes its all. So my next 12 minutes will be to highlight on the point that how to give a new insight to this disease, as well as to the life, not only for the patient, as well as my colleagues, as well as other doctors. Next slide, please. So why should we have next slide? Next slide, please. Why should we have the diagnosis? Because once you have diagnosed or stamped them as polycystic ovarian disease, please understand it has got a lifelong implications of the metabolic syndrome later creeping into their life. And we have to start the corrective measures early to create the awareness not only among the patients, but as well as their parents and to the community. And not to forget to avoid the psychological scarring. Next one. But how to diagnose? What? Next slide. The famous Rotterdam, NIH, AES, all these things are for adult population. The previous one. And the 3 main important parameters are the previous slide, please. The three pillars, what we have been seeing on all these things are hyperandrogenism, ovulatory dysfunction, and polycystic morphology in ultrasound. Whether 2 of the 3 or 1 plus 2 or 2 plus 1, whatever it is, these 3 were our hallmarks, but please understand this is for adult population. So none of these criteria is ideal for our adolescent population. Next slide. And what are the gray zones in these 3 distinguished all these criteria? Because anovulatory cycles, as all of us know, are quite common among adolescents. The symptoms of hyperandrogenism, especially clinical symptoms, are less reliable because hirsutism will be in the developing stage and it takes another 2 to 3 years of gynecological years. What we mean by gynecological years is the years after menarche, the initial first 4 to 5 years to reach the sexual hair growth of the adult stage, and acne is pretty common in this age group. The measurement of testosterone, it is naturally increased in an ovulatory cycle, and the paucity of reliable norms, which we usually use for adult, is it ideal for the adolescent population? And the polycystic morphology in ultrasound is quite common in adolescents. Plus, we have got a transvaginal sonography. Next one. So, after many deliberations and meetings, the common bodies have come up to how to diagnose the international consensus of diagnostic criteria for polycystic ovarian syndrome in adolescents. I would like to highlight only these 2 points in my entire talk. The diagnosis of adolescent polycystic ovary is mainly clinical. And the 2 important points you have to stress is abnormal menstrual pattern as evidence of ovulatory dysfunction, which is abnormal for the age or the gynecological age, and most important, persistent for 1 to 2 years. So unless she has passed at least 2 years of her gynecological years or post-menarchal years, please don't be in a hurry to brand them as a polycystic ovarian disease just by an ultrasound evidence alone. Clinical and or biochemical evidence of hyperandrogenism, clinical hirsutism, especially if moderate to severe, or an elevation of total serum total or free testosterone by a specialty reference assay, which should be standardized. Next slide, please. So the clinical features, again, we are focusing hyperandrogenism, hirsutism, mild amount of hirsutism is okay. If we use the Ferriman-Galvez system, you can keep a picture in your consultation room, assess the 9 areas, but the scoring, even though there is a change according to the ethnicity, anything more than 15 is taken as standard because it should be moderate to severe. So it should be a line, and it should be also a differential diagnosis from idiopathic as well as a hypertrichosis, some focal hirsutism. All these things should be ruled out, and please have your eyes to elucidate the points of cutaneous hyperandrogenism, even though the patient has not come for that, or even though the patient is not complaining about it. So hirsutism is the first hyperandrogenesis cutaneous manifestation. Any score above 15 in Ferriman-Galvez system. Acne, again, there are scoring systems and all, but it should be persistent. It should be treatment resistant of oral as well as local antibiotics. It should be progressive, or it should be severe inflammatory. And of course, the male or female pattern of alopecia. Next slide, please. Coming to the ovulatory dysfunction, we have to sit with them and take a detailed history because now that the AUB FIGO1 criteria has come, there are so many terms which have gone out, like oligomenorrhea, hypomenorrhea, all these things are out. So, sorry for the term oligomenorrhea, it is out there. And primary amenorrhea, lack of menarche by 15. Secondary amenorrhea, forget about all these previous terminology, more than 90 days absence of periods is abnormal. And in the infrequent abnormal uterine bleeding, you have to go for cycle length, duration, cyclicity, regularity, all these things you have to take a detailed history. But roughly, in the first post-menarche or the first gynecological year, anything less than 6 periods per year. At the next 1 to 3 post-menarchal years, anything less than 8 periods per year. And above that, anything less than 9 periods per year. That will be easy to remember. Less than 6 periods, less than 8 periods, or less than 9. In the first 4 gynecological years, can brand them as an ovulatory dysfunction. And excessive uterine bleeding, the definition holds true for them also. But anything cycle regularity, anything less than 90 days or more than 90 days, both are abnormal. So this will be the roughly the ovulatory dysfunction of an adolescent age group. Next slide, please. So please remember, PCO morphology in ultrasound has nothing to do with the diagnosis. We don't have to have umpteen number of ultrasound just to say whether the PCOS has increased, decreased, the grade has changed, whether it is cured, etc., etc. Next slide. Of course, they will have some associated features like obesity, the acanthosis nigricans, all these cutaneous markers of insulin resistance, metabolic syndrome with a hypertriglyceridemia or with a hyperglycemic trend, sleep disordered breathing and obstructive apnea syndrome, non-alcoholic fatty liver disease, which is a reversible form of the later going for a fatty liver, as well as the hepatic steatosis, and not to forget about the psychological features. About 50% of them will be having depression. All these features are not essential for diagnosis, but there will be the association. Next one. Still the differential diagnosis. The most important differential diagnosis is physiological adolescent anovulation. That is why the persistence symptoms from the 1 to 2 years is important. Of course, you may get a patient with a severe heavy menstrual bleeding, anovulatory cycles, which will warrant treatment even without branding them as PCOS. You can start the treatment. You can put them under the category at risk for PCOS. If hyperandrogenemia is not clinically or biochemically proven, you can start treatment, but once you treat symptomatically, stop for 3 months and then reassess the patient later, or watch for features of menstrual irregularity or hyperandrogenism later. Of course, the non-classic variety which comes late of the congenital adrenal hyperplasia, virilizing tumors, other endocrine disorders like Cushing's, hyperglycemia, hypothyroidism, etc., and certain drugs which can induce changes similar to this pattern also should be ruled out. Next one. The basic evaluation. Again, we have seen patients with many blood tests. The detailed history remains the clue regarding the menstrual history as well as the signs of hyperandrogenism. And then one single measurement, if you will ask me to brand them, will be either total testosterone or free testosterone. If you get a high total testosterone in a good lab with a very validated result, then that holds true and it has got more reliable value than the clinical signs of hyperandrogenism. But most often we won't get it. Then you have to roll out the circadian rhythm. You can repeat it in the morning. And if then otherwise you can ask for a free testosterone. Of course, the lab should be assessing the SHBG level as well before giving you the free testosterone index. If these two are there elevated, that is the most sensitive marker. But otherwise, most often we will have to look for the signs of clinical signs of hyperandrogenism. Of course, rule out pregnancy, chronic disease panel with PCDCS or CRP. You have to do FSH, LH, prolactin, TSH to rule out the basic parameters, but please understand the FSH-LH ratio to be repeated on and off in every cycle is not at all warranted. LH and FSH variation will be there in most of the PCOS. Why we are doing is, if there is a high FSH, it shows a primary gonadal problem. If there is FSH and LH are depressed, it may be a secondary problem as well. Next one. Then coming to the extended evaluation, next one, we will go for, if you suspect there is a congenital adrenal hyperplasia or an adrenal tumors, you can go for 17-hydroxyprogesterone, DHEAs, cortisol, etc. Please note the point that I have not mentioned fasting insulin or glucose levels in this glucose insulin ratio or fasting insulin levels. Nothing is written here. Others, of course, we have to go for OGTT rather than HbA1c or fasting blood sugar because they are at risk for metabolic syndrome. The lipid profile, check their BMI, and what is the role of USG? Even if there is a role, of course, you know there is a restriction for the transvaginal sonography. The adult terminologies of the number of follicles, the ovarian volume, all these things are not applicable for them. So the role of USG is, first of all, one is reassuring to the patient because they think that nothing is wrong. Second, you have to sit and make them understand this polycystic ovary is not a cyst to be removed. You can rule out the other tumors like a serous cyst or mucinous cyst or a dermoid and other virilizing tumors. And one more use of ultrasound, which you actually find very useful in clinical practice, is a patient coming with an ovulatory cycle or severe bleeding PV. You can get the endometrial thickness. If the endometrial thickness is too high, you have to go for a progesterone to stabilize it to have a withdrawal bleeding. If the endometrium is too thin and washed out, then what you have to do, you should use an estrogen combination to build up the endometrium to arrest the bleeding. Next one. Coming to the treatment, what is the treatment of polycystic ovarian syndrome? The only treatment is creating awareness, make them understand it is not a disease, it is really needs a lifestyle change. But what we offer as treatment is primarily symptomatic treatment. The symptomatic treatment should be addressing these three areas. One is bleeding, second is hyperandrogenism, third is the obesity and insulin resistance. As I told you earlier, obesity and insulin resistance is not there in the diagnostic, but coming to the treatment part, you have to address this issue. Next one. And what will be the first line of management for the menstrual irregularity? Again and again, combined OCP remains as the first line. The combined OCP, what is it doing? The estrogen is arresting the androgen production, increasing the SHBG. The progesterone is actually preventing the endometrial hyperplasia, which is later a risk factor for malignancy. So that is why the combined OCP and the dose of estrogen, of course, should be somewhere between 20 to 30. If the bleeding is heavy, you will not do with the 20 microgram preparation. Most often we have seen they are started with a very low dose pills and the bleeding continues. So you'll have to go for 30 microgram. And the progesterone part is very important. The progestin is very important. What you use is with the least androgenic, anti-androgenic properties coming somewhere between desogestrone, drosperinone, or if cyproterone acetate. So choosing your combination is very important. All OCPs are not ideal for all treatment of menstrual irregularity. So along with the correcting the hyperandrogenism, this gives immediate predictable withdrawal bleeding. And how long can you give it? You can give continuously if there are no other contraindications till the patient gets matured, or at least the 4 post-menarchal years are over, or if the patient has lost a considerable amount of weight, you can stop and see. When will you go for a progestin-only regimen? When an adolescent is brought to you, you have not evaluated her because she's heavily bleeding. In spite of all your symptomatic measures, you can start on progesterone, but please understand, progesterone only stops the bleeding and disrupts the endometrial hyperplasia, but it is not useful for the hirsutism part. And you will have some mood swings and all other some other the progesterone. Of course, you have to use symptomatic measures with antifibrinolytics, and believe me, PCOS is one among the two, the other being the blood dyscrasias, which really warrants admission. People have come with HB3 and 4 and to the casualty just by bleeding by an ovulatory cycle from polycystic ovarian syndrome. Next slide. Addressing the hirsutism part, again, combined OC pills remains as the first line. But of course, you have to choose the progesterone. Here, the cyproterone acetate or anti-androgen will be better. And you can start cosmetic treatment along with that, the local as well as the oral treatment. And if both these fails, along with the lifestyle management, then we can add on with the anti-androgens. Next slide. Next slide. Obesity. Lifestyle management, very easier said, previous one, very easier said than being done. We all know that personally, as well as when you advise this to the patient as well. But so far, obesity, there are no magic diet, no crash diet, no keto diet, no shakes, nothing, only workout and reduce your calories. That really does wonders. But for them to make understand, you at least in the first visit, you will have to sit with them and make them understand what is this disease. And so far, I have not touched on the topic of metformin. When will you put metformin for patients with polycystic ovarian disease? Next slide. Metformin, always we have seen the adolescents pushed with, they are coming with many prescriptions with the metformin and myocytol as the first line. Next one, next slide please. Metformin we use for patients who have actually, there are 3 indications. Sorry, I didn't put one. This is actually along with the combined dose pills in obese, insulin resistant adolescents with a metabolic syndrome, or if the in that case also, if they have failed with their lifestyle management as well as psychological support, or along with lifestyle management, if ovulation is their primary concern, or if there are any contraindications of combined OC pills, you can start on metformin. The ideal dose, you start with 500. Of course, the anorexia, the retching will be a problem. If they have to adhere to the treatment, you have to tell them why you are using it, how long are you using it, and what are the side effects expected, and what are the effects you anticipate. And for the US FDA approval is only for the metformin is only for type 2 diabetes. This is an off-label use, but you can use it. And once you step up to the correct dosage, you can give it minimum 3 months or 3 to 6 months, and then you stop. If the patient has not lost weight, the metformin alone will not do any wonders. Metformin is mainly to reduce the glucose production as well as to increase the insulin sensitivity. It has got wonderful effects on the lipid profile changes, but it does not.
Sorry to disturb, ma'am.
Sorry.
Excuse me, ma'am. We're running short of time, ma'am.
Only 1 more minute. This is my last slide.
Yes.
And coming to the myoinositol, it is a promising drug, but it is not at the first line. And when the teens will be very in a hurry to reduce weight, so they will jump to bariatric surgery, but please make them understand surgery is the last option. Next slide. So summing up, from all these 12 to 15 minutes, even if you have not listened to any of this, if you have not seen any slide, my two play is adolescent PCOS is a clinical diagnosis. Use your clinical wisdom to look for signs of clinical and clinical hyperandrogenism as well as the ovulatory dysfunction. Follow them up, give them correct advice. Lifestyle management is very crucial. Psychological support and calling them back and giving incentives will do many, many wonders. Please don't push them with metformin and myoinositol as the first line for many, many years. You are supporting with them drug, do it in the correct dose, correct composition, and at least for the first 3 years of their post-menarchal phase. Thank you so much for the patient listening.
Fantastic, Deepti.
Thank you, Dr. Deepti, for your elaborate presentation. As you correctly mentioned, lifestyle modification and psychological support is the must for these adolescent girls, because we have to relieve them from their stress and strain of school studies and these complaints. Okay, thank you. Thank you very much.
Thank you, ma'am.
Thank you, madam. Dr. Sampath madam and Dr. Sripriya, I am on call today. If it is okay, can I leave the conference now? Will there be any discussion at the end of the session?
We'll just check the chat box, madam. 1 second. No questions so far, madam.
Madhumita, next.
So there is
Yes,
any,
thank you,
I
ma'am.
think we can manage it.
Yes, ma'am. Thank you very much, ma'am, for such an informative talk. Next, I request Dr. Sneha Surendra Buyar. I request Dr. Sneha Surendra Buyar to kindly introduce Dr. Hepzibah for the next talk.
Sneha is not there. Ask Omana madam to introduce.
Kindly put the slide, Madhu.
The slide, please. The CV slide of Dr. Hepzibah, please.
Hepzibah madam slide, Sahibi.
Yes. Dr. Omana ma'am, can you
Yes,
please?
yes. Very good morning to all. First of all, let me congratulate Sampath Kumari madam and TNFOG team for organizing such a very practical webinar with very useful topics for especially practicing obstetricians, peripheral obstetricians like us. I think it is from the grassroots level to the latest updates. So congratulations, ma'am, and I bring all the love and affection from Kerala, my colleagues, for this webinar. Now, coming to my duty, Madam is the former Superintendent, Stanley Medical College, Professor, 7th Medical College, CIMATS, past President of ObGyn Society, Southern OGSSI, President of Chennai Menopause Society, past Indian Menopause Society Education Committee Chairperson, Research Member Secretary, Civil University, conducts awareness programs for Tamil Nadu paramedical staff, schools and colleges, presented and published many papers in indexed journal and review HST, PhD guide for SRMC, and she awards Lifetime Achievement Award. Then she had Lifetime Achievement Award, Foxy 2015, Teacher Award, Stanley Medical College 2016, Dr. APJ Abdul Kalam Award 2017, Best Scientist Award 2018, Best Faculty Award 2019 and 20, Excellence Specialist Award from TN Medical Council. Yes, from Honorable Tamil Nadu Governor 2018. She has developed Midlife and Beyond app for IMS, written textbook, video embedded undergraduate manual of clinical obstetrics and gynecology, 3rd edition, handbook USG for training MBBS doctors, Foxy Focus, endometriosis and menopause. I'm proud to introduce such a learned person in front of you. And I again thank Sampath Kumari madam and team for making me a part of this wonderful program. Coming to you, ma'am.
At the outset, I congratulate Dr. Sampath Kumari and Anjalakshmi
for the wonderful 2-day seminar, webinar, and it has covered almost all the topic. And thank you for inviting me and make me a part of this wonderful webinar. Can I share the screen now?
Yes, ma'am, sure.
Yes, ma'am.
Epsiba, madam, share the screen.
Yes, madam, it is seen. Are you able to see?
Yes, ma'am. Yes, yes, yes.
Yes, ma'am.
Right. The topic of the day is non-hormonal management of menopause. When it is given, few questions came to my mind. What is the need for non-hormonal management? What are the indications? What are all the non-hormonal management? What is its mechanism? And what is the recent evidence about non-hormonal management? It's not, yes. Why we talk about menopause and its treatment? It is natural. The population is increasing and women outlive men. And there are two drive factors because the falling fertility rate, and the second is people live longer, especially ladies. So an identifiable milestone of a woman is menopause because she has to spend nearly 1/3 of her life postmenopausal period because our Indians attain menopause very early, 45.6, and they live longer for 70 years. So we have to have a good health to move forward. So the treatment is highly individualized. So our role and how to approach the menopause is we have to prevent certain health issues. If they are asymptomatic, we have to give some support. And if they are symptomatic, we have to treat them. So to maintain the quality of life after menopause, three things can be done. We have to improve the life quality by diet, exercise, and natural supplements. And non-hormonal therapy also can be given when the MHT is contraindicated, and alternative therapy like reflexology, then acupuncture and other things, and it relieves the symptoms rather than the disease prevention or reduction. So to live with menopause, the healthy diet is very, very essential. As Benjamin already said, to lengthen thy life, lessen thy meals. So in short, we have to less the salt, avoid sugar, avoid saturated fat, and stop smoking, small meals, frequent level, and it should have low fat, adequate liquids, proteins, vitamins, calcium, high fiber, fruits and vegetables, and protein intake is very much essential so that the sarcopenia will not develop. So this and all we have to avoid alcohol and smoking. We need to have a good sleep. And the most valuable prescription to prevent and treat disease is the exercise. It decreases the fall risk in elderly by 58%, decreases dementia. The brisk walk for 30 minutes for 3 to 5 days a week is very good. Morning walk is better than the evening walk. So all that we have to exercise, change our attitude, eat properly. You don't have to lose anything except your weight. So we have to keep our mind active, stimulating activities. We have to read books, play games, music, social work. And most important is we have to cope up our stress. So by involving some social work, and we have to laugh and smile and all this meditation. So with all that deformity, she is dancing so happily. So it is old as when you give up. Until then, you're spectacular. So we have to be very active, and then exercise and other things we have to continue. In addition to the diet and exercise, the supplements are required. The calcium 800 to 1200 milligrams per day, and vitamin D 1500 to 2000. This will reduce the risk of cardiovascular events. Calculi are not absorbed with the recommended dose of calcium. So the calcium supplements are contraindicated in few conditions like hypercalcemia, renal insufficiency, nephrolithiasis, and it should not be taken together with anticonvulsant thyroid medication. Most of them are thyroid, hypothyroidism. Most of them will be on corticosteroids. So we should tell them it should not be combined with all these drugs. So we are all natively vitamin D deficiency. Though we live in tropical countries, we are not having proper vitamin deficiency. As we grow old, the skin sensitivity to absorb the sun, this thing also is reduced. So the management of vitamin D deficiency should be taken care of. Vitamin D3 tablet or powder, 60,000 international unit once a week for 8 weeks, preferably with milk, or we can give injection, 6 lakhs international unit to correct the deficiency. And remember, it should not be repeated before 3 months. And after correction, we have to do the maintenance therapy, that is by tablet or a powder, 60,000 once a month in summer, twice a month in winter. It can be given by oral spray or oral tablet, 2,000 international unit per day, or injection 3 lakhs twice a year or 6 lakhs once a week. And 1,000 international unit cholesterol will raise blood levels on an average by approximately 10 milligrams. So these are all the supplements we have to advise them. Why we need a non-hormonal treatment for menopausal symptoms? The 2 major safety concerns involved are breast cancer and the heart disease, development of breast cancer and heart disease. Like any other molecule, it has got its own side effects like stroke, cardiovascular disease, cancer, embolism, DVT can occur. So according to the Women's Health Concern Fact Sheet, in recent survey, 95% of the women said they would try alternative therapy before HRT because they think it is natural and because they are worried about health risk. So this is the reason. So the indications, when they are symptomatic and when there is a contraindication, we can give non-hormonal management. And those who opt for natural products, those who have stopped for, see, it cannot be given eternally, hormones. That time also we can add on this non-hormonal management. So the non-hormonal management can be of 2 types, pharmacological therapy or complementary therapy. So coming to non-hormonal management of pharmacological therapy, it is very useful for the relief of hot flushes, night sweats, and mood swings. SSRI, namely the paroxetine and fluoxetine, and SNRI like venlafaxine and desvenlafaxine, anticonvulsants like gabapentin, 30 milligrams TID for 6 weeks, and alpha-2 adrenergic agonist clonidine can be given daily for them, especially when they have hypertension. This combination with VMS is very useful. And remember, paroxetine is the only FDA-approved formulation for management of VMS. So the non-hormonal we have to select. For women with insomnia, predominant symptoms, you can choose gabapentin. Women with predominant mood disorders, you can prefer fluoxetine and paroxetine. When women with dyslipidemia, we can put them on fluoxetine, citalopram, and most favorable effect on the lipid profile. So we can choose according to the patient need and highly individualized. So apart from pharmacological therapy, non-hormonal therapy, complementary therapies are also available. Okay, so we all know the black wash, red clover extract, St. John's wort, and soya product, and the cinnamon and 3 combination, Formis and Angelia, and Siberian herb, Roham, Properium are all available in the market. And in addition, when they are not able to give estrogen locally, we can advise them vaginal moisturizer like KY gel, and we have to prescribe the glycerin-free moisturizer we can prescribe for vaginal dryness and this thing. Coming to the phytoestrogen, it is called dietary estrogen. It is naturally occurring in the plant components and structurally similar to estradiol, 17-beta estradiol. It can be estrogenic and anti-estrogenic effect. And this is the reason the Japanese live for a long time. They use a lot of soya products. And so this isoflavone, as I already told you, it has got both estrogenic and anti-estrogenic effect. And they act on preferably beta estrogen receptors in CNS, blood vessels, bone, and skin. and no stimulation on breast or uterus. That is why they are more useful for VMS and sleep disorders. And soya protein, in addition, it reduces cholesterol, decreases oxidation of LDL, impede thrombosis, improve vasodilator response in arteries exhibiting the plaque formation, generally decreases the atherosclerosis also. So, but according to Cochrane and the recent conclusion, the phytoestrogen, Jensen like this, has been shown to be effective on Vosamata symptoms without an adverse effect on endometrium. And we have the Siberian root, which has got a selective action on estrogen receptor beta receptors. It reduces almost all the climatic symptoms, minimal affinity for ER, so no risk for tumor. So it can be easily taken by 4 milligrams with a glass of water, and it has got no major effect. People have done a lot of studies. It's a long-term studies also they have been done. They have done for 12 weeks, but they have extended the efficacy for at least 2 years. And there is a lot of improvement in almost all the menopausal symptoms. And at another herbal product is the 3 combination. The Synacium wilfredi, it is an antioxidant and immunomodulatory. Phlomosis ambrosa, it's anti-inflammatory. Angelia prevent loss both in trabecular and cortical bone. So the 100 milligrams twice daily for 12 weeks. There is a study by the Cochrane Society of Menopause in 2500. It improves menopausal symptoms and bone density also without any serious effects. So a lot of studies are there. But when we look at the evidence, however, the evidence-based medicine and Cochrane review and NICE found insufficient evidence to support the use of these products, and their long-term safety is unknown. So another thing which is used very commonly in abroad is a bioidentical hormone. This is also from plant source, similar to traditional HRT, and it has been recognized by FDA and Endocrine Society, but there is no conclusive proof that they are inherently safe and more effective than pharmacological counterparts. So when we prescribe, we have to remember, when we recommend herbs, it would be essential to inform the woman that very little human data are available on the usefulness of this formulation, and side effects of the herbs have not been studied. It is important to read the label to determine isoflavone content and to warn them that in India, there are few regulations about the quality of such products.
Excuse
so there
me,
are other developments.
Excuse me, ma'am. We have 2 more minutes to finish, ma'am.
I will finish in 1 minute.
Yeah,
The
thank you,
recent trials of neurokine 3 receptor agonist is a safe and new non-hormonal agent, which works within few days for the vasomotor symptom. So it will be a valuable agent for those who use non-hormonal therapies. It is currently only available for research setting. There are alternative therapy for menopausal hormone menopause management, acupuncture, yoga, reflexology, homeopathy, hypnosis, and NICE recommends cognitive behavioral therapy for postmenopausal anxiety and vasomotor symptoms. So to lead a blissful postmenopausal age, eating the right diet along with supplements, having an adequate sleep, exercise regularly are the keys to elevate the symptoms. When symptomatic, when MHT is contraindicated, there is non-hormone treatment is indicated. So to treat menopause is really a challenge because of increasing aging population, eroding family tradition and ties and nuclear small families, negligible trained personnel in menopausal and geriatric medicine. So the physician heals, the nature makes well. To ease menopause symptoms, non-hormonal treatments are available. And to conclude, there is always a progress in science resulting in new techniques, new discoveries, new things. Tomorrow, someone will come and talk to you some other new drug. For menopause symptoms to treat, we have widened our drugs. And thank you for patient listening.
Thank you, ma'am. It was a very nice elaborative talk. Just, in Kerala, we are more educating yoga for these postmenopausal people, usually early morning, 6 to 7 o'clock like that. So the joint movements as well as the breathing exercises are helping them a lot.
Yes, ma'am. Yeah, we are also in Indian Menopause Society. Every Sunday we have dance exercise.
Yes, Zumba.
So all we have to be active. I showed you know that.
Yes, ma'am. That's very nice. Very nice.
So happy and doing dance. All
Yes.
that we have to age gracefully. That is that. Thank you. Thank you for the opportunity. It was a wonderful thing for to join in the wonderful seminar. Thank you, Madam, Dr. Anjalachi and Dr. Sambat Kumari and Vijay Lakshmi. It's a great going. All the best.
Thank you so much, ma'am, for providing us the detailed insight about non-hormonal management of menopause. For our next talk, I request Dr. Vijay Lakshmi Jnanashekaran to please introduce Dr. Sheila Mane.
A very good afternoon to one and all. It's really a pleasure to introduce Sheila Mane, Madam. Who does not know Madam? Madam is currently the DNB faculty at KCG Hospital, Bengaluru. And Madam was the president of Isoparp Society, Bengaluru, president Bangalore Menopause Society, ICOG vice chairperson elect at present. She's been, she was part of the scientific thing of the ICOG Bengaluru, which was a treat to all of us. Over to you, Madam. I don't want to stand in between you and the scientific session.
Thank you. Where can I get the slide? Share screen. Yeah.
The green button.
Yes. I think the same thing is happening here. What happened with Dr.
Sheila Mane, don't go to Zoom.
No. Can you see my slides now? Is it seen?
Madam. No, not yet. Ma'am, you close your PPT. Minimize your PPT.
It is minimized.
Then go to share screen, ma'am.
Yeah, I have gone to share screen.
Now your PPT will be seen there. Your laptop, what do you call, taskbar will be seen. Now click on that PPT.
Is it seen
now?
Yes.
Yes, madam. We are there in the last slide. So
no, it will start. No problem.
Slideshow, ma'am.
Thank you. Yeah.
Okay.
Thank
you very much. I think it's really great going, and thank you for the invitation and excellent scientific program, and it's a real feast. And I think I really enjoyed Dr. Hebziba's talk and Dr. Dipti's talk. Okay, so all of us, as we know that wherever it is indicated, HRT plays a role, and so newer HRTs is a hope for millions of menopausal women. Now, we will have a checklist manifesto, array of choices available for Indian women, and what are the newer entrants, are they superior, and it's the time to make a right choice. Okay, so now what to consider while making a right choice is so many things when it comes to HRT: right route, right estrogen, progesterone, dose, regimen, duration. So there are 6 rights to make a right choice. Now, HRT options which are available are systemic therapy. That is, we have estrogen, which is CE, which is available for a long time now, estradiol valerate, and 17-beta estradiol in the oral form as well as transdermal gel. Progesterones are dihydrogesterone, micronized progesterone, medroxyprogesterone, and levonorgestrel in intrauterine device. Tibolone, then combinations of estrogen and progesterone, we have sequential and continuous with 17-beta estradiol and dihydrogesterone, and SERMs are benzodoxifene plus CE and ospemifene. They are still not approved, but available in India. Now the SERMs, that is benzodoxifene with CE, it improves the BMD and reduces the fracture risk, improves the VMS and VVA, that is vulvovaginal symptoms, and there is no risk of carcinoma breast. Now, it is given 20 milligram per day alone, had no effect on vaginal pH after week 12. And vaginal pH was most bothersome symptom, significantly improved with that is benzodoxifene and CE compared with placebo. So it is effective in treating moderate to severe VA and vaginal symptoms, but it's not available, but available in US. Coming to ospemifene, it is a 3rd generation SERM. First, some approved to treat dyspareunia associated with VA. It reverses the structural changes associated with VEA and relieves the symptoms of dyspareunia. It is generally safe, showing minimal impact on breast cancer or endometrial hyperplasia or carcinoma, but it is approved again in US and EU and not available. Coming to the combinations of 17-estradiol, hemohydrate and dihydrogesterone is the natural choice and mimics the physiological hormone and which is currently available. It is the most potent estrogen, and dihydrogesterone is a retroprogesterone with high oral bioavailability and affinity for progesterone receptors. So we have sequential and we also have combined. Now, sequential is for perimenopause and those with premature ovarian insufficiency, and continuous combined is for post-menopause. Yes, the dosage will differ here, will be definitely lesser for the post-menopause compared to the perimenopause. Progesterone is added to prevent estrogen-induced endometrial changes, and the type of hormone therapy a woman receives will therefore depend on whether or not she still has a uterus. Women who still have a uterus usually use estrogen plus progesterone to protect the lining. Who have had a hysterectomy generally can use only unopposed estrogen, and women who have had endometrial ablation need progesterone because some endometrial tissue may remain. Now, how to approach a natural menopause? POI, we have to must start the therapy, for POI. No risk of carcinoma breast, there is no risk, reduced the CVD risk, osteoporosis, Alzheimer's, premature death, symptoms, moderate to severe, and high strength of estrogen is required. And we have to continue the treatment till the age of natural menopause. For Indian women, it is 46.4 years, average age. Natural menopause, in perimenopausal, we can give sequential estrogen and progesterone. Estradiol is only 1 milligram. It regularizes bleeding and improves symptoms. Post-menopause, we have to give continued combined low dose, that is with 0.5 to 1 milligram of estradiol, no bleeding and improved symptoms. What to consider while making a right choice, right estrogen? So these are the estrogen. 17 beta estradiol, chemically and biologically identical to the endogenous human estradiol, unconjugated, hence rapidly available for injection, minimal liver load, circulates in the plasma as free estradiol, absorbed rapidly and thus escapes metabolism. Estradiol valerate, again, it is metabolized in the liver, split up rapidly into 17 beta estradiol and valeric acid. Orally given is subject to an extensive first pass metabolism, so there could be a high liver load. CEE is extracted from the urine of a pregnant mare, thus they cause 2 to 3 times extra load on liver. There could be prothrombic effect is related to high levels of estrogen in the liver due to first pass effect. So there is an increased risk of ET and stroke. Coming to the, again, E is a synthetic derivative of estradiol and is an agonist of the estrogen receptor, most commonly used as contraception in combined oral contraceptives. Is extensively conjugated, is more resistant to metabolism, increased effect in certain types of the body part like liver and uterus, and these differences make E more favorable for use as COC. Then it causes risk of ET than estradiol due to its 17-alpha ethinyl substitution and consequent reduced metabolism. It shows strong and disproportionate effects on liver protein synthesis. It greatly increased magnitude of effect on VT and CVD risk related to estradiol. And more adverse effects on, again, greater incidence and severity of cholestatic hepatotoxicity. Plasma protein binding of E is almost 97 to 98%. It is bound almost exclusively to albumin, and we know that the liver load is more. Now, when it comes to progesterone, again, we know we have different types of progesterone available. Micronized progesterone is progesterogenic, anti-androgenic is plus or minus, and anti-mineralocorticoid and glucocorticoid. Dihydrogesterone has maximum benefits like progesterogenic, anti-androgenic, anti-mineralocorticoid is again plus or minus. Drosperinone is again progesterogenic, anti-androgenic, and anti-mineralocorticoid. Cypraterone acetate is more androgenic and glucocorticoid. Medroxyprogesterone, androgenic plus or minus, but it is glucocorticoid. And norethistérone is again, we know that androgenic more. So with synthetic progesterone, there is increased risk of CVD, VTE, stroke, and breast cancer in comparison to natural, that is dihydrogesterone and micronized progesterone, as we know that it is the progesterone which is the culprit for the carcinoma breast. So we have to have a critical appraisal of WHI, and all of us we know. I will not go into the risk because this study was not accepted later as it was done in elderly women again. Okay. So post WHI study, the MPA turned from 0 to 0, as we know that it has a consensus that the poor cardiovascular and breast results of that. Now the risk of breast cancer, if we assess, okay, with dihydrogesterone, they found that in MHT the risk was lesser. So there is a difference in breast cancer incidence per 1,000 women aged 50 to 59 years. 23 cases of breast cancer were diagnosed in UK. Combined MHT, there were 4 more cases. Estrogen only MHT, 4 fewer cases. Overweight or obese patients, there were 24 more cases. And those who used to take alcohol, there were 5 more cases. Combined oral contraceptives, hormonal, 4 more cases. Current smokers, 3 more cases. But at least 2.5 hours moderate exercise per week reduced 7 fewer cases. So Dr. Hepzibah already mentioned about that. And I think it is not. We have to have a holistic approach because that can really reduce the body mass index and reduce the incidence of breast cancer. Now, the risk of breast cancer is again not the same with all MHTs. Okay. So MHT, does it cause significant risk? IMS and NAMS and NICE and ASCOG again says that with IMS, it is very small. NAMS says it is rare. NICE also says little or no change. And estrogen alone does not initiate or promote breast cancer. Does progesterone matters? Yes. Primarily associated risk is with synthetic progesterone. More progesterone, NAMS says, such as MPA, may have a more adverse effect. Yes, EPT, NICE says, can be associated with an increase in the risk. So which progesterone is safer? That they say that either micronized progesterone or dihydrogesterone can reduce the risk. So the choice of progesterone, risk elevation may not be uniform for all progesterone. And we know that this was again a cohort study where they found that estradiol with dihydrogesterone, there was no significant risk. So progesterone does matters there. Micronized progesterone or dihydrogesterone appear to be linked with a lower risk of MHT-associated breast cancer than synthetic progesterone. Coming to VTO and CVD risk again, transdermal estrogens likely to produce less likely to produce VTE, stroke, and CAD. So there is a concern: is VTE risk is high with MHT? VTE is less frequent among Asians and non-obese less than 60 years. NAM says it is more common with more than 60 years and or more than 10 years of postmenopause are at a high absolute risk of CHD and VTE. NICE, DVT risk increases with age and BMI. And again, American Society says increased risk with higher age, BMI, positive family history and personal history. So does estrogen and progesterone matters? Oral estrogen increases the risk. And if there is a suggestive history of cardiac insufficiency, again, MPA can increase the risk. Again, greater risk with oral estrogen and androgenic synthetic progesterone. With NICE and American oral estrogen increases the risk. So which MHT is safer? If there is a risk of VT, transdermal estrogen is safe. All of them say that transdermal estrogen there is a lower risk of this VTE, again containing natural micronized progesterone or dihydrogesterone. So this was again another study. So dihydrogesterone and micronized progesterone appear to have an acceptable thrombotic risk profile. So these are all the studies. Now, what to consider again when it comes to combined MHT? We know right now we have a newer molecule combined MHT, and it is easier. I already said for perimenopause and POI, sequential 1 milligram of estradiol and 10 milligram of dihydrogesterone. Postmenopausal, you have to give lesser dose of dihydrogesterone. Okay, it definitely improves the hot flushes. So there is a significant reduction in moderate to severe hot flushes versus placebo when the patient is put on MHT. So all of us, we know this was again the comparison with estradiol and dihydrogesterone and CE with norgestrel. And if we look at that, we find that Psychological scale was almost equal. Somatic scale also we can say equal. Vasomotor scale slightly better with estradiol and dydrogesterone. Sexual dysfunction also equal in these combinations.
Excuse me, ma'am.
Gynecological cancer risk.
We have 2 more minutes to finish, ma'am.
Yeah. So again, we find that they have assessed the risk of this also. They find that ED use was not associated with a higher risk. So these are the sequential we know, and these are different trials which I will not go. Coming to Tibolon, I think which is there with us for a long time now. It is again used. We know that it is equally effective, improves the libido, no risk or increase in breast density. More frequent breakthrough bleeding can occur. Risk of stroke may be more because it causes dyslipidemia and decreases HDL and increases LDL. So we have to assess them regularly. It may cause weight gain. Okay, so Tibolon, again, symptomatic benefit of Tibolon appear questionable compared to those of combined HRT. But if it cannot be given, Tibolon is a choice, particularly in cases if they are post-endometriotic hysterectomies, we may use that. Okay, so these are sequential estrogen and digesterone definitely improves the HDL levels, but CE and norgestrol did not. So when we are choosing, I think we will have to be very choosy while selecting this, that which progesterone we should choose. Yes, again, I already discussed, I think premature, yes, MHT is mandatory, that we will discuss till natural age. 40 to 50 years, it benefits exceed the risk. 50 to 60 years, benefits again exceed the risk, but we'll have to monitor. Above risk can be more, so we do not recommend. So in POI, we must continue up to the age of natural menopause. We have to continue this. Okay. CVD risk timing hypothesis. MHT started in the perimenopausal, all early menopausal period can have a cardioprotective effect, and later after menopause of 10 years, there is a increased risk. Okay. So these are the things. So these are the benefits. Reduces VMS and GUS, reduces osteoporosis and fracture risk, improves osteoarthritis, reduces CVD risk, reduces the risk of T2, diabetes mellitus, abdominal obesity, reduces, prevents cognitive impairment, reduces neovascular macular lesions, reduces the risk of colorectal cancer, reduces the risk of endometrial cancer with combinations, and improves the quality of life. Now, depending on the risk, there could be the risk, but we will have to assess this patient. So, dear friend, again, coming to this, which parameter, I think we already discussed, depending on the risk, what to use. I think the time is not much. Transdermal with the more risk of VTE and stroke. Otherwise, we can use oral. So, these are the newer HRTs, and I don't think there is a time to discuss now. There is a patient, 51-year-old mid-level business leader. She has LMP 14-month MAC. She had hot flushes with sweats. She's also having mood swings, feeling tired. Her quality of life is impacted. Her uterus is intact. No other significant family and personal history. So I think she's postmenopausal with symptoms and intact uterus. I think definitely we can go with oral progesterone continuous combined therapy. Another case, she's having irregular cycles, feeling hot flushes. She's also having mood swings, impacting her relationships. Her quality of life is impacted. Her uterus is intact. So she's perimenopausal. In that case, we can go for sequential. Okay. So these are the options. Age is a major concern. We already discussed. These are the benefits. Okay. So right women, right hormonal therapy, right age, right dose, and right dose and right route. So the woman's age at initiation of MHT is important in terms of treatment. This was again a patient with hot flushes because she had a hysterectomy with BSO for fibroids by endometriosis 5 months ago. Which one and what MHT should be given? How to approach surgical menopause? Both ovaries are removed. Then she has gone through her natural menopause. It's called as surgical menopause. Sudden and severe onset of hot flushes, increased risk of osteoporosis, sexual dysfunction. So MHT is advised for all women who undergo surgical menopause under the age of 45, provided they do not have contraindications. Okay. So in general, hysterectomized women, estrogen alone. Patients with endometriosis, unopposed estrogen may stimulate the remnant pathology, and adenocarcinoma has been reported in patients with pelvic endometriosis being treated with unopposed estrogen. Hence, progesterone has place in the management of residual endometriosis following radical surgery or subtotal hysterectomy. And we can give dydrogesterone and micronized progesterone. They are both effective in reducing endometriosis-related symptoms or TB1. So again, we know that hysterectomized patient, only estrogen. Hysterectomized patients with endometriosis with either progesterone or TB1. So clinicians should continue to treat women with a history of endometriosis after surgical menopause, either with combined EP, maybe for a shorter period, or Tibolon, at least up to the age of a natural menopause. Okay. So I think we have already discussed. As there is no time, I think I'll stop here. Okay. Thank you very much.
Sheila, madam, you have done full justice to the topic. It was really elaborate, but you have conveyed the message on the right estrogens that has to be used, the right progesterones, and you have made it very clear that you have to individualize the treatment depending on the requirement of every patient, and there is no single prescription for anybody. That was very, very elaborate, but very nicely brought out lecture, madam. Thank you so much. And you have validated the Hepzibah madam's talk on non-hormonal management, which is very, very important as regards to the lifestyle modifications, which is very important for menopause. Thanks to both Hepzibah madam and Sheila madam. That was a lovely session on midlife management. Thank you. And thank you, Sampath madam, for the opportunity. We will move on to the next. Over to Madhumita.
Yes, ma'am. Thank you, ma'am. Yes,
thank you, everybody. And if you don't mind, can I leave because I have to join another webinar? If you
yes, madam.
Okay.
Yes, madam.
Thank you very much.
Sure. That was
very
fantastic.
much. Yeah,
ma'am.
thank you. Thank you.
I request Dr. Vijayalakshmi Gnanashekaran to introduce our next renowned speaker, Professor Dr. Tushar Kar. Over to you, ma'am.
Vijay Crisper.
Okay. Professor Tushar Kar, who is a fellow of laparoscopic surgery from USA, professor and head of the Department of Cuttack, Odisha, Department of ObGyn from Odisha, Shrishti Hospital and Cuttack, and he has been president of AOGO, chairperson ICOG in 2019, and executive committee members of various societies. And sir is going to be the candidate for Foxy President Election 2023. Okay, now over to you, sir.
Instead of Dr.
Thank you, madam.
1 minute, sir. Madhuri madam has some emergency work, so instead of Madhuri, yes, sir.
Okay.
13 minutes.
Okay, then that's sir. Yeah, so I was wondering what sir is going to talk. So it's really from all the gynec that we have heard. Now we are going to obstetrics. We don't expect catastrophe. So he is going to tell us if there is a catastrophe, what is the way you are going to communicate to the patient, the art of communication. Over to you, sir. Oh no, sir, prophylactic. Okay, topic is again changed. Okay, sorry, prophylactic salpingectomy and benign hysterectomy. Okay, sir, thank you.
Thank you, Vijayalakshmi ma'am, for a nice introduction. I am overwhelmed. At the outset, I am very much thankful and extremely thankful to Sampath Kumari ma'am and the entire organizing team and all the members of our Tamil Nadu, AP, Telangana, Karnataka and Kerala for this opportunity in a very, very SOS. Urgently, Sampath Kumari madam has adjusted me. Thank you so much, Sampath Kumari ma'am. And at the same time, I'll be dealing with very common topic and very recent topic, that is prophylactic salpingectomy and benign hysterectomy, which is our original work. So greetings from and blessings from Lord Jagannath. You see, this time Rath Yatra just finished. So this productivity is never on an accident. It is always the result of a commitment to excellence and intelligent planning and focused efforts. Like today, the prophylactic salpingectomy has gone for benign hysterectomy. So there is an interesting observation few days back, which we got a 55-year Hindu female, lower abdominal discomfort on ultrasound, postmenopausal, biometrium normal, ET was 1 millimeter, bilateral ovarian mass of 4.5 into 5 and 6 into 5.4, and PAP was negative, but serum CA120 was 370. So with this, we went for a laparotomy. You can see what is the gross picture of this. Then we are interested. We are routinely examining the uterus for myometrium, endometrium, and also the ovary. Let us see the tube in this case. What is happening? Thus, it's an accidental case because my wife is a pathology doctor, Sanjay Kaur, professor at HOD. So she told that let us examine the tube also. So incidentally, that ciliated cells 25%, peg cell 10%, secretory cell 60% was there. Then we saw that yes, this could give another light towards stick cell. So with this, that nuclear stratification was there. There was loss of polarity, loss of cilia, nuclear pleomorphism, high NC ratio. Then it gave an idea. Can you not do the immunohistochemistry, that Ki67 and P53? Then we found that the stick cells were confirmed. That is serous tubular intraepithelial carcinoma in the fallopian tube in this malignant ovarian tumor. And the older version was that, yes, there is a OSC. OSC means ovarian surface epithelium, which was caused for the culprit for the ovarian surface epithelial tumor. Perhaps from the ovarian surface epithelium, cell goes and migrates and cause the malignancy. But today, whether the stick cell can come from the femoral end of the fallopian tube and can lodge in the ovary and thereby may cause the epithelial ovarian tumor. So with this, the carcinogenesis theory came into play, that the OSC, that is ovarian surface epithelium, for OSC, ovarian embryonic carcinoma, that weak histological argument was there. Yes, it cannot, because the cells of the OSC was not found in OEC. Then large number of limitations are there. What are those? That normal ovarian constituents have no resemblance with the ovarian epithelial carcinoma. Now, biomarker like FOXA and PAX8 extensively expressed in OEC but not in ovarian surface epithelium. OAC or mesothelium embryologically is distinct from Mullerian epithelium. And lastly, true precursor lesion of OAC has rarely, if ever, been found in ovary. So really, it is a wonder what is the pathogenesis of the OEC. Now, the recent concept, so from the femoral end, can stick cell lodge in the ovary and it can cause the malignancy, that is epithelial ovarian malignancy. So therefore, whether tube or not tube, then that is the question, whether the tube or not tube. So with this, the carcinogenic sequence, let's see what are those. The first is the SCOUT, that is serous cell outgrowth. Then P53 signature. Then STILT, that is tubal intraepithelial lesion in transition. Then STIC, that is serotubular intraepithelial carcinoma. So these can affect mainly three structures in the woman, that is in the pelvis, fallopian tube, ovarian, peritoneal cancer. So these prove that yes, the succession at least 30 almost exclusively secretory cells in with a pseudo-stratified appearance that picks up a SCOUT. But here there is a low Ki67 index and no P53 mutation. So next is P53 signature. So what happens? Here P53 accumulates 12 or more consecutive secretory cells are there. Then happens the TILT or STILT. TILT is transitional intraepithelial lesion in the tube or tubal intraepithelial lesion in transition. Here intermediate between P53 signature and this stick is there. But here low moderate Ki67 index. And finally stick cell, where there is expression of the disorganized high NC ratio, nuclear stratification is not there, and there is loss of polarity with immunohistochemistry, that is high Ki67 index and strong P53 staining is there. So with this, now what we find that the stick is the culprit for the ovarian epithelial cancer. So now the WHO and the UK cancer screening, they devise a method, that is screening method. So they suggested that can you not bilateral salpingotomy without oophorectomy as benign hysterectomy. So here we have got Indian study like CORE and CORE, that is in year 2017. We compared with other studies like American, German, Canadian study, 3 other studies, where we got a correlation of high-grade papillary serous carcinoma of the ovary is responsible by stick almost 28, you can see up to that 56%. But subsequently, you see high-grade papillary serous carcinoma was 28% only stick positive, and papillary peritoneal cancer only one, that is 50%, and tubal serous carcinoma almost 100% out of our own series. So here various precursor lesions, you can see we saw stick that is almost around 30%, then tilt almost 18%, and P50 signature expression in 26% in our own work. Then another case, that is the case, you can see the sample that here you can see that from the sample again that P53 is expression and Ki67 was there. Now what you do? This case was again subjected for the fallopian tube simultaneous examination, and stick was frankly positive. So here you can see this is also a bilateral ovarian tumor case. So we'll go to, yeah. So you can see in this case that this is the gross and the microscopic. You can see similar type of lesion in the, you can see that 61 Hindu female with high-grade squamous carcinoma ovary. The stick cell was positive, but most important that Ki67 and P53 signature was also found. Yeah. Is it moving? Yeah, is it moving? Sorry. Yeah. Is the slide moving? Yeah. So here you can see here another interesting case is there. There are 48 years Hindu female high-grade squamous cell carcinoma of the ovary. Again, we got this stick cell P53 and Ki67. No, it's not going. Let it be there. So it's not moving. So another case again, 47-year high-grade squamous cell carcinoma of the ovary where stick was positive. Then another 51-year high-grade squamous cell carcinoma ovary Ki67 and P50 signature was there. So these are the cases. But we found a very interesting case, that synchronous cellular papillary carcinoma of the ovary and the endometrium, where 55-year female with abdominal discomfort and bleeding, ultrasound enlarged bilateral ovaries, and heterogeneous mass lesion in the endometrium, and per-abdominal swelling of lower abdomen, CA 125/760, PAP suspicious, and endometrial biopsy adenocarcinoma and papillary serous carcinoma. So here is the case where you can find simultaneous synchronous finding in the endometrial cavity as well as ovarian malignancy. So squash cytology was done, and ovary was histopathology and endometrial pathology was there. Everywhere that adenocarcinoma came out, and stick histology was positive in the fallopian tube as well as in the ovary as well as in the endometrium. So here is a very important case, that is fallopian tube, very atypical case, serous carcinoma. It is the only primary cancer of the fallopian tube. Again, the immunohistochemistry was positive. So the primary peritoneal carcinoma criteria, what as proposed by gynecology oncology group, that there must be demonstration of unremarkable bilateral ovaries. That means ovaries must be healthy. Presence of tumor bulb in the peritoneum rather than in the ovaries and fallopian tube. No microscopic foci or tumor in the ovary, and tumor must be confined to the surface epithelium, and cytohistopathological appearance similar to ovarian serous papillary adenocarcinoma irrespective of tumor grade. But look at the fallopian tube carcinoma criteria. What it says, that grossly the main tumor is in the tube and arises from the endosalpinge. Histopathologically, the pattern reproduces the epithelium of the tubal mucosa. Transition from benign to malignant tubal epithelium should be demonstrated, and the ovaries and endometrium must be normal. So these are the findings demonstrated by gynecology oncology group. Now, primary peritoneal carcinoma, very interesting case we got, that here again the Ki67 and P53 signature was demonstrated. So we compared with, as I have told, American journal, Canadian, German, and Indian study. Then we got a correlation of 30% of the tubal stick, that stick is responsible for arising of the secondary ovarian epithelial malignancy. So it is as compared to the other study, you can see that they have also almost 18 to 52% all these three other groups. So with this, again in the FIGO, we met Diane Miller from the Canada, who is a member of their country. So other country members were there, and we corroborated with their Indian study with the other country. Now we again produced this in our Foxy journal, and fortunately, and because of your good wishes, and we got the best publication award in 2018. So evidence by different authors in favor of stick as the source that you see, you can see that American and all these three publications, and our Indian, almost our 30%, they are 40, 48 or 20% also to certain extent. Now to conclude, ovarian cancer are amongst the most common female genital cancer. Its pathogenesis is still not clear. We are astonished to know there is no universal screening of the malignant ovarian tumor so far. New concept pointing to the fallopian tube as the real culprit. Is it the culprit? So perhaps this stick pathogenesis is a precursor lesion for most fallopian tube tumor, ovarian and peritoneal high-grade serous carcinoma. So stick has been detected in patients even without carcinoma. So prophylactic salpingectomy at benign hysterectomy can prevent adnexal serous carcinoma in these patients up to 30% in Indian scenario so far. But stick precursor lesion for most fallopian tube, ovarian and peritoneal high-grade serous carcinoma has been proved. Their similar histogenesis has led to a common staging system in all non-uterine pelvic carcinoma as concluded by FIGO Rome 2012. In absence of proper screening method for high-grade squamous carcinoma of the ovary, future method of prevention should be directed at the fallopian tube. And to go forward, that in addition to the prophylactic salpingectomy, while doing for a benign hysterectomy, they have suggested fimbrectomy should be done while you are going for a bilateral BTL ligation, bilateral tubal ligation, which I personally and the Indian Foxy do not agree with this, that in Indian scenario today, we cannot go for a only fimbrectomy to prevent the ovarian epithelial cancer. But British Columbia Agency, Vancouver General Hospital, they suggested this. So they tell that this can achieve ultimate goal of reduction in incidence of pelvic serous carcinoma. So therefore, friends, we agree that prophylactic salpingectomy should be encouraged, done in case of while doing for a benign hysterectomy, but not while going for a bilateral tubal ligation. We should not go for a fimbrectomy at our situation, especially in Southeast Asia. So future clinical trials are necessary. Extremely thorough histopathological examination of the fallopian tube in all cases of adnexal mass. What happens with the clinician? Do not send the fallopian tube for histopathology. We send the ovaries. We send the uterus for endomyo. We send the cervix. But friends, we must send the fallopian tube along with whenever there is an ovarian growth. Let it be a benign one. So we should do regularly. So we acknowledge our department, medical college, pathology department, and cancer hospital, our Acharya Harihara Cancer, and our Srushti Hospital for this great job and great work for the cases. And lastly, I appeal all of you, all my friends, dear sir, madam, with the Lord Jagannath, a blessing and your support. Please help me and please do favor for me. Thank you very much.
Thank you, sir.
So anyone who stops learning is old, whether at 20 or 80. So anyone keeps learning, stays young, like Vijay Lakshmi madam, like Sampadakuri madam. Many are there, especially I have seen in Tamil Nadu and South. All the persons, they are so much friendly and they are so much eager to learn. And really, I express my thanks to all of you. Thank you again, Sampadakuri madam, and all of you.
Thank you, sir. Madhumita will go to the next question. Thank you, sir.
Okay. Thank you.
Thank you. So moving on to session 3, I request our chairpersons to take over. Our chairpersons are Dr. Anjalakshi. Ma'am needs no introduction. She's the founder president of TN Fog, and she was a past president of Foxy. She's the governing council member of DIPSI. She's the recipient of Best Doctor Award from IMA, and she's also the retired professor of ObGyn from Madras Medical College. Our second chairperson, yes,
thank you. Proceed.
Dr. Manjula Raghunathan. Dr. Manjula, Ma'am is the medical director and senior consultant in Srinivasa Nursing Home, and she's the honorable secretary of Nalgoda ObGyn Society since 2018. She also served as a vice president to Nalgoda ObGyn Society from 2011 to 2017. So I request our chairperson, Dr. Anjalakshi ma'am, to introduce our first keynote speaker, Dr. Jaideep Tank.
Good morning. Thank you, Dr. Madhumita. See, we are having a very elaborate program and we are running short of time, 1 hour and 35 minutes. So I request the speakers, if possible, to reduce the timing. Okay, now I am very much privileged and honored to introduce Dr. Jaideep Tank. So we should know the law of the land. We have learned about the POXO Act. Now Dr. Jaideep is going to talk to us on MTP Act. He was the Secretary General Federation of Obstetrics and Gynaecology Societies of India 2018 to 21 and project lead FOXY project USAID project 2020 to 24, past president Mumbai Obstetric Gynaec Societies. He has got so many credits for himself. I request Dr. Jaideep Tank to proceed with his talk on the MTP Act.
Thank you very much,
Dr.
madam.
Jaideep Tank, please.
Yes,
Sir?
madam. Yes. I hope I am audible. I'll just share my screen.
Yes, sir.
Yes, madam.
You can increase your volume.
Yes, madam. Right. I hope my first slide is seen. My first slide is the brochure of the conference.
A to Z.
So thank you very much. I must thank all the societies who have put together this absolutely wonderful webinar. In fact, if I really think about the contents of the program, I think this is one of the most comprehensive webinars covering so many topics with such wonderful faculty. I suppose I shouldn't say that because I am a faculty myself, but the faculty that you have chosen is absolutely wonderful. And many, many congratulations to the organizers. I know that a lot of state societies have taken part in organizing this webinar. There's the Telangana Society led by Shanta and Jamna. There's the Andra Pradesh led by Dr. Ganga and Dr. Uma Shankar. There's the Kasoga led by Dr. Kasturi and Dr. Bharati. And the KFOG led by Sarina Madam and Venu. And of course, I think the driving force behind this webinar is the TNFOG and Dr. Anjalakshi and Dr. Sampath Kumari Madam. I must specially thank both of you. Both of you are doing such a fantastic job. I know the TNFOG has just, how do I say, been conceived, but it has already taken the growth of a 9-month embryo within 2 months like picture, and you have already made it a very mature society. I can assure you that most of the webinars of the TNFOG are very much looked forward to, both for their scientific content as well as the wonderful way in which you conduct them. So congratulations again, Sampath Kumari ma'am and Dr. Anjalakshi ma'am. I'm delighted to see so many friends who are present over here. And it is also my delight to speak immediately after Dr. Tusharkar and in a session alongside Sunita. Both dear friends and chaired by Dr. Anjalakshi and Dr. Manjula. So I'm going to speak on the MTP Act, but rather than just looking at the MTP Act as a series of clauses and sub-clauses, what I will try and do is contextualize the way we think about the law in our day-to-day life and day-to-day practice, and contextualize the MTP Act within service delivery in our day-to-day practice. I'll also talk a little bit about certain acts which conflate the MTP Act. And lastly, we will talk a little bit about the amendments which have taken place to the MTP Act quite recently, if I may say so. But before I begin, I think it might be appropriate for me to start with this story. And the reason I'm telling this story is that sometimes in the hurly-burly of day-to-day practice, sometimes in our desire to understand acts and laws very well, we forget what these acts, what our practice, what service provision for safe abortion actually means. This is the story of a 12-year-old girl. Now, I just want you to, for a minute, close your eyes and imagine this small village in some part of our country. There is this family, father, mother, a 12-year-old daughter. Both the parents are daily wage earners. They go out in the field every day to make a living. And they leave their daughter behind with whom they think is a trusted relative, the maternal uncle. Unfortunately, this maternal uncle turns out to be the worst kind of predator, a pedophile. He repeatedly rapes this 12-year-old girl until inevitably she becomes pregnant. Now, not having had the benefit of menstrual hygiene education, pregnancy-related education, and so on, she doesn't realize that she's pregnant. By the time her mother thinks that my daughter has not got periods since quite a long time and takes her daughter to the primary health center, the girl is already 24 weeks pregnant. At the primary health center, she's told that we are sorry, but you're 24 weeks pregnant, and this was before the amendments came in, and we can't do anything for you. And then begins the round of going to various courts and authorities and lawyers and so on, until finally the girl reaches the Supreme Court. Now, I just want you to take a minute and imagine the trauma that this family has gone through. And even worse, if there could be something worse, every time they go to a new authority, a new lawyer, a new judge, a new court, they have to relive this trauma time and again. Because everywhere people want to ask them, what happened, how happened, so on and so on. This girl finally reaches the Supreme Court, having undergone this trauma and reliving the trauma so many times. And I was asked for an opinion in this case on whether abortion should be provided to this 12-year-old girl or not. I obviously said that yes, abortion should be provided. But the Supreme Court found that since she was healthy, the fetus was healthy and not anomalous, they did not give permission to conduct this abortion. The girl then had to go right up to term, and at 37 weeks had to undergo an elective cesarean section, deliver, and then give that baby up for adoption. Now, whenever we talk about MTP, we talk about medical abortion, MVA, surgical abortion, and the MTP Act, in fact, I would like you to keep this 12-year-old girl and her family in mind and contextualize what we are doing, what we are trying to do, what service provision we are trying to do through the lens of this family. Now, it's rather unfortunate that because of the way laws are written, there is a general cynicism and skepticism amongst us as service providers to even read the various laws. We tend to think of laws which obstruct our practice rather than facilitate it. In fact, this quote from one of my favorite book series, the Harry Potter series, where Scrimgeour asks Hermione, are you planning to follow a career in magical law? And Hermione says, no, I'm not. I'm actually hoping to do some good in the world. Pretty much encapsulates the attitude we as service providers have towards law, acts, regulations, policies, etc. And this leads to the fact that we don't even read the laws that govern us, which is surprising given the fact that as obstetricians and gynecologists, we are the most regulated specialty in all of medicine. If you look at the landscape of laws which govern our practice, you will find that we actually have more laws governing us than even transplant surgeons. I sometimes tell activists and government people that this obviously means you think that doing obstetrics and gynecology is more difficult than doing renal and cardiac transplants. They don't think of it as a compliment, and neither do I. But because of this attitude, laws, acts, policies, GRs remain, as Mark Twain said, a classic, something that everybody wants to have read and nobody wants to read. I'm not asking for a show of hands, but just internally just think, how many of you have read the MTP Act cover to cover? And if you have not read it, I would strongly urge you to read it. For me, the MTP Act is actually one of the most elegant acts to come out of the Indian Parliament. It's short, it's comprehensive, and most importantly, it is empowering to the women who seek abortion and protective to the doctors who provide abortion. But to correctly understand the MTP Act, we need to understand the timeline and why this MTP Act was required in our country. The reason the MTP Act was required was that the Indian Penal Code, promulgated way back in 1860 when we were ruled by the Britishers, with all its Victorian mores and moralities, criminalized abortion. These sections from 312 to 316 of the Indian Penal Code criminalized not only those who provided the abortion, they also criminalized the person who sought the abortion. Now, because demand and supply both were criminalized, obviously abortion went underground. And when a procedure like abortion goes underground, morbidity and mortality from abortion rise. The government of the day in 1964 realized this and therefore set up a committee which was headed by a retired bureaucrat from Mumbai called Shantilal Shah to recommend a broadening and rationalization of the laws related to abortion. The committee worked for 2 years, gave its recommendations in 1966, and the MTP bill was finally presented to the Rajya Sabha in 69, passed in 71, and enforced in 1972. If you look at this page, which I have displayed on the slide next to the text, you will see circled in red there that even in 1966, Foxy was represented in the Shantilal Shah committee. Not everyone may be aware, but it was Dr. V.N. Shirodkar who represented Foxy to this committee very ably and gave some strong statements in support of liberalizing the abortion laws. You know, we all know Dr. Shirodkar for the cerclage, his tuboplasty procedures, his sling procedures, but I dare say that with this single act of representing Foxy in the Shantilal Shah committee, Dr. Shirodkar actually touched many more lives than he did with his excellent gynecological procedures. But the way we provide abortion in this country is not determined by the act alone. The act is an act of parliament and it provides an overview and then delegates some authority. These are then followed by the rules. The rules are framed by the central government and then ratified by each house of the parliament. The regulations are something which the state has control over, because remember, in India, health is a state subject. So although there may be a central law, the state still needs to be given some say in the matter. These regulations are framed by the state government, but very importantly, the regulations pertain only to opinions, reporting and maintaining secrecy. And these are then followed by the SOPs. So if you look at what influences or what determines the way we provide abortions in this country, it is the act, the rules, the regulations, and then the SOPs. And in fact, if you really think about it, sometimes the rules have a much bigger impact on the provision of abortion compared to the act itself. And medical abortion is a classic example. I've been very fortunate to be a part of the amendments to laws for abortion, both way back in 2002 and again recently in 2021. And one of the things which the rules did way back then was bring medical abortion into the ambit of the law. We are able to provide medical abortion in this country today because of that one simple paragraph, which appears as an explanation in the rules. Now, look at the impact of this one small paragraph. 70 to 80% of all abortions in this country are now provided by mifepristone and misoprostol. And these 70 to 80 abortions being legal is owed to this one paragraph, which is there in the rules of 2002-2003. SOPs are equally important. We continue to use mifepristone and misoprostol in second trimester abortion because the SOPs from the Government of India in 2014 actually say that this is the safest way to provide an abortion. Of course, it also helps when organizations like FOXY come out with good GCPRs which support best practices. If you look at this, you'll see the FOXY ICOG GCPR on MTP in pregnancy, which I had the good fortune of drafting for FOXY way back in 2004 when I was the chair of the MTP committee of FOXY. I'm very happy that these were quite forward-looking. They have stood the test of time and even now have not needed to be revised. Although with the new amendments, I suppose a few annexures would not be out of place in this GCPRs. The abortion law, as I said, is excellent, is very good, is much required. But then sometimes this law gets conflated quite unnecessarily by laws which are made in silos, not looking at the impact which these well-meaning laws will have on the provision of abortion. A classic example of this is the PCPNDT Act. If you look at the Act through a legal lens, there is actually no conflict at all between the MTP Act and the PCPNDT Act. And this is an argument I sometimes have with our radiology colleagues. They seem to always say that let's ban sex-selected abortions and the problem of gender selection will get solved. And I always tell them that when you ban one kind of abortion, it will affect all the women who seek abortion. In fact, there is good data to show that even in late second trimester abortions, less than 10% of all women seek abortions for sex determination. So what is going to happen if you ban or restrict abortions in the second trimester is that 90% of women who are getting abortions done for their own reasons are going to suffer because of this unreasonable ban. I always tell them the problem and the reason for the PCPNDT Act is not sex-selected abortion. It is sex selection or gender determination. It's an upstream problem which this Act seeks to address, and that is what we should be concentrating on. Then, of course, is my time up already?
No, sir. No, sir.
No.
Sorry,
I didn't say anything, Dr.
Okay,
Jaydeep.
sorry, madam. Sorry. Yeah. So there is, of course, the POXO Act. You know, this is a needed act, but again, it's one of those things where an act has undesired or unreasonable kind of consequences. Because if you really think about it, the MTP Act was actually very friendly towards adolescents. Before the POXO Act came, what the MTP Act said was, if there is any girl below the age of 18 who has an unwanted pregnancy and needs an MTP, she can come with a guardian. Now, mind you, this is the importance of word. It said guardian and not legal guardian. So till the POXO Act came, for purposes of the MTP Act, a guardian was anybody above the age of 18. It could be her friend, her aunt, elder sister, anybody who is above the age of 18 of sound mental mind. But then the POXO Act came. And what the POXO Act did essentially was it criminalized all sexual activity below the age of 18. All sexual activity below the age of 18. And by doing so, it created hurdles in providing abortion to adolescents. It has also created a lot of conflict and conflation because on the same government website where there's a POXO Act, which criminalizes all sexual activity below 18. There is also a wonderful document called the RKSK Act. It's an RKSK document, which essentially says that, of course, adolescents have sex. Of course, adolescents need abortion. And of course, adolescents should have access to contraception. And because of this conflict and conflation, I get asked questions many times on the POXO Act. So I'll just answer a few, although I'm sure Dr. M.C. Patel has already talked about this. Very quickly, does a provider have a legal duty to inform the authorities if a minor girl is pregnant? The answer is unequivocally yes. Even if the girl does not want to take legal action, even if it is a married minor, you still have to inform the authorities. How do you inform? On your letterhead, you simply write, Miss So-and-so has been examined by me, aged so-and-so, and I find that she's so many weeks pregnant. Take 2 copies to the police station and give them 1 copy, take a received stamp on the other, and then come back to your clinic. And once you come back to your clinic after having informed the authorities, you and the patient both move from the POXO Act to the MTP Act. And you then do not have to wait for any medical legal procedure before performing the abortion, unless and until the provider, the authority has given in writing that you should not provide the abortion. Should you preserve the products of conception? This is quite controversial and different lawyers have different opinions. But in a consensus where some Supreme Court judges, lawyers led by the Jindal School in IPAS, it was found that there is really no need to products of conception routinely unless and until the authority has asked you to do so. So this was the last time the Act was amended 2002-2003. And we will then now move on to the amendments. And what I'd like to show you is this slide. Now, this is a screenshot of my calendar from 6th October 2008. And the reason why I'm showing you this is because of what happened on that day. You can see squared in red is the event which happened on that day. You see MTP amendments meeting at the Ministry of Health and Family Welfare in New Delhi. That's how long it has taken for these amendments to come through. And this was just the first official meeting. We had several unofficial meetings before that. I've also, there has been a lot of teamwork, a lot of advocacy, a lot of stakeholders writing in so many things and advocating for these amendments. This is some of the work which I have done. These are my op-eds and my articles. You can see they have appeared in Hindustan Times, Mumbai Mirror, a few op-eds in Hindu. I've actually also published in law journals and I have been quoted in law journals on the need for the amendments. This is part of an interview where I was interviewed by the Jindal Law School on the conflation between the MTP and PCPNDT Act. I have also published in the International Journal of ONG on the need for amendments. And as I said earlier, I have given several presentations to parliamentarians on this issue. In fact, whenever we used to speak to parliamentarians, we used to tell them that the question of abortion should not be an issue in the political arena. And when a woman has to make this kind of decision, she should be able to see her doctor, not her lawyer, which is what was happening till now. In fact, after a lot of discussion, the parliamentary panels were quite convinced that the need for amendments to the Act exists. We even had visited the Prime Minister's office. We did not meet the Prime Minister, but we met the person who was in charge at the Prime Minister's office. And we told them that these are the changes which were urgently needed. And you can see the rather long list of changes that we had both suggested and advocated for. And we were therefore very, very pleasantly surprised when the MTP Act finally came to the Lok Sabha. One reason for being very happy was that the Act finally made it to the Parliament, but other most important reason was that in the amended Act, the government had practically listened to each and every of our suggestions and tried to implement almost all of them. There was only one suggestion where we said that the abortion should be a right of the woman till 12 weeks, which they did not implement. In fact, during the Rajya Sabha debates, I'm not sure you can hear this, but that's Dr. Harshvardhan, who was the health minister at that time. For the first time, I believe, in Foxy's history, Foxy during this debate was mentioned as the first and most prominent stakeholder whose opinion was taken before the amendments were to take place. So these were the amendments. They were followed by the rules, and I will very quickly take you through them. Just for your reference, what is in orange? Sorry, Madhumita, you said?
Sir, we have 5 more minutes, sir.
Oh, yeah, I'll finish in 5 minutes. Thank you. What is in orange are the amendments which took place in 2002. What is in red are the current amendments. So the current amendments say that a medical board needs to be formed, and for the first time mentions that medical or surgical methods are to be used. Did you know that all this time the act was silent on the methods of providing an abortion? Now, I believe this is an underrated change because it will completely change the way we provide second trimester abortions. Another very important change which took place was that right up to 20 weeks of gestation, a single signature is allowed. Till now, up to 12 weeks, we had a single opinion. 12 to 20 weeks, there were 2 opinions. Now, right up to 20 weeks, a single opinion is adequate. Between 20 and 24 weeks, you need 2 opinions. A seemingly small change, but very important change societally, is that in the clause for failure of contraception, the word married has now been removed. Why do I say that this is a significant change in societal terms? I say that because with this, the government acknowledges that single women also have sex, single women also could get pregnant, and they also need safe abortion. Within the act itself, the gestational age limit for rape has been moved right up to 24 weeks. And the next 2 slides that I'm going to show you are really extraordinarily significant. If you look at the rules, they lay down some indications for which abortion can be provided right up to 24 weeks. And look at the list of indications. It starts from survivors of sexual assault, minors, right down to women with pregnancy in humanitarian settings. If you really think about the indications for abortion in our country, you will realize that in India now, you can provide an abortion for degree holders in ONG. You do not need any fresh registration, reapplication, certification, or inspection if you're registered up to 20 weeks. Medical boards are another very, very important thing. Just imagine what used to happen earlier. The patient had to go to High Court, and no other court would do it. Had to be High Court. Had to go to High Court. The judge would then set up a medical board. The medical board would give the judge an opinion, and there was no time. The medical board could take 2 weeks, 3 weeks, etc. The medical board used to give an opinion to the judge in a sealed envelope. The judge would then decide whether an abortion should be provided, or this whole process has been made redundant. Now, if a request goes to a medical board, and you will see how easy it is to form the medical board, within a very limited period of time, the patient can access an abortion. But there is a bit of a hitch here. The medical boards are to be formed via a gazette of the state, and not many states have provided this gazette. In fact, I recently helped a couple from Delhi to go to High Court, where we got a medical board to be formed in Delhi, and then they could access the abortion at 28 weeks. Look at this extraordinary change. If a couple goes to a medical board, the opinion has to be given in 3 days, and the abortion has to be provided within 5 days. Now compare this to what used to happen earlier with weeks and weeks of delay and dates within the court. There has been some consternation about Section 5, but I think we'll get more clarity when the regulations come out. There are some changes to the training requirement, which has entailed changes to opinions, and there are 2 new forms. There's Form D, which is to be filled by the medical board, and Form E, which we have to fill if we provide an abortion between 20 and 24 weeks. We are, of course, still waiting for the SOPs. This were the SOPs I had written for the government of Maharashtra. You can see that letter asking me to write those SOPs. They went, of course, through a committee, etc. These have been sent to the center, and we hope that these SOPs will come out soon. In fact, after the amendments came out, I was asked to write an op-ed by the government of India. And I was very happy when this op-ed was published, was sent as an official press note from the government. And it was published on the websites of many high commissions and embassies from all over the world. So if you go to these commissions and embassies, you'll be able to read my op-ed there. At the end, I can understand that there has been some criticism of the amendment, saying that perhaps we could have done much more. But the fact of the matter is that as it exists now, India currently has perhaps one of the best abortion laws in the world. And I can say this because I've just completed my tenure as the chair of the FIGO Committee for Abortion. For example, in the US, supposedly the most advanced country in the world, abortion is entirely unavailable in entire states. Can you imagine Texas, the largest state in America, does not have a single abortion provider or clinic. But of course, the path between policy and implementation is never straight. It's rather tortuous, but we have to navigate it. We have to navigate it because for the need of one of the safest medical procedures known to humankind, women are still dying. And they're not dying only in India, they're dying all over the world. We need to stop unsafe abortion, ladies and gentlemen. After all, history is her story too. Thank you very much.
Thank you very much, sir, for the detailed and informative talk about MTP Act, covering all the aspects.
Madhu, Anjalakshi madam will say a few words. I think she's trying to say,
Yes,
but muted.
I think ma'am is muted.
Madam, unmute yourself, Anjalakshi ma'am. Anjalakshi madam, unmute panikyonga. We can't hear you.
Fantastic, sir. Jaydeep, thanks, sir.
Yes, ma'am, you're unmuted.
Okay. Sampath madam, ninge wine.
Jaydeep, thanks, sir. As expected, you have covered everything, sir. That MTP Act 2021, what is to be done for adolescents and what are all the new facts, everything you have cleared, sir. Thank you so much for the wonderful talk, sir. Thank you, sir. Thank you.
Fantastic.
For the next talk, I request our chairperson, Dr. Manjula Raghunathan, to introduce our speaker, Dr. Sunita Tandurkar. Over to you, ma'am.
Yes.
Dr. Manjula.
Yes, ma'am. I am on screen.
Yes, you can introduce Dr. Sunita.
Good afternoon, everybody. I thank Dr. Sampath Kumari madam and her team for making as a part of this very prestigious webinar, which is going since yesterday, and which is a very wonderful thought, and making all the house societies is a part of the webinar, and also framed in such a way that with excellent academic sessions and with eminent faculty. And I congratulate Dr. Sampath Kumari madam and her team for wonderful, successful this webinar. And I'm introducing Dr. Sunita Tandurkar, and who the name doesn't need any introduction, but still she's recently she presented in our TCOG conference now, and she's a thank you to the Sunita madam, and she came on to the TCOG on our request, and she's a head HOD of the of Ruby Hall Clinic, Pune, India, and she's a founder and medical advisor of Solo Stem Cells and Stem Cells Research and Application Center in Pune in India, and she is a vice president for the West Zone FOXY 2017, and she is a chairperson for Maharashtra chapter of ISAR 2019 to 2020, and she is the elected board member and International Society and Gynecological Endoscopies ISTE 2013 to 2017, and she is the chairperson FOXY Infertility Committee 2011 to 2013. And she's an advisor and reviewer for the Journal and Human Reproductive Sciences. I request Dr. Sunita madam, please onto the screen and start her session. Ma'am, Nita madam.
Thank you. Thank you, everybody. It is such a great pleasure and an honor to be on this platform. My special thanks to Dr. Sampath Kumari, who has designed this wonderful program. I'm also thankful to all the South India organization from Telangana to Andhra Pradesh to Kasoga to KFOG and the TNFOG. Dr. Anjalakshmi Madam, thank you so much. The presidents of all the organization, Dr. Kasturi Madam, Dr. Sashmita Madam, Dr. Sarina Gilwas, and Dr. Shanta Kumari, the newly installed president of Telangana organization. Without wasting much time, let me go for my talk.
Dr. Ganga.
Yeah.
Telangana, Andhra Pradesh, president.
Dr. Ganga Sishmita, I have said, and the secretaries as well, Dr. Uma Shankar, Dr. Bharti, Sampath, yourself, Dr. Venugopal, and everyone, and the Vice President of Foxy, Dr. Facey Lewis, who is the love of all South India, for giving me this opportunity to be with you all. Endometriosis and infertility, really, it is an enigma. And today, with my talk, I will try and make it, I'm just trying to put this out. Just allow me to adjust the screen. Yeah. So, friends, endometriosis is an agonizing condition. It's a chronic and recurrent disease. Functional endometrial glands or the stromal lesion outside the uterus or the outside in routine normal endometrial lining. It may be superficial lesion, implants, or a deep infiltrating lesion. We have to understand that 10% of the women of a reproductive age suffer from this endometriosis. And if you see the prevalence in India, it is 1/8 of the global prevalence. So it is quite a big. Endometriosis and infertility, the few facts everyone who should know is it is 6 to 8 times more likely to have endometriosis than the fertile woman. And women with endometriosis have a lower monthly fecundity. It has a lower live birth rate. So if you want to say women who present with infertility, 25 to 50% will have an endometriosis, and of the women of endometriosis, 30 to 50% will have an infertility. Now, what are the pathogenic mechanisms just before we go for the treatment and everything? Retrograde menstruation, Samson's theory, way back 1 decade, 1 century ago, we used to speak, but the altered immunity, metaplasia of the coelomic tissue, genetics, stem cell, so many things are coming. What is important is to understand the pathogenesis of this chronic inflammatory disease. These peritoneal lesions, they activate the macrophages. After the activation of macrophages, what happens is there is an increased generation of inflammatory factors. So reactive oxygen species, nitrogen species, the pro-inflammatory cytokines, growth factors, all they get elevated. And because of their elevation, there is an adverse pelvic atmosphere. And that is why even the pelvic endometriosis, it may not be detected on sonography, but still can have, because there is an activation of these macrophages, and this chronic infiltration is the reason why the pain and the fertility issues happen. Now, what are the pathogenic mechanisms by which infertility can happen? Underlying adhesions, because anywhere there is a blood, there will be an adhesion. There may be altered Th2, Th1 immunity. Normally, you need a Th2 immunity, and there is a paradigm shift increasing Th1 immunity over Th2. And because of these various factors, one is elevated oxidative stress. Presence of ovarian endometrioma itself will decrease the ovarian reserve. Altered immune function, as I said already. Changes in the tubal anatomy. The tube may be open. These patients, unless there is a femoral block and hydrosulfings, otherwise, believe me, HSG will not be able to detect, because tubes usually don't get blocked so easily. There is an altered follicular and peritoneal hormones also, on which I'm going to highlight little more. What is the alteration in the hormones? abnormal folliculogenesis. This is very important. And altered or abnormal endometrial receptivity because of an altered immunity. So all these comes together. So what is the difference in the hormones? The impaired progesterone signaling. This is very important. In endometriosis, there is a disruption in a progesterone and estrogen signaling. There is a suppressed cellular response to the progesterone exposure. And this is why there is a altered every function in a infertility from a folliculogenesis to implantation. Now, this impaired progesterone signaling, there is a resistance of the progesterone, which is conformed to the endometrial tissue. And that is why at foreign location, when there is an endometrial this tissue, it keeps on surviving. It doesn't go dead. And that's why it keeps on proliferating every month. So you should know this. The most crucial point is the activation of a macrophages. And that is where there is an increase in interleukin, VEGF factors, the TNF factors. I'm talking about this, though it looks very much theoretical. Unless you understand that, the management which I'm going to discuss, you will not understand. So there is a progesterone resistance, there is an altered signaling, and there is a macrophage activation releasing wrong interleukins and growth factors. So endometriosis is common in infertility. We all understood that, but its management is very, very controversial. So when a patient comes with the endometriosis, how do we go it? Very important is we have to proceed with the evaluation. This may be the first time she has come to your cabin. She may not be aware that she is endometriosis. Sorry. So first is we have to go in a detail about the history, the ovulation, everything. And then the combination of factors which you have received, you need to do the laparoscopy. Why laparoscopy is needed? To assess the staging of endometriosis. The treatment of endometriosis differ when it is endometriosis grading 1, 2, or 3, or a grade 4, depending upon what stage is. And that is why in a patient of unexplained, or because majority of the time when there is a peritoneal lesion, it will not be detected on sonography, and we label this patient unfortunately as unexplained. And to explore the more cause, we do the laparohysteroscopies for this patient. So staging is very important in a case of endometriosis. Of course, this ASRM classification from stage 1, 2, 3, 4, or now the new classification which has come is an Insanian classification. This is becoming little more acceptable because it classifies as per the retroperitoneal structures involved. The component A, the component B, and component C, or depending upon the mode of invasion, less than 1 centimeter, 1 to 3 centimeter, or more than 3 centimeter, or deep endometriosis and invasion into the other organ. And that is where it elaboratively, and maybe it helps us to detect. Now, these patients of endometrioma, indication. Now, once you know that this patient is of endometriosis, she has been operated. Now, indication for a repeat surgery is only for the severe recurrent pain symptoms, which is impairing the quality. In case of a recurrent endometriosis, let me make one bold golden line treatment. Repeat surgery does not improve the fertility. So please don't ask this patient to undergo once more the surgery. You need to understand that with every surgery, we are causing further damage to it. And that's why the first surgery has to be best. And after the surgery, one need to do very good counseling to the patient to decide her further obstetric or the future fertility point of view, so that even before the recurrence happen, she become pregnant. But unfortunately, we do have a recurrent endometriosis, and friends, believe me, don't keep on operating this woman. If she is your younger sister, if she is your sister-in-law, if she is your daughter, you are not going to operate. Same way, don't do this for your patient. But the one which has not undergone any surgery, She is known to have an endometrioma, whether to operate or not in an asymptomatic patient. This is the most important thing. Now, I feel we should be operating for two things. One, to decide the staging. She has never have undergone laparoscopy. Sonography cannot decide the staging. It is only laparoscopy which will decide. But at the same time, laparoscopic surgery can increase the chances of spontaneous conception. Okay, but whether it will improve in a live birth, we don't know. But laparoscopic surgery, if I'm doing, am I causing more harm than the help? For a primary surgery, no. You are doing a staging. That's why you need to have an expert. At the same time, after your surgery, see what is the end result. If the end result is very good, good tubo-ovarian relationship, you feel that patient is young, her ovarian reserve is acceptable, semen is normal, you may ask her to try and conceive with the simple modality, maybe a natural relation, or with the ovulation induction and IUI for a few cycles. Maximum result is in first 3 cycles. And these are the patients where you should be giving for IUI gonadotropin, because the success rate with the oral ovulogen alone will be 6 to 8%. When you add on the gonadotropin IUI, the success rate can go from 15 to 30%. What is important is the success is in first 6 to 8 months after laparoscopic surgery. So treat that as a golden period after the laparoscopy. Remember one very important thing. Women with endometrioma experience a progressive decline in the AMH. It is faster than a healthy. This is very interesting. The presence of endometrioma itself is decreasing in AMH, but these patients who have endometrioma, suppose she's 30 years and she has endometrioma, and another lady of 30 years without endometriosis. The decline rate of AMH is faster in the patient of endometriosis. So don't think that you have done a very good job and the patient will conceive. Remember, you might have thought of no recurrence, but remember, as the time passes, her AMH will drastically go down. And it's very important that that golden period window of fertility don't allow to be spoiled. The ovarian reserve is measured. This is a very interesting article where they have studied the endometriosis and the ovarian reserve after 1 month and 6 months. And they said after 6 months, it may pick up. And it is good at the end. So don't jump on doing a AMH. Start thinking more, how do I give a pregnancy to this patient? There is no golden rule. It has to be individualized as per the patient. Now, the decision about whether to operate or pursue for an ART will depend on various factors. Now, let us consider the situation. Patient has an endometrioma. She was never operated. Whether I should operate and give her a chance to conceive naturally, or whether I should go for an IVF. How do I decide about this? Which is the best? It depends upon the age of the patient. Again, individualize. Don't have a golden formula. It doesn't fit for all. See what is her age. See what is her ovarian reserve. What are the associated others? She may have undergone in childhood some ovarian cyst surgery. You never know. Whether her pelvic pain, because we have to be sympathetic with her quality of pain. Size of an endometrioma. Assessed for the anatomical. See, if endometrioma and whether if I have to go directly for a IVF, whether the ovaries are accessible or they are high up. And if they are accessible, whether the endometrioma is coming in the way of a surgery. Now, if I have to do the surgery and if I have to go ahead it, look at this. You have to understand certain principles of a surgery. The first surgery has to be the best surgery. So ensure that you will be. Try to do laparoscopic because chances of adhesions will be less. Now, this is the patient I will label level 3, but tubo-ovarianship not altered. So I will try and work out in conserving as much as ovarian tissue. Try to be next on the cleavage line so that your plane is bloodless plane and you don't coagulate much. By chance, if you have to coagulate, always coagulate on the cyst wall and never on the cortex. So you don't cause further damage, because in this cyst wall also you are taking out lot of corpus. And most importantly, I'm just going to the end, see the end result. Don't cauterize this. Do the compression. Neoangiogenesis is the first step in the pathogenesis of endometriosis. So there will be a lot of bleeding, but with the compression, these capillaries can close down. So don't start cauterizing. And if end result is a good tubo-ovarian relationship, these are the patient I'll think of doing 3 to 4 cycles of a IUI. And if no success, and if prolonged duration of a marriage, age is advancing, there is any other thing, I will directly go for a ART after this. But in this surgery, if this was a level 3, but the end result is tubo-ovarian relationship is damaged, tubes are not healthy, hydrosulfings is there, I may justify to go for a IVF. What does the endometrioma do? This is a very interesting retrospective study. Why I like this? Because it has a huge volume of 862 in both the endometrioma and no endometrioma. What does the presence of endometrioma does? It decreases the AFI, it decreases the oocyte maturation, fertilization rate, blastocyst rate, number of oocytes, and hence the number of available endometrioma. But in these cases, if you do the surgery and then you have to go for a IVF-ICSI, you will have a better, because presence of endometrioma is affecting the oocyte quality, the fertilization, and the top quality. Because you operated, you may have more of a high mature oocyte, better fertilization rate, better top quality embryo, but the number of eggs you will retrieve are going to be less. So you have to balance the patient's age and the AMH before deciding whether you want to operate and see you want to do the staging or you want to go for the IVF. Remember one very important, live birth rates were compared when there was endometrioma and women in the control group. So presence of endometrioma, what is ultimately? It may be I will have a little bad quality egg. My fertilization rate may be less. My top quality embryo will be less, but live birth rate are comparable. So don't jump in under surgery for each and every patient. Now, endometriosis, this is a ISHRE guidelines which has come, which says operative laparoscopy, very important in level 1 and 2. I always say level 1 and 2, you can diagnose only when you do the laparoscopy. So you go as an unexplained infertility, you put in a laparoscope and you find that there are endometriotic deposit. The black one, black powdered are the old, but the fresh one will have either vascularization, neoangiogenesis, you may have a brown red spots, you may have a pseudo pouches. Do the fulguration of these spots. That is why they say operative laparoscopy. What is operative? Fulguration of these pairs. And clinician may consider operative laparoscopy for the treatment of this, as it may increase the chance of a natural pregnancy. But this is a weak evidence, although no compelling evidence that operative laparoscopy for a deep infiltrating endometriosis, the one which goes on the sigmoid colon, whether it will improve, we don't know. So only if it is symptomatic, you operate. Are there any hormone or a medical therapy effective for endometriosis? No. GnRH agonists, progestrogens, OC pill, because they are causing anovulation. It is not going to be effective, but I'm going to tell you in 5 minutes about the dydrogesterone, the right choice for the treatment. What did I tell you? What was the problem? Progesterone resistance. That is what happens in endometriosis. And there is a repetitive retrograde shedding. Now, this also increases the progesterone resistance. And what do dydrogesterone do is it increases the progesterone receptor expression and it decreases the pro-inflammatory cytokines, the macrophage activation, everything gets it out. This is very important, and that is why. And another most important thing about dydrogesterone is it exerts the anti-inflammatory action. So it decreases those natural killer cells, leukocyte adhesion molecule. And above all, dydrogesterone doesn't cause anovulation. It doesn't stop the lady from ovulating. So I'm getting a win-win situation. So what I do usually is, if it is endometriosis, I did a laparoscopy. I find that there are level stage 1 or stage 2, only endometriotic deposits, mild to minimal. I'm going to fulgurate and I put these patients on a dydrogesterone if I'm asking them to try naturally for 6 months because they are very young, 25 to 27 age group, age is extremely good, and it was a very early stage. I put this patient on dydrogesterone. This dydrogesterone helps me to prevent the further progress of endometriosis. At the same time, it doesn't cause anovulation, so it helps me to give. Even the video which I showed you, endometrioma, I operated, I found that then there is no much lesion, but there can be every month progression of the endometriotic pathology which is going. And I put these patients also on dydrogesterone 10 milligram once a day because it is an expensive drug. I might have to tell them to take it for 6 months, and that's where. This dydrogesterone, it tackles the chronic inflammatory cells. It decreases the TNF factors. It decreases this tumor necrosis factor, the wrong interleukins, the wrong growth factors, and this dydrogesterone inhibits this pro-inflammatory action. And that's why it plays a very, very important role. I'm not here for any companies. There is so much about dydrogesterone going on. For about last 2 decades, all these endometriotic patients, when I'm not going for a ART, IVF or ICSI, I'm putting this patient on dydrogesterone and they will come to you for a spontaneous pregnancy. There is a reduction in their pain symptoms. There is a reduction in endometriotic lesion. Improvement, most importantly, is it doesn't inhibit the ovulation and it increases the pregnancy outcome. That is the why no medical line of treatment like GnRH or these OC pills in a fertile woman or who wishes to have a fertility, but you can keep a dydrogesterone. Do the pre or post-surgical therapy, I can use as an adjuvant. As I just told you, it is only the dydrogesterone which will be. Other pre and post-surgical medical therapy, the results are uncertain and you don't improve. In women with endometriosis, is surgery effective to increase the chances of natural pregnancy? I have already spoken to you that ovarian endometrioma negatively impacts oocyte quality, quantity, but not the overall live pregnancy rate. So you decide whether we need to do the surgery or not, depending on age, her ovarian reserve, her duration of marriage, and associated male factor. Is ART more effective for infertility associated with endometriosis? Of course, in level 1 and 2, you can think of doing IUI, as I say, with the gonadotropin as a stimulation, but you can think about ART if there are so many other factors, especially tubes are compromised, patient's age is advancing, AMH is low. Are medical therapies effective as an adjuvant too? So now I'm doing an ART treatment. Am I supposed to use medical therapy as an adjuvant, like a long-term agonist therapy? Am I supposed to give a GnRH to this patient? This is a recent meta-analysis which has come by the Cochrane in 2019, and they say GnRH agonist prior to ART treatment to increase the live birth is not recommended. And there is insufficient evidence to suggest that. Many of us do the frozen cycle. Actually, even if the Cochrane says that, let me tell you, in my practice, if I'm doing a ART for an endometriosis patient, there is an active endometrioma or there is a uterine endometriosis, that is adenomyosis, I do freeze the embryos. I give a GnRH to the patient and then I do the frozen embryo transfer. I believe that GnRH will cause shift of Th1 immunity to Th2, improve the endometrial receptivity, decrease the pro-inflammatory and anti-inflammatory cells. But the Cochrane doesn't support it. Cochrane says the data doesn't even. So patient who received GnRH 3 months had a lower concentration of the cytokine and they may have a higher fertilization than the other woman, but the embryo quality and clinical pregnancy did not show. That is what Cochrane says. But I, in my practice, give a GnRH by doing a frozen embryo transfer. Are surgical therapy effective as an adjuvant? As I told you just now, presence of endometrioma before ART, don't do. There is no benefit. It may, presence of endometrioma may affect the oocyte quality, the fertilization cleavage rate, but it doesn't change the live birth rate. But if the patient has agonizing pain, if she has, the endometrioma is coming in the way of the oocyte retrieval, doing a careful surgery doesn't decrease the live birth rate. That is also very important for all of us.
Excuse
Now,
me, ma'am.
Another 3 minutes only.
Yes, ma'am. We have 5 more minutes to go.
5 minutes, I know. Fertility before and after surgery for deep infiltrating, they said there can be. So those patients who have an infiltrating region, you can improve. So surgery for endometrioma or deep endometriosis prior to ART can be considered to just if there is a pain or for the accessibility of the follicle for the egg retrieval, otherwise it is not. Is there any other non-medical treatment available? We don't know. The evidence doesn't support any nutritional enzymes. There are so many enzymes which has come apart from the CoQ. I don't think anyone will improve the oocyte quality. The Chinese medicine, the acupunctures, the exercise, psychological intervention, there is no evidence. Is endometriosis an indication for a fertility preservation? Last 2 slides. If I see the patient of endometriosis, I operated 35 years, unmarried girl. Am I supposed to tell this is what I usually do? If she is unmarried, not only say it's not easy to tell just, oh, get married soon. From where she will find a guy to get married? So am I supposed to do the fertility preservation? I'm operating on one-sided endometrioma. Can I take some ovarian tissue from other side and can I do the cryopreservation of ovarian tissue? Yes, I do that in my routine practice. I tell them if you are not planning the pregnancy or if you are not married, your AMH is low irrespective of age, please go for a fertility preservation of your oocyte, or at the time of a laparoscopic surgery, we do routinely the cryopreservation of the ovarian tissue. If she gets married, if she conceives naturally, wonderful. Otherwise, you have the ovarian tissue to cryopreserve or to do the retransplant, though the studies are limited. Otherwise, explain her and do the fertility preservation. But why I'm saying but, this is what I do in my practice, but the evidence, this is a Garcia's recent publication in 2008. They say in case of an extensive endometriosis, ovarian tissue cryopreservation, should discuss the pros and cons. And the benefit of the fertility preservation remains unknown because it is expensive treatment. I do understand and I do agree. And that is why you should be sitting with the patient. This patient needs a counseling. Look, your AMH is very low. You are not planning pregnancy or not planning marriage. Then what are the various fertility options? What is oocyte freezing? What are the success rate? How many number of oocyte I need depends upon the age. She's 37. And if I freeze only 5 oocyte, it is not going to be sufficient. There are calculations at what age, how many oocyte you should be having to give her successful birth later. Otherwise, that poor lady will think, oh, I have my eggs frozen, I don't have to bother. But number of 5 eggs at 35 are not important, not sufficient. At the same time, if I'm doing an ovarian tissue, I need to explain it is not the ovarian tissue I'm freezing today. Tomorrow, I need to do the transplant of, and as of now, the studies are very less where the ovarian transplant was done, and then they have done the stimulation and the delivery. So to conclude, in infertility, individualization of each case is important. Tremendous understanding of a pathophysiology of endometriosis is a must if you are handling those patients, especially with infertility. Early reference to the infertility expert helps to avoid the recurrence, and the time interval to the pregnancy may be reduced. If surgery is needed, expertise in the field is mandatory, as the first surgery has to be best surgery to avoid the recurrence and high spontaneous conception after the surgery. Treating endometriosis patient is always challenging, but be thankful for each new challenge, because that builds up your strength, that builds up your character, that builds up your experience over the years. And that's why when you are treating the patient, you need to be updated with all the recent publication from time to time, because then you, by other study, you gain the confidence, you get the experience, and you can help your patient in a better way. I appeal to all those 273 people who have joined. Please consider my candidature for the President Foxy next year. Around August, September, the elections will happen. Help me by voting and support me. Thank you so much. Thank you once again for giving me this golden opportunity to be with you all. Thank you.
Yeah, thank you very much, ma'am. Dr. Sunita madam, as usual, you have given very clear and point-wise presentation on the complicated pathological endometriosis, and stressing on the practical clinical points in treatment of endometriosis, where and how to tailor and individualize the treatment for the lady disease, whether it is an fertility or in a symptomatic relief, or in how it, if she comes in an unmarried stage, and how we have to preserve the fertility in future. In a future when she comes after a marriage. And then you have stressed on the importance of fertility preservation, that is a method. And then you stressed on the newer classifications depending upon the lesions and extensions. The very clear and point wise presentation, madam. Thank you, ma'am. And here is one question from the chat box, madam. How to give dihydrogesterone and how long?
Okay, very nice question. Ideally, they say you might have to give 20 milligram, but dydrogesterone is very expensive. So in my practice for last 20 years, I'm giving 10 milligram tablet once a day. She can take morning, evening, doesn't matter. Dydrogesterone, 1 tablet per day till she conceives, or usually I tell them, try for 6 months. Laparohysteroscopy, I found early endometriosis or just the endometrioma with rest of the pelvis very good. Then I put them on them and I explain them how natural pregnancy happen. It's very important to sit and discuss with this patient how natural pregnancy happen, how valuable is to find the peri-ovulatory period. At the same time, I don't encourage to do LH monitoring to find when the ovulation happen. I tell them if your cycles are 28 to 30 days, you ovulate between 14 to 16 days. So 24 to 48 hours prior and 24 to 48 hours after this window of implantation, try to have at least 3 times relationship. The sperm will be viable for 72 hours, while oocyte will be viable for 12 hours. So you maximize their, it is very important to educate them. We can't just say them, oh, try naturally. When to try is very important. So we explain that. And in 6 months, if she doesn't conceive, then we go either with IUI or with the ART to the patient. So till 6 months, till she comes to me, till her either beta HCG positive or urine pregnancy test positive, or if no pregnancy till 6 months, I continue every day dydrogesterone.
Thank you, Dr. Madhumita.
Yes, ma'am.
Thank you. Wonderful.
Thank you, Sampath Kumari. Thank you so much. It's my honor. Thank you, Dhanalakshmi madam. Thank you, everyone. Revati, madam, I'm seeing you after long. Thank you so much for blessings and giving me an opportunity to be with you all.
Yes, with Sunita's talk, I think everyone can have the lunch in your house. Now we will go to the next session. There is no lunch break. Thank you, Dr. Sunita.
Thank you.
Angela,
Thank you, and thank you, Anjalakshmi madam, and thank you for giving me this great opportunity to share with the legendary faculty person, Dr. Jaideep sir and Dr. Sunita madam, and to share my chair with Dr. Great legendary madam, Dr. Anjalakshmi madam. Thank you, Sampath Kumar.
Thank you, madam. Thank you.
As we're running behind in time, we're not breaking for lunch. So moving on to our session 4, it's my privilege to introduce our chairpersons for this session. Chairperson is Dr. Uma Brinda, who's a Joint Secretary of Tanjavur Obstetrics and Gynecological Society. Our next chairperson is Dr. Agnes Matthew. Next slide, please. Dr. Agnes Matthew.
Madhupita ma'am, go ahead, please.
Dr. Agnes Matthews, a consultant gynecologist at Muvatupuzha, retired HOD and former Dean of MEU. And her passion is the positive health. She has been doing a lot of adolescent work also. Next chairperson. Next is Dr. Poonam Chandramati. She is the director of Sri Chandra Hospital, Karimnagar, professor of ObGyn in Shalmana Medical College, Karimnagar, and practicing for 18 years. Next chairperson is our own Dr. Vidya Prabhakar. She is a president of OG Society Salem and assistant professor KMC Manipal since 2000. And ART training she had at ART training NUH at Singapore, trained in gynae endoscopy. Now she is doing a lot of work with colposcopy with Dr. Priya Ganesh Kumar of Oncology Committee chairperson. Yes, I hand over the mic to the chairperson. First chairperson can introduce Dr. Dhanalakshmi.
I request Dr. Uma Brinda to introduce Dr. Dhanalakshmi.
Dr. Uma, are you there? Dr. Vidya, you can introduce.
Uma madam, kindly unmute yourself, please. Uma Brinda madam, she's available, ma'am. Uma Brinda ma'am, kindly unmute.
Yes, ma'am. Am I audible, ma'am?
Yes, you introduce Dr. Dhanalakshmi. Yes, ma'am. Dr. Uma, you can introduce.
Yes, ma'am. Good afternoon, ma'am. I am very much privileged to introduce Dr. Dhanalakshmi, ma'am. She is a professor and senior consultant in Department of Obstetrics and Gynaecology, Sri Ramachandra University, Chennai. Undergraduate and postgraduate teacher since 1995. And at Ramachandra University, she is a member, UG Curriculum and Faculty Credentiating Committee, organizing chairperson for OG Quest 2016 and 19, and she is a coordinator for webinars, refresh conferences, and basic gynec endoscopy. That's ObGyn. She is the honorary joint secretary in the year 2021, AACOG 2015 chairperson.
Thanks, madam. Thanks, madam. Let
Yes,
me share my
yes,
screen,
ma'am.
madam.
Yes,
Thank you so much for
over
the
to you, ma'am.
introduction.
Ma'am will
Dr.
keep on.
Dhanalakshmi is the
Ma'am will
vibrant
keep on.
secretary of Chennai Society. Yes, back to Dr. Dhana.
Yes, ma'am.
Yeah,
Over to you,
is
ma'am.
my screen seen, pa? Is my screen seen?
Yes, ma'am. Yes, ma'am. Dhana ma'am is.
Yeah. I know for people like who are following me, Dr. Lily, Dr. Tamil Siddi, Dr. Veena, please you can have your lunch as I am sharing this PPT. This PPT is mainly meant for people who just want to brush up their knowledge about POBQ. And let me go ahead to the first one. And at the outset, I want to thank Dr. Lalita Devadasan for letting me use her video, and also Dr. Ajit Virkud for I've taken most of the slides from his YouTube videos. So what is POBQ? It is a quantification system for prolapse. It is an objective one, site-specific system for describing and staging pelvic organ prolapse. It is useful to find the level of defect and plan site-specific repair. And you can, as a surgeon, you can see the POBQ. As a surgeon, you can have a POBQ before the procedure,
the intended procedure or whatever treatment you're going to offer, whether it's a pessary or anything, and then you can compare it with the POBGyn after the treatment is over. And each patient is different, and apart from other considerations, POBGyn helps in decision making. What kind of a surgery you're going to do for the patient. So I'm going to take you through these 5 headings: history about POBGyn, how it came about, and levels of support, and understanding the measurements, and a short video on POBGyn and advantages and limitations. And history, if you can see, in 1996, the standard system of terminology was proposed by Dr. Bump in his article in the American Journal, and it was later approved for description of female pelvic organ prolapse by ICAS, IU, AGS, and SGS, and it goes into a standardized system of pelvic organ prolapse quantification came into being after the article by Abrams et al. So what are the levels of support? The levels of support, we can divide them into 3 supports as per Delancey. The first support is the apical support to the vagina and the cervix, which is given by the uterosacral ligaments and carnal ligaments. So it acts like a hammock. So every time you cough and increase the intra-abdominal pressure, your uterus tends to go down, but this is kept in place by this pericervical ring formed by these 2 ligaments. So when this becomes defective, it ends up in a suspension defect, and the result could be an enterocele or vaginal wall prolapse if the uterus is absent. And the level 2 support is to the middle of the vagina, both anteriorly and posteriorly, and through this arcus tendinous fascia pelvis and arcus tendinous rectovaginalis. And when this becomes defective, you have this attachment defect. So accordingly, you can have a defect in the anterior vaginal wall, which is called as a cystocele, and posteriorly you can have a rectocele. And level 3 support is to the lower part of the vagina. It is through this perineal membrane, perineal body, and the perineal muscles, which the defect of which causes a fusion defect, and the result ends up in a urethrocoele or lax perineum and SUI. One minute, please. So understanding the measurements before going into what is POBGyn, you'll have to know what you're trying to measure. To understand the basics are, the hymen is selected as a reference point rather than the introitus because it's more precisely identified, because the introitus, if it is gaping, we do not know what is the end point. Whereas the hymen is an anatomical structure, even though it is less obvious in the elderly, still you can make bits and pieces of them. And the terminology avoids assigning a specific label. You don't have to label it as a cystocele and rectocele, because you may not, may not be able to clearly differentiate between the rectocele and the rectocele. And 6 points are measured with maximum straining, and 3 measurements are done without straining. And hymen is a fixed plane. This plane is called as 0. So all points which are measured and are above the level of this hymen are given a negative number. All points which have come below this hymen are given a positive number. We will just understand as we go through the next few slides. There are 6 points. One is anteriorly you have point AA and point BA. These are situated on the anterior vaginal wall. This AA represents roughly the area where the uretrovesical junction. This corresponds to level 2 anterior support as suggested by Delancey. And then other 2 points are C and D. C and D are C represents cervix if the uterus is intact. If the uterus has been removed after hysterectomy, C represents the cup of vagina, and D represents the pouch of Douglas. So this represents the level end support as proposed by Delancey. And posteriorly you have another 2 points, AP and BP, and so posteriorly you have AP and BP. On the posterior vaginal wall, again they represent, AP represents kind of an area where the perineal body ends and the rectum starts, and BP is the most dependent or the most prominent portion on the posterior vaginal wall. There are 3 measurements to be made: genital hiatus, perineal body, and total vaginal length. So now with this diagram, I should be able to explain this. Point KT represents the point on the anterior vaginal wall, roughly 3 cm from the external urethral meatus. Okay, so this represents roughly the uretrovesical junction. So this, when there is no prolapse, this point A will be at -3, which means it is 3 centimeter above the level of the hymen. Whereas if there is a prolapse, this point can reach up to +3. So the pendulum swings between -3 to +3. Whereas BA, that is point B on the anterior vaginal wall, represents the most distal point on the anterior vaginal wall, and this is the lowest point of the prolapse between the apex and the point A. That is, apex is represented by the cervix on the anterior vaginal wall. So this is the most prominent point on the anterior vaginal wall. So this can be, if there is no prolapse, this point A will be located in the same area as point A, and so this will be -3, or it can reach up to the total vaginal length. Okay, so total vaginal length in a normal, not a neglected progeria, can be as high as +8 or +10 centimeter. Okay, so this is for the points A and BA, that is on the anterior wall. Whereas when you take the posterior vaginal wall, there are 2 points again, point AP and point BP. AP represents that area, as I already told you. It represents the area where the pineal body ends and the rectum kind of starts. And this also swings between -3 to +3. Okay, so it cannot be more than +3. Whereas the point B is the most distal point measured on the posterior vaginal wall. And this can be, if there is no prolapse, this point B on the posterior vaginal wall can be at -3. Or if there's a prolapse, it can reach and be equal to the length of the total vaginal length, can be from 8 to 10 centimeter. Also neglected prolapse, it can be more than that also. Okay, so you must understand point A oscillates between -3 to +3, whereas point B will depend on how much of prolapses happen. Now point C. What is point C? Point C represents the cervix in an intact uterus. So this will be the leading point in most of the prolapse what we see. And if uterus had been taken off following hysterectomy, the cicatrix or the cuff of vagina forms the leading point. So this is represented as point C. The next point D, it is represents the porch of Douglas, posterior fornix. Represents the level of uterosacral ligament attachment to the posterior cervix. And we must differentiate this, because if the point D is high, but still the cervix is low, then probably we are dealing with a case of intravaginal elongation of cervix. This point D will not be there in your POPQ system if the patient had a hysterectomy, which means the patient had a hysterectomy, total hysterectomy. Okay. Now coming to 3 measurements. Now we saw the 6 measurements which are taken when the patient maximally strains. Okay, these other three measurements out of the 9, we have already dealt with 6. The other 3 measurements are taken when the patient is relaxed. Okay, and these are taken when the patient is relaxing. Gentle hiatus is the middle of the external urethral meatus to the posterior hymen. Total vaginal length is the greatest depth of vagina in centimeter after reducing the prolapse. And the perineal body is the distance between the posterior margin of the gentle hiatus to mid-anal opening. So this, we don't have any reference for perineal body or GH, but generally we know by looking at the patient whether she's having a gaping introitus or not. Now taking measurements. Taking measurements can happen with the something like a pop sticks, which is a dedicated one, or you can have a graduated anti-vaginal wall retractors, or simply a IS spatula which has been calibrated, or in a busy OPD, you can have the measurement of your own fingers, middle finger, index finger, and then you can straight away write, assign the distance or the measurement based on which finger is fitting into that particular defect at the particular point. Apart from measuring this 9 points, we are also 9 measurements. We are also supposed to evaluate the other 3 important muscles, the pivococcygeal aorta of uterine axis at 4 o'clock and 8 o'clock position, then the bulbospongiosis, perineal body, and tone of the anal sphincter. Because with this, we'll be able to give additional, say, a small procedure. Okay, or perineography can be better if you know this before the surgery started. So now coming to this hymen. Is my video running?
Not running, Dana.
Okay, okay. I don't know, it's just not running. I just try it. Yeah.
Madam, is there an audio to
Voice is not.
Is audio seen? I mean, heard? Is audio seen?
Audio is not heard, ma'am. Video is on, but it's a little getting stuck in the middle little.
Dhanamam audio illa.
Audio. Okay, okay. I'll talk then. Okay. So yeah, I'll talk. Okay, I'll talk then. Okay, so this is the hymenal. This is the hymenal ring. Okay, so this is the hymenal ring, but most of the women whom we meet may not have this hymenal ring that well defined. Okay, and this is how we start measuring the various points on the anterior and the posterior vaginal wall. The first measurement to be measured is the point A and the anterior vaginal wall, which is AA, which is measured from the external urethral meatus to a point which is about 3 centimeter from the external urethral meatus. Since this is at 3 centimeter from the external urethral meatus and it is outside the hymen, we put this point A as +3. Okay, the next point that is measured on the anterior vaginal wall is point B, which is otherwise called as BA, and this is the point B, and this is measured from the hymen. Whereas only this alone is measured from the external urethral meatus, rest of it is measured from the hymen. So this is measured and this is found to be roughly +8. Okay, so we already told you any point that is outside the hymen is given a plus. Okay, so it is given a positive number. So we are given a positive number to the point B. Then the next measurement that you're going to make is the posterior wall, that is to the cervix.
Excuse me, ma'am.
Yes.
We have 2 more minutes to go, ma'am.
Yeah. I'll just finish it off. And we have this is a cervix that is measured, which is about 9.5 centimeter. And the next point that we are going to measure is the point A on the posterior vaginal wall, which is roughly around, I'll just brush through, which is roughly 3 centimeter outside the hymenal ring. So it's given a number +3. And then we have this last measurement BP, which is, sorry, the BP is the leading point on the posterior vaginal wall, which is about +8 centimeter from the hymenal ring. And then point D is the distance from the attachment of the infrasternal ligament to the hymenal ring, which is about +6. So once we measure all this, we are supposed to reduce the prolapse and get all the other 3 measurements, which is the dental hiatus, which we already described, and then the perineal body and the total vaginal length. The stages of prolapse, even though we have been following so many other stages so far, this is the one that has been advocated from since 1996 and it's come into force from 2002, even though many of us have not taken to it seriously. Okay, and accordingly, we can have a stage 1 prolapse, which is -1, I mean, that is 1 centimeter above the hymenal ring, whereas -1 to +1 of the hymenal ring will be a stage 2. Anything more than +1 from the hymenal ring, +1 centimeter is a stage 3, and total vaginal eversion is called as a stage 4. Once the measurements are taken, the patients are assigned to the corresponding staging. Stage 0, no prolapse. And whatever I told you now is depicted in this exercise 1. We can just quickly go through the exercises. And what is the diagnosis? You can put in the chat box. So all points AA, BA, AP, and BP are in respective, more or less respective positions. Okay, except it is a stage 0, no prolapse. I'm sorry, it should have been this BA should have been given the wrong this one. Exercise 2. Here, the point A on the anterior aspect is -1. BA has come to +5. So the diagnosis is anterior compartment prolapse. And exercise 3, the diagnosis is posterior compartment prolapse, where the AP and BP are in plus numbers. And this is the fourth one, where the middle compartment prolapse is depicted by the C, which is in +2 station. And this is a diagnosis. You can be sure, like there is no D point, which means we had a hysterectomy. So D point is missing, and the prolapse has descended up to -2, which means it's a post-hysterectomy wall prolapse of stage 1. And this is a prolapse in which the D point is missing, which means there is no uterus. At the same time, the cervix and the total vaginal length are equal, which means there's a total vaginal eventration. So post-hysterectomy, total wall eversion. So we have to know this well in advance so that we can combine the hysterectomy or the repair procedures with some other fixation like a high uterosacral ligament fixation or sacrospinous fixation. The advantages are excellent inter-observer and intra-observer reliability, and we can follow up the women with prolapse and outcome reporting after repair since 1996. And according to conventional classification, all these will be designated as second-degree EV prolapse. We all agree, right? Cervix is at the introitus. So by the conventional method, we will be calling all of these people as a EV prolapse. But just put a POBQ, and what do we get? So here the same POBQ tells you there's a stage 1 posterior vaginal wall prolapse, which means got an entocele with minimal cystocele. And this one has got a stage 3 anterior wall prolapse, moderate cystocele, stage 3 uterine descent, and stage 2 posterior wall prolapse, rectocele and entocele. And this is the patient where there is an intravaginal elongation of cervix with cystocele. So they all look similar when you just looked at them after separating the labia. But then once you put a POBQ, you know, they have to be dealt in differently. The surgeries are different. And to prevent wall prolapse later, this also has to be taken care of. Okay, and the POBQ measurement, even though they are looking the same, both of them look stage 3 and stage 4 prolapse, but then this stage 4 prolapse needs much more processes other than a simple hysterectomy. Okay, it needs a fixation of the wall to the stronger structures like a uterosacral ligament or sacrospinous ligament.
Excuse me, ma'am.
So, yeah,
we're out of time.
Limitations, more difficult to learn than the traditional staging, and does not differentiate between rectocele and enterocele. No normal values for dental hiatus and PB. The reference point is Hymen, which is not seen in most of the multiparous ladies. And this is my request to all of you to practice POBQ in a larger way so that all of us will speak the same language in the long run. Thank you so much, and thanks Sampath for giving me this opportunity, and I thank once again Lalita madam for letting me use her video for my presentation. Thank you.
Wonderful, Dana. Wonderful. Yes, Madhumita.
Thank you so much, ma'am, for the clear and elaborate talk on POBQ. I request our next chairperson, Dr. Agnes Matthew, to introduce our speaker, Dr. Lily Varghese.
Thank you, Madhumita. Because your audio got cut, I was privileged to be introduced by my own good friend, Sampath Kumari madam, who is passionately following all the good things in TNFOG now. Bringing us together, yes, that is the very best thing. And it was an extravaganza of academics so far, 2 days. And all of you sitting there, congratulations. We have our next speaker, Dr. Lily Varghese, Professor and Head of Urogynecology. And I'm really happy to introduce another CMCite because I am from CMC Ludhiana and Madam is from Velu. And you can see she has been passionately following urogynecology with a fellowship from Loyola, Chicago, and also MMC. And having worked for an organization, Freedom from Fistula in South Africa. And her areas of interest are pelvic floor reconstruction, female congenital, genitourinary anomalies, minimally invasive gynecologic surgery. And she is a UG and PG teacher, PG examiner, and has many publications, international, national, and is a book reviewer. Over to you, Lily.
Thank you very much, Dr. Agnes. Thank you, TN, for this opportunity. Dr. Sampath, Dr. Anjalakshi, Dr. Vijayalakshmi, Dr. Dhanam, so many friends, colleagues. It's a great opportunity and a great honor to share space with you here. So maybe I will go on. I have just 15 minutes, and that means time is very brief. So I will go on to share my screen space and share my PowerPoint. Please do tell me if it is, when it is visible. So today, basically, I hope I'm audible. Am I audible?
Yes,
Go ahead, go ahead, go ahead.
And 1 minute, I'll just get it to full screen. Okay, so greetings from my institution. It's a real pleasure to be here. Now, when we call this procedure, we basically call it sometimes a Manchester procedure, sometimes we call it the Fothergill's procedure. And at the bottom line, it's a hystropexy. There's pelvic organ prolapse. And what we are talking is repositioning the uterus in its original place, or as much as possible back to its original supports. So this was without history, nothing can move ahead. So it was first performed by Professor Donnell from Manchester. So it's sometimes called the Manchester procedure. It was described about 20 years later by his colleague, Dr. Fothergill, so also called the Fothergill procedure. Now it's a native tissue repair. I'll come back to a few points over and over again. It conserves reproductive function. Or if a woman so desires, it can just even conserve only menstrual function, because you may do a concurrent sterilization along with this. Now, before we go further, it should be done only in symptomatic prolapse. So a small stage 1 prolapse, a little bulge, no treatment required. Failure of non-surgical treatment in women who desire it, it is a definitive form of therapy, and the indication is in women with pelvic organ prolapse, particularly in women with cervical elongation, stage 2 and 3 prolapse. Stage 4, it may not be so successful unless you add on additional procedures, and particularly in women who prefer to retain their uterus for the sake of fertility. So the original Manchester repair involves the excision of an elongated cervix and approximation of the cardinal ligaments anterior to the cervix. What is the end result of this procedure? The cervix is elevated and posteriorly directed, promoting uterine anteversion and supported at level 1. However, having said that, it is very important for us to get few basic concepts before I go to the videos. Now, this is a picture taken off the net. As you can see, there's the corpus, which is about 5 centimeters. There's a small isthmus, and there is a portion of the cervix we call the portio vaginalis, or the vaginal portion of the cervix. It's not infravaginal because it's not below the vagina, it's within the vagina, the vaginal portion of the cervix. And just above the fornices, the vaginal fornices, up to the os, the internal os, is the supravaginal portion of the cervix. Why is this important? Because invariably in cases of prolapse, there is supravaginal elongation because of the downward drag of the uterus outside into and out of the vagina, while the level 1 supports are trying to hold it back in place. So the modified Manchester procedure for the gills is defined, as we can see, by 3 primary procedures. It may be combined with an anterior vaginal wall prolapse, amputation of the cervix, and posterior vaginal wall repair. You address the levels of support as and where they are needed. But primarily, the Manchester Fothergill's repair deals with a restoration of the level 1 support. Okay, this is a lady, Mrs. R. She was 41 years. She was a nullipara. She had an almost a stage 3, so a large stage 3. She had an almost stage 4. She had a large stage 3 prolapse. but she would not listen even though her AMH was low and her fertility prognosis was very poor. So we decided to go ahead with the Fothergill's procedure because she was really keen on it. Now, all the other prerequisites as for any other pelvic organ prolapse surgery is needed in this case. In this particular case, the uterocervical length was 13 centimeters and the total cervical length was 8 centimeters, predominantly supravaginal elongation. Okay, so here you can see in the video, the quality is not very good because we record it ourselves. So all POQ should be measured as mentioned by Dr. Dhanam. You can see here I'm holding the uterosacral ligaments and point D is marked. Okay, so then we are taking the cervical length and then we take the uterocervical length and we minus the total cervical length from the uterocervical length, which gives us the total cervical length, and this is divided between the supravaginal portion and the vaginal portion of the cervix. Why is this important? Because when you are dealing with amputation of the cervix, you need to retain about 2.5 to 3 centimeters of the cervix if you want the cervix to remain competent. Okay, so now this is a picture which shows the common uterocervical and the cardinal ligament complex. They fuse into one structure very close to the cervix. So it's not possible to discretely say the ligaments apart at this point. And this is the hero of the procedure. So what is a Manchester Fothergill's procedure? It's a hysteropexy using native tissue. You are restoring the level 1 supports where it is first cut. It is detached at this point at the common uterosacral cardinal ligament complex. And then there's a partial low amputation that is done, which is trachelectomy, trying to preserve competence of the cervix. The ligaments are then reattached anteriorly to the cervix in a new location, promoting anteversion and level 1 support. Okay, so this is where we cut and we take it forward and reattach. So the key terms to understanding this procedure, particularly if there are postgraduates and others involved, is very confusing, particularly is something called the Fothergill's point. The other key term is the Fothergill's stitch. And the third term is understanding the Strumdorf stitch. We'll take this one at a time. The Fothergill's points are points which marks out a diamond-shaped area. The cervix is at the center. A is a suburethral point. B and C are points which are on either side of the cervix, which denote the transverse cervicals. And D is a point posterior to the cervix. What does it do? It allows us to assess support points, cervical elongation, and also how much vagina can be excised. Now, this is a video showing you the Fothergill points. So, I'm marking the suburethral point, the point on one side left, the right, and then the posterior, I've actually marked it at the pouch of Douglas, so you are aware of how much cervical elongation is there. Even though we will not be excising the vagina up to point D, I've just marked it in a diamond shape so that you are able to recognize how much of supravaginal elongation is there. This is, I have looped the videos so that you can re-see the videos even as I am talking. So that is point D. And this is marking out the Fothergill's point. Now you will see many videos which tell you you have to remove a diamond shape from above downwards, from below upwards. None of that matters. Remove the redundant vagina as required, but keep an eye on your transverse cervicals. All other steps are very simple and easy as in any other vaginal hysterectomy. So I'm going to start this video, which is a very quick fast-forwarded video. It shows us beginning with the circumcervical. We are circumscribing the cervix, the anterior incision, and we are going on to the posterior incision. Okay, so and then cutting the vesicocervical ligament attachment is cut. The posterior vagina is opened, but the pouch of Douglas is not opened. I'm going only up to where the pouch of Douglas and the uterosacrals are attached. Then I am removing the excess redundant vagina as we would do in any other vaginal procedure, separating the vesicos, pubovesicocervical fascia of the vaginal wall, and that is the vesicocervical ligament. That thing we have retracted the pubovesicocervical fascia with the bladder, isolated the transverse cervicals, and we are now cutting them, clamped, cut, ligated, and we hold these sutures in place because we want to use it subsequently for what we call the fothergill stitch. Now, this is showing just the cut edge of the pubovesicocervical fascia where it is condensed and attached onto the cervix, where it is called the vesicocervical ligament. The pubovesicocervical fascia, which is overlying the bladder, has been pushed upwards and has been replicated in a position that's higher. You can see the two tagged uterosacral cardinal ligament complex sutures, which are taken off the cervix, and you can see the cervix is amputated here. I will show you the video, but I have put in these intermittent images for a better understanding, and because the video is not moving so rapidly that you're not listening to what is being said. So now I'm going forward to this slide, which shows where do you amputate the cervix. So all the pericervical tissue is pushed up. As I said, the pubovesicocervical fascia is resutured higher up. And then you sound the uterus, the uterocervical length, and you sound the cervical length alone from the internal os to the external os, and retain a residual cervix of about 2.5 to 3 centimeters. Since your tissues are on stretch, this is a tip. Take about 3.5 centimeters before you divide it, because when you release your traction on your valsalum or your allus with whatever you're holding the forceps, the cervix will become even shorter. The minimum possible length of cervix to be retained is about 2.5 centimeters. The picture here on the left shows the fothergill stitch. So one can take, it takes one cut ligament, take a deep bite into the anterior portion of the body of the cervix, and take another bite to the opposing transverse cervical ligament complex. This can be tied and then resuspended to the vagina, or a stitch can alternatively be taken from the vagina outside in, transverse cervical ligament, uterus at the level of the isthmus or a little lower, opposite side transverse cervical ligament, and out through the vagina. When one ties this, what happens is the uterus becomes anteverted and it is pulled up because we are shortening and retying the transverse cervical ligaments. So this is the video which will be going, this is, I'm sounding the uterus and we are deciding the length of the cervix to be left behind. As you can see, I am using the cutting mode of the cautery. You can see the amputated cervix. Here you can see the pubovesicocervical ligament is ligated already, replicated higher up. I'm taking a fothergill stitch from one transverse cervical onto the cervix, onto the opposite transverse cervical ligament. Now I am tying it, going to tie it forward. You can see how the cervix is also getting scrunched up in between as we are repositioning this. I'm taking a second stitch to reinforce the first stitch. Now the suture material used can either be Vicryl or PDS in these instances. So I apologize for the quality of the thing, but this is the best we can do with our setup. And this is the whole video is being looped again. So we'll just watch it once more so that you get a clearer idea. The amputation of the cervix, the pubovesicocervical ligament being replicated higher up, transverse cervical ligament, cervix, deep bite into the cervix, and then out to the opposite transverse cervical ligament, tie it in the center, and take sutures. So what do we do? So the cervix is skeletonized, pubovesicocervical fascia reattached higher up, cervix amputated, residual cervical length retained 2.5 to 3 centimeters, fothergill stitch taken. One has to ensure cervical patency by repeatedly passing the cervical dilator to prevent any form of cryptomenorrhea, iatrogenic cryptomenorrhea.
Excuse me, ma'am. We have 2 more minutes, ma'am.
Yes, the next important one is the Strumdorf suture, which is a re-epithelialization of the cervix. Since you've denuded the cervix, A strummed off suture can be taken in various methods, as you have seen here, various modifications. One does not even need to invaginate the vagina into the cervical canal. So here I am doing a strummed off suture. As you can see, I am taking the anterior vagina and we are replicating it. We are recovering the raw cervix and reforming a new cervix. So as you can see here, I'm taking the vaginal flaps separately and covering the raw cervical area. And the cervical canal patency will be recorded. You should ensure cervical patency to ensure egress of menstrual discharge. Now, there's a lot of shake. The anterior vaginal wall is done. The posterior cervix is covered, and then the lateral stitches are taken. Fast forwarding it a bit, sorry, because we are running short of time. And then at the end of it, what you see is this is the cervix. I am now releasing the traction on the cervix. And as you can see, the uterus is slowly retracting back. Once the effect of anesthesia goes, the uterus will be further carried higher up. And once postoperative fibrosis takes place, what happens is the support is even better. So the pelvic support principles include all standard procedural steps, which include an esophageal surgery, amputation of a hypertrophied cervix, re-establishment of uterine anteversion, re-establishment of uterine supports, and anterior and posterior colporrhaphy as the requirement may be. So it is a revival of a historic technique using autologous fascia, and the alternatives are a vaginal sacrospinous hystropexy, mesh, or tissue slings. However, there is a big question mark on all these mesh procedures. So it is preferable to learn how to do the Fothergill's procedure, particularly in lesser stages of pelvic organ prolapse. What about its effect on fertility? Decreased fertility and increased rates of pregnancy loss have been noted. Fertility rates are reduced in the range of 21 to 33% because of interference with cervical mucus or a very short cervix. Most experts recommend a cesarean delivery in the event pregnancy occurs. The failure rate has been found in many recent studies to be equal to that of a vaginal hysterectomy and a routine pelvic floor repair. As this quote says, life is a classroom. Only those who are willing to be lifelong learners can move not just to the head of the class, but can continue to provide good care for the patients who trust us so implicitly with their health and their bodies. Thank you once more, TNFOG and all the associated bodies. Thank you very much for this academic opportunity and the sharing of this platform. We continue to learn on every single day and in every single day. Thank you very much.
Thank you, Dr. Lily. In spite of your family function, you managed to. Thank you.
Thank you, madam. Thank you very much.
Thank you, Dr. Lily. It was very nice, very nicely put and very short and very clearly shown. Your videos are good. Thank you.
Oh, thank you, madam. I'm really embarrassed by its quality. Thank you, everybody.
Thank you very much, ma'am. Moving on to our next talk, I invite Dr. Poonam Chandramati to introduce our next speaker, Dr. Tamil Selvi.
Thank you, Dr. Madhumita. And I also thank the team for the organizers and Dr. Sampath Kumari ma'am for giving me this opportunity to introduce, include me in this webinar. I feel privileged to introduce Dr. Tamil Selvi ma'am, who is an FRCOG from UK. She has done her undergraduate and postgraduate education in Madras Medical College with a specialist registrar training CCST London degree, and has done a clinical fellowship in urogynecology, UK. Her current post is the senior consultant urogynecologist and pelvic floor surgeon in Madras Medical Mission Hospital in Mangai, WHE, Chennai. She is editor of Principles and Practice of Urogynecology and co-editor of Ambulatory Urology and Urogynecology textbook. She has given several publications in peer-reviewed journals and chapters textbooks. Presentations are invited in several forums. She is member of IUGA, URP SSI, OG SSI, AOGIN, and RCOG. The areas of interest is creation and implementation skills, training and obstetrics academic training of junior doctors. She is a course convener for MRCOG 2 and 3 exam and part 3 MRCOG exam. She is international she is one of the member of International Representative Committee, RCOG CZ Fellowship Representative and Secretary of Chennai Menopause Society. I welcome Dr. Tamil Selvi ma'am to deliver her speech.
Thank you so much. Would like to apologize if there is any Hello, can you hear me?
Yes, madam. I think the signal is a bit weak.
Okay. I think the signal might be a bit weak because greetings from Mumbai airport. I'm actually sitting in the airport and talking with you guys. So that's the reason the signal is a bit weak. And thank you organizers and thank you chairpersons for the introduction. And I'm going to be talking today on prevention of wall prolapse. Now, the only reason I chose on wall prolapse to talk on prevention is this is something which every gynecologist, starting from the junior colleagues to the senior colleagues, can actually start practicing right from tomorrow. So that is the reason I thought we can start with prevention of wall prolapse. Next slide, please. And I would like to thank Priya for actually sharing the slide on my behalf. So I will be saying next after each slide. So the incidence of wall prolapse is quite high. It can be even up to 43%. And the need for repeat surgery in cases of a wall prolapse is up to 10%. Next, please. Next slide. So if you're wondering what actually happens after hysterectomy, is the wall prolapse more common after abdominal or a vaginal hysterectomy? The evidence actually shows that it occurs in equal numbers after abdominal vaginal hysterectomy when the indication for the hysterectomy is non-prolapse. So any other surgery where you do it for a fibroid or for a DUB, either you choose abdominal or the incidence of wall prolapse is equal. But whereas when you do a hysterectomy for prolapse, the incidence of wall prolapse is 11.6%, and the following other indications is only around 2% risk. Next, please. Next slide. Next slide. Previous slide, please.
Yeah, previous slide.
Previous slide. Taken out the animation and I actually, yeah, that's it. That's fine. So when you look at the pathophysiology of a wall prolapse, what basically happens is at the end of a surgery, we actually approximate both the vaginal walls, and those vaginal walls are just lying down in the vagina. The vaginal walls have to be prevented from coming down, need to be reattached to the uterosacral ligaments, as you can see on the picture on the right hand side, on the left hand side of the screen. Now, only if it is reattached to the uterosacral ligament, then the vault will not come down. That is the basic principle in wall prolapse prevention. Next, please. So what do we normally do when we close the vagina? Several people have different techniques. Some just approximate the vaginal wall. Some approximate the peritoneum of the cul-de-sac and then approximate the vaginal wall. Some fix the uterosacral ligament to the wall and actually close the wall. And then some do a McCall scaldoplasty. Out of this, if you think of the basic principle, by just closing the vaginal wall or closing the peritoneum is possibly not going to do any help in preventing wall prolapse. It's only when the uterosacral ligament is actually fixed to the wall, only then the vault is prevented from coming down. Next slide, please. Priya, next slide. Next slide, please.
And I'm already next slide only, ma'am. Please.
Okay, fine. So this is the anatomical supports. The anatomical supports, as you can see, it's a continuous fascial support which condenses to form ligaments. So what the uterosacral ligament is holding is the lower portion of the cervix and the upper portion of the vagina prior to hysterectomy. And after hysterectomy, it is supposed to hold the upper portion of the vagina. But unfortunately, if we don't do the approximation, then there is a high incidence of wall prolapse. Next, please. So the easiest way in actually we can prevent wall prolapse irrespective of whether we're doing an abdominal, vaginal, robotic or laparoscopic hysterectomy is the McCall's scaldoplasty. And that is the procedure I'm going to take you through. So in the original description, there was an internal McCall and then external McCall. In the internal McCall, the peritoneum between the uterosacral ligaments are actually approximated in the midline, bringing the uterosacral ligaments together. In the external McCalls, the actual suture starts from the lateral angle of the vagina, goes through the uterosacral ligament, takes the peritoneum in a purse string manner from the 3 o'clock to the 9 o'clock position. At the 9 o'clock position, it secures the uterosacral ligament onto one side and comes out through the vaginal wall. So which means the vaginal wall is attached to the uterosacral ligament. Next, please keep going. So what happens is when you actually pull through the uterosacral, the stitch, the uterosacral ligaments are pull up the vaginal wall upwards. Can you click, please? It will play a video. So this is internal McCall. Internal in the internal McCall, you are actually basically there is a lot of noise. You just go from one end of the peritoneum to the other end of the peritoneum in the midline. You can run it fast. Yeah. Keep running it fast. So you can see how the needle goes from one side to the other. Actually, the vaginal wall was secured as well. Keep going. Then let's move over to the next one. I think we have actually demonstrated the internal. Can we move over to the next slide, please? There'll be another video. That is the external McCalls, which I would like you to watch carefully. That is basically a series of pictures I put through a video. So you basically come through the vaginal wall, take the uterosacral ligament and go along the vagina. You can see the peritoneum, go along the peritoneum, come out through the other side uterosacral ligament, and then on to the vaginal wall. So basically from inside to outside, and then you secure it. So when you do that, that will actually show you both the vaginal wall and the uterosacral ligament towards the sacrum. And that is the basic principle. So if everyone starts doing this, the incidence of wall prolapse will definitely come down. By how much? And we have evidence for that. Next slide, please. So the evidence shows basically if you do a McCall suture, the incidence of wall prolapse comes down from 10 to 20% to actually 5 to 6%, and that is the evidence. So when you do a hysterectomy via the abdominal route, can you actually do it? Yes, you can. If you think of it, you approximate the uterosacral, you do take a pedicle of uterosacral ligaments on either side at the level of the vault. So when you actually close the vault, if you incorporate the uterosacral ligament onto the vault and you elevate it, approximate it along with the peritoneum, the vault gets secured to the uterosacral ligament. Next slide, please. And this video is actually the laparoscopic video, which shows, can you play it, Priya? So this actually shows that the through laparoscope that you do it, how exactly it works. So when you do it with the laparoscope, the same principle. As you can see, this is a very old video, so the quality might not be that good. So if you take the uterosacral ligament on either side, and then you keep coming through, this is a long video, you can keep moving, you won't miss anything, Priya, just keep moving until we reach the end of it. You can see that, the purse string manner where it comes. Yeah, keep going. So, and then you reach the opposite side. So, and then you tie it together. So as you can see, it is basically a simple procedure. It just takes extra 2 to 3 minutes for us to do this. If we start doing this in all hysterectomies, then we can prevent wall prolapse. So this is the evidence. At the end of 5 years follow-up, there is a 3 years follow-up. Patients who underwent McCall's procedure at a significantly lower incidence of prolapse. Next slide, please. So this is for patients whom we are doing hysterectomy for benign conditions. And I already told you when you do prolapse surgeries, the incidence of wall prolapse is slightly higher. So what do you do to prevent wall prolapse in that group of patients? Next slide, please. In that group of patients, either you can do a vaginal procedure or an abdominal procedure. And the vaginal procedure is your tight-tested sacrospinal fixation or a high uterosacral ligament suspension. Abdominally, you can do a sacrocolpopexy. Next, please. So we know in abdominal sacrocolpopexy is the gold standard. So the abdominal sacrocolpopexy, you attach the wall to the anterior longitudinal ligament of the sacrum. So that is the best part of it. So that is the wall is attached to the anterior longitudinal ligament of the sacrum. Next, please. So the cure rate in that is more than 90% and the vaginal length is preserved. And the only complication you should be worried about is the mesh erosion, which happens in only 2 to 10%. And this is one of the indications where mesh is agreed to be used by all bodies is the abdominal sacrocolpopexy. Next, please. So the procedure, very importantly, for those of you who are willing to learn, it's a vaginal procedure and the rectal pillar has to be divided. It's a combination of sharp and dissection, please. And the uterus and the sacrospinous ligament have to be identified. And I usually recommend those who are learning, please have a look at the sacrospinous ligament. Just don't feel for the sacrospinous ligament. Next, please. Next, please. Yeah. So you attach it to the sacrospinous ligament medial to the ischial spine. So the wall does that. That's fine. No, that's all right. So it is highly effective. The only side effect of it is there is a higher strain on the posterior compartment. So what happens is the anterior compartment starts to sag down. So the recurrence of cystocele is more common in this group of patients. Next, please. And the next one is the high uterosacral ligament suspension, where the vault is attached to the uterosacral ligament on either side, the sutures being placed medial and cephalic to the ischial spine. So basically, it pulls the vaginal wall higher up towards the uterosacral ligament. Technically challenging to learn. Next, please. And more challenging is the fact that there is 11% risk of ureteric injury. So when there is risk of ureteric injury, anyone who's learning to do this procedure should learn to do cystoscopy and to identify the ureteric injury and to take necessary precautions to actually overcome this difficulty. Next, please. So cystoscopy is a mandatory requirement for all gynecologists. Every gynecologist should learn to do a cystoscopy, not only just for the sake of doing high uterosacral ligament suspension, it also becomes useful in all cases of both vaginal and abdominal surgery. But this is vaginally, this is the gold standard technique for prevention of wall prolapse, and it should be learned under supervision, and at least 10 cases should be done under supervision before we actually move on to do it individually. Next, please. So what is the procedure of choice? We said abdominal sacrocolpopexy, you did sacrospinous fixation, and then you actually talked about uterosacral ligament suspension. What is the procedure of choice? So we need to know what is the normal vaginal axis. The normal vaginal axis is shown in the picture. Anything which mimics the normal vaginal axis is the procedure of choice. So as you can see in vaginal sacrospinous fixation, the axis is tilted, which means cystocele recurrence is higher, whereas in abdominal sacrocolpopexy, the procedure of choice, the vaginal axis is actually maintained very well. Next, please. So whatever you would like to do, either a uterosacral ligament, SSF, or abdominal sacrocolpopexy. So you need to know the anatomical and functional outcomes of each of this. Sacrospinous ligament has a high cure rate with moderate rate of anterior wall recurrence. Uterosacral ligament has a high cure rate with increased ureteral compromise. Next, please. So in conclusion, the suspension of the apex by appropriate meticulous technique should be considered at the time of each hysterectomy in those without prolapse, a simple McCall's scaldoplasty should be practiced by all gynecologists. And removal of uterus does not restore the anatomy. We need to understand that, and the aim is to provide a durable procedure with less morbidity to the patients, so that the recurrence of another surgery can be reduced. Thank you, organizers, and sorry about all the disturbances around me. Thank you.
Thank you so much, ma'am, for the elaborate discussion on wall prolapse. It was really informative to see the videos and hear you talk. Moving on to
the airport, Madhumita.
Ma'am?
That too from the
Yes,
airport.
ma'am. Yes, ma'am. That shows your enthusiasm, ma'am. Thank you so much for being with us today. Thank you, ma'am.
Thank you, Tamil.
Thank you, madam. Thank you so much.
Yes, Madhumita.
So, yes, ma'am. So moving on to our next awaited very interesting session. It is a debate about carbetocin versus oxytocin. So for this, I request Dr. Vidya Prabhagar, ma'am, to invite our judge, Dr. Revati Janakiraman.
Saita, kindly unmute all the videos because the faculty is not able to unmute.
Okay, okay.
Vidya, ma'am?
TV podungappa.
I think
Dr. Revati Janakiraman. All of us know Madam. Madam is the founder secretary of Madurai OG Society, president of IMS Madurai chapter, president of Madurai chapter of TAPISAR, and vice president of TNFOG, and recipient of Foxy Dr. Durusha Community Services Award, recipient of Lifetime Achievement Award, and master trainer for PPIUCD, FICO, and Foxy, author of Foxy Focus Amniotic Fluid, and she has written many chapters in Foxy Focus and Foxy Books. Madam was the retired director of Institute of Obstetrics and Gynaecology. Yes, Revati. Yes, Priya, sorry. And the debaters are Dr. Niranjana Ashokan, assistant professor in Panimalar Medical College, fellow in gynae endoscopy. She has awards of best paper in South Zone Niva Foxy, winner in Obstetrics, and Amarendra Nath Dawn Prize at ACOG 2019, and the Mangalam Kasirajan Gold Medal, that is a prestigious medal from our own Foxy, and Dr. C.S. Dawn Prize, ACOG 2020 Indo. And our next
Ma'am, Revati ma'am is there, ma'am.
That is why I said video is not opening.
Ma'am, எல்லாரும் open ஆயிடுச்சு ma'am இப்போ.
எனக்கு ஆகல இன்னும். I am trying, but I am not able to. Just now it got. Okay, thank you. So we have got two nice youngsters to fight on whether to use carbetocin or oxytocin. First is Dr. Niranjana, daughter of Dr. Sampath Kumari. And the second one is Aditi Natkarni, who is the director of Ivacare Fertility Center, Vapi. And she's also director Natkarni's Medical Training Academy, and she has trained more than 1,200 delegates from all over the world, and was a past president of Vapi ObGyn Society. And she has to create more than 3,000 IVF babies to couples hailing from India and also abroad. So I hand over the mic to the competitors, like first to Niranjana to talk on carbetocin.
Regarding the flow of events of the debate, we have 12 minutes for each speaker. And then once the second speaker is done, 2 more minutes for the first speaker to revert, and then 4 minutes for the judge's opinion. Thank you. Over to you, Dr. Niranjana.
Thank you so much, ma'am. First, I'd like to thank the organizers for giving me this opportunity.
Make it slideshow, Niranjana.
Yeah. So, moving on to the topic. The topic given to me is carbetocin versus oxytocin. It's actually a debate between two really very strong drugs, and I'm going to be advocating for carbetocin. So, before moving on to the pros and cons of each drug, first a little intro about what is carbetocin. Carbetocin has been in use for the past 2 decades and is available in India of late. It's a long-acting synthetic analog of oxytocin. There have been some modifications made to the structure of the carbetocin from oxytocin, which makes it resistant to cleavage by the aminopeptidase and the disulfide. Because of this change in structure, carbetocin has an enhanced stability compared to oxytocin, and it also has a longer duration of action. The next difference between carbetocin and oxytocin is it has lower affinity for the vasopressin receptors. So because of this, it's not going to have the complications related to the fluid retention or water intoxication that can be encountered with the oxytocin. The next most important point with carbetocin is it has a rapid onset of action. The action begins within 1 to 2 minutes of injection, and if the duration of action is prolonged, it can act as long as about 1 hour after the injection. So the studies have found that 1 dose of carbetocin can act for a duration comparable with about 16 hours of infusion of oxytocin. That means instead of putting a patient on an infusion for 16 hours and keeping her with the monitor on the bed, we can give her 1 dose of carbetocin and have the same effect. Next, in terms of safety profile, they have said it's comparable to oxytocin. So how does this drug act? It acts through the same oxytocin receptor, but because of its long duration of action and rapid onset of the action, it's going to cause rhythmic contractions of the uterus straight away, which are going to be increased in frequency and increased in tone. And these contractions are going to persist for a longer duration. So because the contraction is going to be for a longer duration, the control of PPH, the control of bleeding by the myometrial ligatures are going to be more effective compared to oxytocin. So why are we talking about the drugs? It's because they are used to treat the condition PPH. PPH is a nightmare for every obstetrician because we cannot predict which patient is going to end up with PPH. Even a low-risk patient whom we consider is going to deliver without any issue can end up with a postpartum hemorrhage. And when this condition occurs, it's not just the patient. She's going to have an increase in the hospital stay. There's going to be mortality, morbidity, and in the family, the entire family. If she has a kid, husband, everybody is going to be affected. Not just the patient, even the doctor. Till the patient's bleeding settles down, we use every resource that is available to us to make sure the PPH settles down and the patient is back to normal. The patient's bleeding care gets to normal, but the doctor's BP takes a little longer to come back to normal. So if we have a drug that can make this condition a little more manageable, why not go for it? So if you are going to see the cause of PPH, the most common cause is stool. And because of this, earlier while we were having expected management, we started recommending for active management. And there are a number of uterotonics that have been available, like the oxytocin, misoprostol, ergometrin, carboplatin. All these drugs have varied mechanism of action and varied duration of action. But invariably, all these drugs also have concerns. Oxytocin, it requires to be stored between 2 to 8 degrees Celsius. As I said earlier, it has a very short half-life. So it requires multiple dosing. And it is not selective for the vasopressin receptors. So it's also having a problem of water intoxication. And the next thing is we use oxytocin for induction and augmentation of labor. So prolonged use of oxytocin during labor desensitizes the oxytocin receptors, and it itself can lead the uterus to uterine atony. The next drug we have ergometrin, that is also requiring special storage conditions about 2 to 8 degrees Celsius. We cannot give it for patients who have heart diseases, who have hypertension, and the drug itself can cause nausea and vomiting. Misoprostol. The one good thing with misoprostol is it doesn't require the cold storage, but it can cause shivering and pyrexia. The other thing with misoprostol is it doesn't require a skilled health personnel. So if there is nobody available to give an injection, misoprostol becomes a drug of choice. And the next carboplatin, that also requires a storage at 2 to 8 degrees Celsius, and it cannot be given for women with bronchial asthma, and because it causes bronchospasm. So moving to the drug in question here, oxytocin. So from the manufacturer to the patient, the drug is going to have multiple levels of transport, procurement, storage, and everything. So at all levels, we need to ensure that the cold chain is maintained. But if the cold chain is not maintained, the drug is not going to be effective. Studies have found that about 46 to 74% of vials of oxytocin have not passed the quality test. Many studies in India have shown that because of exposure to the heat and degradation, the active ingredients available in oxytocin are very much lesser. That means if you're not going to have the active ingredient, the effect of oxytocin is going to be very less, and it's not going to be very effective in terms of preventing the PPH, which is why we are going to administer it. So, not just this cold storage. Oxytocin has other drawbacks as well. It has the antidiuretic effect and can lead on to water intoxication. It requires multiple doses, as I said earlier, because it is short acting. And if the cold cold storage is not maintained and the drug is not effective, it will lead to failure of the prophylaxis. It also has stability and quality issues. So if you have all these conditions, and now oxytocin is a very important drug because all of us are following active management of third stage. So if we are going to have these issues, it's time we go for an upgrade. And what better when we have this carbetocin? So how does this carbetocin improve us? Now we have the heat stable formulation that is stable at the room temperature. It is the same drug but with a different excipient. So because it's stable at room temperature, it does not require the cold chain maintenance or it does not have the storage issue. It can be having a shelf life of about 36 months at room temperature as against oxytocin, which cannot be stable outside of the temperature between 2 to 8 degrees Celsius. So because of this nature, we can store this carbetocin anywhere. We need not rush to the refrigerator, make sure if the patient is throwing a PPH, rush and get the drug. The next problem is even if we are storing it in a refrigerator with all management, every time a delivery is happening, we are not going to go take one vial of oxytocin and go back for the other vial. We are going to take the bunch as such, use and put it back. So when we are going to use it when the drug is going to be outside for longer duration, obviously the cold storage is going to be affected. Well, in that case, when we use a carbetocin, we can keep it outside. We need not be like very cautious of whether it's kept back or not because the drug is going to be stable. So it's going to be very active. It's going to have an onset of action within 2 minutes with a duration of action about 60 minutes, and it can be given as a 100 microgram dose, either IM or IV. So as I said earlier, when compared to oxytocin, this drug is long acting, so we need not give a prolonged infusion or multiple doses. A single dose is sufficient. And it is a well-established dose because guidelines have proven that it can be used for prevention of PPH. It does not have affinity to the vasopressin receptor, so it is not going to cause water intoxication, and it causes less blood loss and no cold chain storage. So with all this, I can say that my point is made, carbetocin is indeed a better drug, but we need evidence, right? So moving on to these trials. These trials have started from as early as 2012. That means for the past 10 years, people have been using carbetocin and proven the safety profile of the drug. This Cochrane study evaluated 11 studies and found that carbetocin had a significant reduction in the need of additional uterotonics as compared to oxytocin. There was reduced need of uterine massage and decrease of nausea, vomiting as compared to symptometry. This study used carbetocin versus oxytocin in cesarean and found that although there was no difference in blood loss, carbetocin gave a better uterine count and no water intoxication. There was no additional uterotonic requirement as compared to 23.5% requirement in the oxytocin group. This study used carbetocin with vaginal delivery, and they said that it is a good alternative to oxytocin in active management of third stage of labor after vaginal delivery. So not just in the management of PPH, carbetocin is also used for active management and prevention of PPH. In this study, compared 196 studies, a very large study, and they found that 3 combinations are effective for preventing PPH of 500 ml. That is ergometrin oxytocin, carbetocin, and misoprostol oxytocin. Yes, they did say that ergometrin oxytocin had a better profile compared to carbetocin. The relative risk was only 0.69 in this combination, 0.72 in carbetocin, and 0.73 in misoprostol oxytocin. For the side effect profile, when you use a combination of drugs, you're going to expose the patient to the side effect of both drugs. So comparison on every term, all these 3 drugs had a similar profile. So instead of going for 2 drugs, if you are going to go for 1 drug, you can definitely use carbetocin because it's going to reduce your PPH, reduce your blood loss, reduce your need for additional drugs, and make sure the patient is fine. Symptometrin has been shown effective in this study. But the problem is symptometrin causes severe adverse effects like nausea and vomiting. So the patient in the initial 2 hours when she's supposed to bond with the baby, she's going to be throwing up and feeling uncomfortable. So we are going to lose that time. So when we use carbetocin, we are going to counter those adverse effects. So I was saying all adverse effect. This study evaluated the adverse effects and they found that carbetocin had a lesser, if not or similar to oxytocin, the side effect profile. It was not more than oxytocin. And this
one more minute, Dr. Niranjana. You have 1 more minute.
Carbetocin with oxytocin, and they proved that it was non-inferior. They didn't say it was superior to oxytocin, but in terms of side effect profile and everything, it was on par with oxytocin. So proving by all this, if cold chain is not available, carbetocin can be the drug of choice. The next thing my speaker might say is cost. Yes, it is indeed costlier than oxytocin. But if you take the use of additional drugs, stay, blood transfusion, the overall cost of carbetocin is not going to be much more than what the patient will pay if she's going to use an oxytocin. Multiple studies have been done even in low resource countries like Peru and low socioeconomic status, and they've all proven that the overall cost effectiveness with carbetocin for prevention of PPH is good and it can be given. And not just that, the WHO has included it in the essential medicines and they have recommended use of carbetocin for all births when the cost is comparable. When we start using it as a public sector, the cost economy is also going to come down and the patient will be able to have better benefits with carbetocin, not just look about the cost. So the FIGO also recommends use of carbetocin, and the Canada guidelines have started using carbetocin as a first-line nutrotonic at cesarean because it's a risk factor in itself, and vaginal delivery with one risk factor. So going by all these guidelines, whatever I said, carbetocin is indeed superior to every drug available as nutrotonic. If not superior, it's at least on par with them with a lesser side effect profile. It can be used in women with heart disease. It can be used in women with severe preeclampsia. It can be used in low resource settings where the cold chain storage cannot be maintained. All these proves that carbetocin is indeed a wonder drug. Well, I'd like to conclude saying that earlier, this was how we were conducting deliveries. But now we have the birthing suites where there is so many facilities available. If we are going to look at cost and everything as the only factor, we'll have to get back to these modes. But we are not doing that because we look for the comfort of the patient and we look labor as an experience for the mother. So if we are going to give a good labor for the mother as well as the doctor, it's time we go for a change. Because if we don't change, we might lose a chance to improve the outcome. So we can try carbetocin for prevention of PPH as well as for management of PPH in place of oxytocin and see how it works. Thank you.
Okay. Good, Dr. Niranjana. You have enumerated all the benefits of carbetocin. Now, Dr. Aditi, how are you going to answer her and support oxytocin? Aditi, please. You please start sharing your slides.
Good afternoon, everyone. At the outset, I would like to thank all my seniors, all professors here for giving me this opportunity. And today, I'm going to speak on oxytocin. Dr. Niranjana, you were very good. And nowadays, everybody speak about carbetocin, and everybody loves this drug carbetocin. It is something which is a new kid on the block, but I would like to speak on oxytocin. So oxytocin, it has been derived from the term quick and childbirth. It is a cyclic nonapeptide that differs from vasopressin by only 2
Aditi,
amino
go to
acids.
slideshow. Aditi, go to slideshow.
Yes, ma'am. Slideshow. Yes, ma'am, I'm in slideshow itself.
No, Aditi.
Full screen.
Yes. Okay, ma'am.
No, it's not yet. You have to bring it full screen.
The slideshow button is in the bottom.
There's the lower down on the right side.
Yes.
There you go. Click on that, you'll get it.
The same button that you clicked just now. Just
Yes. Okay. Yeah. So it's essentially its role in milk ejection, and it also has facilitatory effects in initiation of labor and parturition. So it has multiple effects. So anterior pituitary, posterior pituitary. So oxytocin, basically, it is a product of paraventricular nuclei, and then both these hormones, they are synthesized in the hypothalamus, and then they simply get emptied into the posterior capillaries, from where they are drained into the systemic circulation. So it's also oxytocin. It's a posterior pituitary hormone which is secreted by the gland posterior pituitary, and it occurs by sensory stimulation from cervix, vagina, and from suckling of the breast. So the absorption, metabolism, and excretion, it is not effective orally. It has to be administered intravenously or intramuscularly. It also can be given as a nasal spray. It is not bound to plasma proteins. It's catabolized by the liver and the kidneys. And of course, the half-life is just 5 minutes. It stimulates both frequencies and forces of the uterine contractility, particularly of the fundus segment of the uterus. These contractions will resemble the normal physiological contractions of the uterus, that is contractions followed by relaxation. An immature uterus is not it is resistant to oxytocin, so contraction of the uterine smooth muscles is only at term.
Sorry to interfere, Aditi, your slide is not moving. You have to go to the full screen and then start moving the slides also. That's not moving at all. It's stuck at second slide itself.
Okay. Now, ma'am, it's okay?
No, Aditi, next to 74% you have a cup-like signal, no? At the below.
Yes, ma'am.
Bottom.
Yes,
70.
yes. I put that.
That you click it again. That you click it.
Now is it working?
No, no. Some problem with your slide.
Not it. No, she is not clicking the proper icon.
Aditi, you go above, there is animations, next is slideshow. You go above, design, transitions, animations, top slideshow, review, view.
Just above that, no.
Yes,
the top you have now inserted, design, transition, animation, next is slideshow.
Slideshow, you can.
Now it's okay.
Click that.
Right at the top.
Yeah.
On top, you can see home, right? You can see home, right? On top, next to file.
The same
that
line,
just
you go
to animations.
Same line you go. Move.
Okay.
That's the little above. You can see the slideshow, no?
Yes.
You click on this.
Yes.
Yeah, exactly.
Yeah.
Click on that.
Yeah, clicked it, ma'am.
Give a click, ma.
It is clicked, ma'am. Now it is okay. Now it's okay, ma'am.
After that, you come to current slide.
Current slide.
See the two pictures.
Slideshow.
Yes.
Then
Okay, ma'am.
No, you have not clicked current slide. Current slide is just again below the file, the second one. Yeah, I can see your cursor. Just go up little to your left, not to the right.
To the left.
Yeah.
Come to the left.
Yes.
No, all the way. Second from left.
Second from left. From left.
Yes.
Okay, ma'am.
Yes, click.
Yeah. Okay. Click. Now is it okay, ma'am?
No.
Aditi, you proceed. It is not coming. Yes, you proceed.
Okay. Is it seen, ma'am?
It's seen, but you have to move the slides one by one. Okay.
Okay. So the pharmacokinetics I have already said. So these contractions, they resemble the normal physiological contractions of the uterus. So clinically, oxytocin is given only when the cervix is soft and dilated. The mechanism of action is interaction of endogenous or administered oxytocin with myometrial cell membrane receptors, which promotes the influx of calcium from extracellular fluids and from SR into the cell. So this will increase in the cytoplasmic calcium and which will stimulate the uterine contractions. So these are the few therapeutic uses which we all know. We give induction and augmentation by mild preeclampsia, uterine inertias, in incomplete abortions, post-maturity, maternal diabetes. So it has multiple uses, and of course it is also used in therapeutic IV drip by in case of postpartum uterine hemorrhage. So in India we have a lot of oxytocin and it is freely available, and the cost wise is also it is freely available, and it can be used in small setups, in small hospitals, in small cities, in small villages. It is available everywhere. So we all know the global burden, which Dr. Niranjana has already told. So 99% of all maternal deaths, they occur in low and middle income countries. So in such low and middle income countries, maybe the newer drug may or may not be available, and it may not be easily available and not easily seen. So PPH is the leading cause of maternal death, and it is seen. So these were the new findings on nutrotonics for PPH prevention. So Cochrane systemic review and network meta-analysis compared all the uterotonic options. So they were compared with oxytocin. So oxytocin was the main drug which was there. So in the light of this new evidence, the WHO also had recommendations, and they were updated in 2018. So this was what worked was basically efficacy and safety. Safety was an important aspect. And choice of uterotonics for PPH prevention was uterotonic options versus other uterotonic options. So one side there was oxytocin, and rest other side were the other drugs. So these were the different drugs which were useful and which were studied. So let me speak about oxytocin. Use of oxytocin, it was recommended for the prevention of PPH for all births, that is vaginal birth or cesarean section. Skilled health personnel required at cesarean section. Consider dividing the doses and avoid a rapid IV bolus. So that was according to oxytocin. Coming to carbetocin, again, it was for only PPH prevention only. So for other things like other things which we needed from other indications point of view, you could not use carbetocin for any other aspect or any other indication. So coming to oxytocin, oxytocin can be used with any other drug combination, that is with oxytocin and ergometrin, which they showed that was much better with a fixed dose combination. It was recommended for prevention of PPH in context where hypertensive disorders could be safely excluded in vaginal birth or cesarean births and in skilled health personnel. So how do we compare uterotonics to one another? Comparing, oxytocin is the current standard of care, which has the largest number of trials in the network meta-analysis. So it is the king, it is the saliva. So the natural sequence for introducing a new uterotonic option is to evaluate the efficacy with the gold standard option. So these are the different things under which we had to check the other options. So oxytocin was the, it had different desirable outcomes like the maternal deaths, PPH, blood transfusion, etc. and all the other things, and compared to other aspects of the other drugs. So these criteria were considered by GDC for each uterotonic options. So as you see, oxytocin was the reference. It was the reference comparator. So according to oxytocin, the other things were compared. So you could realize that oxytocin is such an important medicine that according to it is other things are compared. So accordingly, there was no clear difference or undesirable effects, while the balance of effects probably favors, of course, carbetocin. But yes, I will be coming to carbetocin. What were the problems associated with carbetocin? It's not a green or a rosy picture every time. Of course, misoprostol plus oxytocin also could be compared to oxytocin. So that's what I said. Oxytocin is a very benign, medication, and it can gel with any other medication. Unlike carbetocin, which they say once you give carbetocin, you cannot give anything else. So that was one, thing which we were all scared about. That carbetocin, after giving carbetocin, that is the end thing. You cannot give much of anything else. So in settings where oxytocin is unavailable or its quality cannot be guaranteed, yes, of course, you may have to give some other things. And coming to, so these were the implementing updated WHO recommendations. If oxytocin available, yes. And if oxytocin not available, then yes, you needed to give the other medications. So these were the various studies on oxytocin. I just Googled, there were so many studies on oxytocin. The list was innumerable and I just couldn't put all of these studies on today's slides. So basically, you could see there were so many things which, now coming to carbetocin, compared to oxytocin, yes, of course it is costly. So a per vial of 1 ml of carbetocin costs around 400 to 500.
Excuse me, Dr. Aditi, you have 2 more minutes.
Yeah. It may not be freely available in extreme rural Indian scenarios. So we know our rural, villages, still there is so much of PPH in rural India. It is not still available in United States and Japan. It needs more publicity because it's still maybe a new kid on the block. Few months ago, all the medical reps were like, we have to keep it in the refrigerator. And now after a few months again, they have come up like it is also okay at 30 degrees Celsius. So actually, what is the actual thing? We are still, under darkness. It is contraindicated in preeclampsia, severe hypertension, epilepsy. You cannot give it in eclamptic patients, and it cannot be administered before delivery as it may cause cardiac and respiratory distress to the mother and also to the baby. These are some adverse effects also. 10 to 40% were experiencing nausea, vomiting, pain, itching skin, etc. Increased body temperature. Some may experience back pain, chest pain, dizziness, anemia, chills, tachycardia. Contraindications again. Inappropriate timing during labor or delivery, such as before parturition or to induce labor, you cannot give it. Some allergic reactions to oxytocin or other oxytocin homologs. Additionally, it should not be used if a person has high blood pressure or cardiovascular issues. And overdosage may also cause problems, hyperexcitation of the oxytocin receptors, which result in excessive and prolonged stimulation of contractions, which will increase the risk of uterine rupture, placental abruption, fetal respiratory distress, and postpartum hemorrhage, which cannot be seen in case of oxytocin. So I think oxytocin and carbetocin Oxytocin is the saliva, it's the king, it's everything. And I think we cannot say that oxytocin is outdated or oxytocin is not good, because it does not mean the older ones are of no use, because the older meds have stood the test of time. They have better efficacies also. Some drugs are forever and they are always here to stand. So oxytocin is one of them. So that is my take on oxytocin and carbetocin. And thank you so much.
Okay, good, Aditi. Back to Dr. Niranjana. Aditi has put forth 5 important points. Just note and you have to answer. She says easy availability and cost, safety, and oxytocin is a benign medication. And about carbetocin, she has put a complaint. It's only for prevention and there is no need for refrigeration is again a questionable point. Now, what are you going to say about all these 5 points? Niranjana, please.
Ma'am, well, I would like to point one thing. Yes, ma'am did say oxytocin is the king, oxytocin is the king. But what we need to know is the king is not going to be the king forever. Once his term is over, the prince is going to become the king. So now carbetocin is the prince. So we don't know when he's going to become the king. And next thing, my point is not carbetocin is going to outro oxytocin in every aspect. No, I'm not recommending carbetocin for induction, carbetocin for abortion. My point is carbetocin for PPH, prevention and management. So only, and ma'am also said it's not easily available. It's because it's a new drug. The cost factor, yes. But when we could afford COVID vaccine for the entire nation, if carbetocin is going to be provided by the government, I don't think the cost will become a factor. And if I can administer carbetocin and make sure the patient is going to be safe with PPH, giving up that extra 20 times of oxytocin is not going to be a problem, because the mother is not going to require any more drugs. Yes, oxytocin is less costlier than carbetocin. But if you're going to add the misoprostol, carboprost, and then the methogen, the blood transfusion, tranexamic acid, put the cost of all these drugs together, I don't think that cost is going to be as low when compared to carbetocin. It's going to come on par with it. And ma'am also said the safety profile. Yes, she did say nausea, vomiting. But I also put forth a slide saying that all studies have shown that the adverse effect, that is the side effect profile of carbetocin, was similar to or less than oxytocin, not more than that. Carbetocin causes nausea, vomiting, but if it is causing in 4%, oxytocin is going to cause it in 10%. So oxytocin is not completely benign. When the drip is not titrated, that is also going to cause a rupture. It all matters with who administers it. If we are going to give it in a safe condition, I think carbetocin can indeed be replaced with carbetocin can be a replacement for oxytocin for management of PPH, not for induction.
So what's your reply, Aditi?
Yes, ma'am. Yes, that is correct. That is absolutely correct that carbetocin is useful only for prevention and management of PPH. But tell me one thing, after delivery, how many of us directly give carbetocin? We never give carbetocin. Always first line treatment drug is oxytocin, because she has been augmented. The labor has been augmented with oxytocin, and after the baby delivery also we start with oxytocin as the first line of drug. We give her 40 units of oxytocin in 1 pint, and then it is given slowly at the drops of 10 to 15 drops per minute. So I feel oxytocin has, it is the first thing which we always give post delivery. And if oxytocin does not work, if that is most of the time, it definitely works. If of course the cold chain and all is maintained, but that is the first thing which we give for all our patients. And then if it doesn't work, then we go to all the things which you mentioned, that is misoprost and prostrodin and carboprost. And then of course later on, if nothing works, then of course carbetocin. Now you just let me put across a point. Okay, we have given carbetocin, but still if it is not not coming under control, what after that? I mean, carbetocin, you have given carbetocin. If it doesn't work, then what next? So it is not the final mantra or something. So you have to still first go on with stepwise drug dosage, stepwise drugs, and then you can jump to a newer drug which is still under investigation, which is still under trials, and which is still under a lot of question and answers. So I feel still I would start with oxytocin, and that would be my first drug of choice after a delivery of any patient.
Okay, fine. Both of you have put forth your valid points. As judge, now it's my duty to give the final word. Well, with the good old oxytocin, we continue to use, as Dr. Aditi says, we continue even now, but still the threat of mortality as well as morbidity due to PPH is still frightening us. And that only has led to the search of something new. And carbitocin as such is not something different. You cannot fight like against ergometrin or prostaglandin or something like that. It's after all just an agonist of oxytocin itself, with a little modification of eliminating the drawbacks of oxytocin. Okay, like greater bioavailability, longer half-life, heat stable, and all those things, which are actually of crucial importance in the poor resource settings. That is very, very important. Okay, and whenever we talk about PPH management studies, there should be an endpoint like control of PPH, need for any additional oxytocin, need for transfusion, and all those things. And various studies have now shown that all these things are much reduced with carbitocin. Okay, because the onset is 2 minutes only, duration 1 hour, and half-life is even 5 to 10 times more than oxytocin. Okay, and as you said, oxytocin is a benign molecule. That's what you mentioned, is it? But it's not like that. And if you give a lot, then the antidiuretic effect. Okay, now and then we need to give infusions, and all those things are there, which is not with carbitocin. Of course, now whenever we talk about the management part, we are mainly focusing on PPH management. Of course, for all other things, as you said, for induction, termination of pregnancy, and all those things, of course, oxytocin is the preferable one. But when we take PPH as such, and especially for prevention, when you take it, all these points, then definitely the safety, except for the cost, and heat stable, long acting, all those things, definitely vote for carbitocin only. Now, the choice of carbitocin for routine prophylaxis will depend upon the cost effectiveness. That is the major issue with that. And once that is taken up by the government and the cost is reduced and being made it available for all, I'm sure the carbitocin will take the first place in management of, especially in prevention of PPH. Thank you very much.
Thank you, ma'am. Thank you, Revati, ma'am.
Thank you, ma'am.
Thank you, Sampat Kumari, ma'am.
Thank you, Aditi. Thank you, Aditi.
Thank you, everyone. So after this interesting post-lunch debate, moving on to our next session, session 6, I'm happy to introduce the chairpersons, Dr. Shobha Shiavi, who's a consultant in Sanjeevani Hospital at Bagalkot. She's the secretary of Bagalkot ObGyn Society and also the secretary of Critical Care Committee of Kasoga. Our next chairperson is Dr. Rashmi Ajit. Next slide, please. Who's associate professor .
First floor uniform VP.
Sambat ma'am. Madhumita ma'am, please.
Yes. Next slide, please. Our next chairperson is Dr. Neena. Can you please change the slide?
Yes, ma'am. Madhumita, are them available or not?
Changed.
Now is Dr. Madhumita Reena ma'am slide only, please.
Yeah, Dr. Reena is a consultant gynecologist in Kerala government. She is a past secretary of Kollam ObGyn Society and associate editor of KFOG Journal in 2021 to 22. Practical obstetric committee member from 21 to 22 and the present KGMOA Kollam 2021 to 22. I request Dr. Sampat Kumari ma'am to introduce our first speaker for the session, Dr. Chitra.
Okay, thank you, Madhumita. It's a pleasure to introduce our dear friend, Dr. Chitra. Dr. Chitra is the consultant ObGyn and infertility specialist at Lalita Nursing Home, Shyamla Nursing Home, and Janani Trichy Fertility Center. She has been organizational position held in the past secretary of Trichy ObGyn Society 2014, organizing secretary in International Conference of Tech OG Trichy on 2014, organizing secretary in International Conference of Endometcon in 2016, past president of Trichy OG Society and invited speaker in many national and international conferences, and she has presented many papers. Dr. Chitra.
Thank you. Thank you. Thank you. Thank you
And
very much.
Ramani Devi are twins. So on behalf of Ramani Madam, we called Dr. Chitra. Yes, Dr. Chitra.
Thank you. Thank you very much. See, yes, of course, because Ramani is out of town, I've been asked by her to present this on her behalf, and I'm proud to do it because I always like what she prepares and I know what she prepares every day. So both of us sit and read together most of the time. So I'm happy to do this. Anyway, I bring greetings from Trichy, the temple town city and the center of Tamil Nadu. Okay. This is again, it's all about fertility preservation in cancer patients. So here, what are we trying to do? We are trying to do fertility sparing strategies for cervical cancer, ovarian cancer, and endometrial cancer. And what are the methods available for fertility preservation are ovarian transposition, embryo cryopreservation, oocyte cryopreservation, ovarian tissue cryopreservation, and GNRL analog co-treatment, and other future possibilities that are available. So here, why do we really need to do or know about fertility preservation these days? See, because currently we know about 10% of female cancers occur in women less than 45 years of age. And between 2002 and 2012, 83% of these women have survived through their cancer. And 5-year survival rate for childhood cancer is as high as 78%. So we have to decide and know about fertility preservation because we have to counsel and talk to all these women who come to us on a daily basis. Effect of cancer treatment upon fertility preservation is the things that we should know. See, we know we either do surgery or we give chemotherapy or radiotherapy for all these patients. And all these three methods of treatment for cancer affects the uterus, ovaries, and the fallopian tubes. So we have to be aware of all these things. So radiation, what does it cost to ovarian tissue? See, it depends upon the total radiation dose that is being given and the location of radiation that is focused, and fractionation of the schedule that is being delivered every day, and of course the age of the patient, which is very important. So what happens is it is the cumulative radiation dose that really affects the or causes the ovarian failure. The higher the dose of radiation therapy, the greater is the risk of ovarian failure. So not less or more is the lower dose. When you give low dose, they go in for premature menopause. So which is better? Both are equally good or bad. So we have to be aware of asking them or telling them about the treatment effect. Again, chemotherapy depends, again, the drug that you use for chemotherapy and the dose of the chemotherapy therapy that is being delivered to the patient and the age of the patient really matters. Of all the drugs, the alkylating agents are the worst. They promote more damage to the ovaries. So a small portion of them become infertile even at the end of the treatment. Some of them have a chance of becoming prematurely failed ovaries have that. And this is mainly because it affects the quickly fast dividing cells, that is the mitotically active cells. And ultimately what happens is the oocyte death occurs and there is a loss of primordial follicles in them. So this radiation usually is given to the abdominal and pelvic radiation, both affects the uterus as well. So what happens to the uterus is the size of the uterus becomes smaller and the endometrial thickness also becomes very thin. This is because of the musculature change and the blood flow that goes to the ovary changes with radiation. So there is an increased incidence of miscarriage, increased incidence of preterm delivery, increased incidence of low birth infants in these women who conceive following radiation to this organ. So you have to tell them, sometimes they may even need to go in for a surrogacy. So you have to counsel them before you really take them up for fertility sparing surgeries. So you have to sit, a gynecologist and a fertility specialist should sit together and talk to them and make them understand that these possibilities or these risks are always involved. And once they become pregnant, and high-risk obstetric specialists should be aware of all the health hazards that they have faced and will be facing so that they take care of them well. Okay, in a cancer cervix patient, the standard treatment protocol, you all know for early stage of cancer is conservative surgery. In stage 1A, B and 2A, we try to cut off only the cervix and keep the rest. So we go for neoadjuvant chemotherapy and conization or we go for a neoadjuvant chemotherapy radical trachelectomy. And radical trachelectomy can be done either through the vaginal route, abdominal route, laparoscopy, or robotic. So nearly 1,000 patients have been studied with low recurrence rate, less than 5% recurrence, and more than 400 pregnancies have been reported in these cases. So the cumulative pregnancy rate has been as high as 55 to 60, but it all depends on the operative skill. So there is the hitch. So ovarian cancers, what we do is we try to do unilateral salpingo-oophorectomy. In staging, surgical staging should be considered for borderline tumors, especially stage 1 and grade 1 and 2 epithelial ovarian tumors in young individuals. Here again, you cannot contemplate between cystectomy or unilateral salpingectomy. Cystectomy causes more recurrences, so it is better always to go for a unilateral salpingo-oophorectomy. Okay. Now, again, the fertility following this conservative surgery in an ovarian cancer woman is about 30 to 80%, but they all require long-term follow-up because recurrent rate has been reported to be very high. In an endometrial cancer, the standard treatment is always total hysterectomy with DSO for stage 1A, grade 1. But then we are trying to look upon patients where we want to conserve fertility. The conservative management, there are about 620 patients who have been studied upon, and there has been no response at all in about 20% of patients. The resolution has occurred in as high as 76% of patients. Live birth rate has been between 20 to 40% following conservative treatment in an endometrial cancer. Recurrence has been 41%. Now, what will you do? You can give medroxyprogesterone acetate 500 milligram a day, or megestrol acetate 160 milligram a day, or use LNG-IUS for about 6 to 12 months. Then you have to make sure that there is no recurrence or there is no tumor there. You can do a hysteroscopy and take a biopsy and confirm, then allow them to go for a pregnancy. So this is all what we can do as a conservative surgery. Now let us look upon what has been advocated as fertility preservation procedures. So American Society of Clinical Oncology recommends embryo cryopreservation is the best established method of conserving one's fertility. So cryopreservation of unfertilized oocytes are also recommended now, because if you have a partner, you can make it as an embryo. If you don't have, that lady does not have a partner yet, then you have to freeze the oocytes. More flexible ovarian protocols are now recommended for oocyte collection. That is, timing of initiation of stimulation does not depend upon the menstrual cycle any longer, so that you need not delay the treatment and you can start anytime. And of course, ovarian transposition, if pelvic radiation is recommended, can also be performed. Ovarian suppression with drugs are not recommended by American Society. And ovarian tissue cryopreservation and transplantation are still very experimental, and there are no big results still or many studies available on this topic. So what do you do about ovarian transposition? Here, the radiation dose to the ovary is planned to be reduced. So they think you can reduce it to 5 to 10%. It can be carried out either by a laparotomy or by a laparoscopy. You cut and divide the utero-ovarian ligament, divide it, then move the ovary from its position to a higher position. You put it in the paracolic gutter so that you prevent, the uppermost portion of the radiation field, and the ovary lies above it. That's what we plan at. But what happens is sometimes this mobilization may not be really good, so they can fall back and it can fail, and radiation can already spoil all your ovary. And of course, surgical complications like chronic ovarian pain, ovarian cyst, and migration of the ovary back to its original position can all occur. But still, if you do transposition of ovary, conception rate of about 16 to 90% has been reported in the literature. So the next comes the most advocated embryo cryopreservation. This is the most established technique. Here you can give GnRH antagonist protocol with GnRH agonist trigger, because you can easily prevent OHSS risk, and the success rate has been very well documented. But the problem is, when you try to do this ovarian stimulation, the estrogen sensitive malignancies, are we right in doing this? This is a big question within ourselves. So the stimulation protocol with aromatase inhibitors may be used, and IVF yields both mature and immature cells, oocytes. So the mature oocytes can be immediately inseminated, fertilized, and can be cryopreserved as embryos. And immature oocytes have to go in for in vitro fertilization or maturation. In the restoration of fertility in young women, even girls following oocyte or ovarian tissue cryopreservation, and there is no risk of transmission of malignant cells, you can use this in vitro maturation. And advantages is you can avoid ovarian hyperstimulation, and it can reduce the cost, time, and the injections, because you are trying to remove even the immature oocytes from the ovary when they are under stimulation. So the disadvantage is very low success rate, because we do not know how much we can retrieve out of an in vitro mature oocytes. And efficacy of fertilization prevention is not known, because we cannot predict about the egg quality, and lack of outcome data in cancer patients is there. So when you want to do an IVM, you have to have at least 10 antral follicles, and during the basal ultrasound, and best candidates are the PCOs. When leading follicle is about 12 to 14, you can give the HCG and go in for a oocyte retrieval. And you can use FSH priming for increased oocyte yield. But the biggest crunch here is the culture should be very, very important. That should be good for us to get a good recovery after this IVM. So oocyte preservation, again, this is again an established method where you want to really grow them to M2 and then take, because we know for sure that they are good. Incidence of congenital anomalies in children born after oocyte preservation is not higher. So you can definitely use oocytes of M2, and oocyte preservation is an established method. Two cryobiological strategies are there. One is slow freezing and another one is vitrification. Of course, vitrification is the best, but studies so far are not very much available for us to say how good is vitrification. Because doing vitrification, you recover everything in the original way. But then slow freezing is what that has been commonly used now. So oocyte retrieval, most data are available from infertile patients or fertility preservation for social reasons. This oncological patients have not been there. Many studies are not available. So we have to wait for this to come in. So issues on oncological patients for oocyte preservation, that's what I was telling you earlier. Very few studies are available. A need for this ovulation induction or stimulation, it may cause trouble because it is more of estrogen that is being produced. So we are worried about that, and we cannot use it very strategically. So random start, for this you can start anytime and get any amount of oocytes at the retrieval time. So when you want to stimulate on estrogen sensitive cancer affected patients, you can either choose a natural IVF treatment where the oocyte retrieval may be very poor and there can be high cancellation rates. And ovulation stimulation with tamoxifen can be tried, and it can increase mature oocytes and embryo yield are as compared to the natural side. And tamoxifen and gonadotropin is another choice. And the last but not the least, or very important now, is the letrozole gonadotropin protocol. Here, the letrozole can reduce the estrogen that is being there, and gonadotropins can increase the yield of oocytes. So this is the best protocol that you can follow in an estrogen sensitive cancer patients. So the next is transplantation of the ovary. 90% of the primordial follicles are located within 1 millimeter of the cortical surface of the ovary. We all know that. So should we really remove the whole ovary or remove only strips of this ovarian cortex has to be considered, and we have to cryopreserve them. The cortical tissue is then transplanted back in a later stage when they are disease-free for their fertility to recover. Advantages, you don't have to do really any ovarian stimulation. You can minimize the delay between the cancer treatment. Suppose you want to start chemotherapy after surgery, it can be done immediately and then you start the cancer therapy. And you don't have to have a partner. And the only method that is available today for a prepubertal girl. So issues with this are success rate is not well established still, and slow freezing versus vitrification for cryopreservation of ovarian tissue do occur. Now where to place it, whether we should use the whole ovary or only a part of it, and how long will this graft really survive. And it's not an option for women with ovarian cancer because we really do not know whether these cells are malignantly affected by the malignancy or not. And putting it again back when they are disease free and we are creating again a cancer there is all a question in anybody's mind. So this should be offered only for women less than 30 years, no previous chemo or radiotherapy if age is more than 15 years. mild non-gonadotrophic chemotherapy if less than 15 years. Realistic chance of survival is only about 5 years. High risk of ovarian failure. Informed consent should be taken. They should be negative for hepatitis and HIV. No. Harvesting of the ovarian tissue can be done in any way, and then you have to put it back. It can be done either laparoscopically or laparotomy can be done, and the whole ovary or strips can be removed. And these can be either slow freezed or vitrification. As I told you, vitrification is better than slow freezing, but it's not documented or there are no studies regarding that. And now, where you put it, you can either.
Excuse me, ma'am. We have a minute more, ma'am.
Yes, I'll finish it. Either you have to put it in the pelvic cavity itself or away from the pelvic cavity. So both are available. But when you put it outside the pelvic cavity, you have to definitely do only an IVF procedure. But when you put it back into the pelvic cavity, a possibility of natural conception also occurs. So there has been studies about it. There have been 30 live births reported so far. 17 has been spontaneous conception and 13 following IVF. So ovarian tissue cryopreservation and transplantation is there. And this cannot be offered for everyone, especially for these high risk, moderate risk enrolls. This is not the treatment of choice at all. And you have to either use the ovarian cortical strips or the whole ovary. And to summarize, the embryo and oocyte cryopreservation are still established method of fertility preservation. So other things you can erase from your mind. Ovarian tissue cryopreservation and reimplantation is still very experimental, though we need more data on this. Choice of which method or combination of methods will depend upon the patient's age, ovarian reserve, type of malignancy, treatment required for malignancy, and time available, and risk of metastatic ovarian involvement that has occurred. So by doing this, as a fertility specialist, I would still say you should give them a chance to become a mother. Thank you very much. Thank you for this, including me in the last minute. Sampath, thank you very much.
Yes, Dr. Chitra. Thank you. We should only thank you for accepting at the last minute. Thank you. Madhumita? Reshmi, introduce Dr. Madhumita.
I'm happy to introduce Dr. Shekaran, who's done her MBBS from MGM and MD from BMMC Pondicherry. She's a gold medalist in MCH Reproductive Medicine from Sri Ramaphosa Medical College. She's presented award-winning papers and posters at national conferences, and she's a winner of Dr. Asha Rao Award in ISAR 2019. Her field of interest is fertility preservation and microsurgery. Over to you, Dr. Madhumita.
Thank you, ma'am. Thank you. Thank you for the kind introduction. I'll share my slide now. Yes. 1 minute. Okay. Ma'am, is my slides visualized?
Yes. Yeah.
Yes, Mama. Okay.
Ma'am,
Not
please
now.
minimize Zoom, ma'am, from yours.
What?
The Zoom panel, the Zoom window seen on your screen on top of the slides.
Okay, how I'm doing that same way only.
Okay, ma'am.
Yes, you share the screen, Madhumita.
Okay. Good afternoon, everyone. I'm Dr. Madhumita Sekaran, and I'm going to present on adenomyosis and infertility. So I try to make my presentation in a very simpler form. So let's move on to the agenda of the session. So these are my agenda for this session. So coming to introduction, I start with a bigger terminology, that is uterine factor infertility, which may affect up to 1 in 500 reproductive age women. So definition is it can be either complete lack of uterus or non-functional uterus. It can be And why did I start with this? Because uterine factor infertility, one of the causes adenomyosis. So I start with this term. And does adenomyosis lead to infertility? So there are various theories which has been proposed. So when I looked into studies, only few epidemiological studies which are available, and they evaluated the prevalence of adenomyosis and its impact on fertility. So when I did research about it, and I found an interesting article which is done by Borden et al. In 2020, which is published in Fertility Sterility. They have done that prevalence of infertility was observed in 30.2%, and among all women with the all types of adenomyosis. And they found primary infertility was 19.8% and secondary infertility was 10.4%. And classification of adenomyosis is of two types, that is diffuse phenotype, and other one is focal phenotype. Diffuse is the one where numerous foci of individual glands and the stroma that is dispersely seen within the inner myometrium. The focal one is where circumferential nodule aggregates or observed in the outer shell of the uterus. So when we see about the proposed theories, we will see about the pathophysiology of adenomyosis, where basal endometrial glands and stroma invade the underlying myometrium, which leads to intrinsic adenomyosis. Another theory is a deep endometriotic nodule of pouch of Douglas that can cause extrinsic type. Another theory is embryologically displaced pluripotent Mullerian remnant that can cause an adenomyosis. But actually, how adenomyosis is causing infertility is it causes altered uterine contractility, modified endometrial vascularity, and abnormal levels of free radicals, abnormal inflammatory response, and dysregulated gene expression profile. The mechanism involved could be dissimilar depending on whether the different type of phenotypes of adenomyosis. So adenomyosis and what else in the sense, it can be associated with other factors. And one of them is an endometriosis. Associated with endometriosis could be present both in focal and diffuse adenomyosis form. So when we see focal, it's more frequently associated with severe form of endometriosis, especially deep infiltrating endometriosis. And there is also a role with because of uterine manipulation, it plays a crucial role in the invasion of endometrial cell into the myometrium. So we should be very gentle while doing an endometrial keratosis section evacuation, so that can be an cause for adenomyosis. Another most common associated condition is the fibroid. When adenomyosis is confined, it may present as a nodule. Occasionally, it is misdiagnosed as a myoma. So, in 18% of the cases, it can coexist. And the main challenging is the diagnosis of adenomyosis and fibroid. So, coming to diagnosis of adenomyosis, these are the methods which is predominantly used, and the highlighted ones are most commonly used everywhere. And we are the one who connects these puzzles. So when we see with 2D ultrasound, we should be focusing on presence of the focal areas with ill-defined border. When these areas are present, and the following criteria of adenomyosis to diagnose them is the presence of heterogeneity, myometrial cyst, and obliteration of endomyometrial junction, asymmetrical enlargement of uterine wall. When we see about the sensitivity and specificity, it carries about 80.8% and specificity of 61.4%. So this is a reporting system on via ultrasound. When we notice an adenomyosis, we have to see where it is, which line, location, everything. So in this form, we have to report, like say if you are diagnosing or suspecting as adenomyosis, so where you are suspecting location, it's anterior wall or posterior wall, right or left, and focal or diffuse. The cystic patterns is same, and in which layer is in the junction zone or in the middle or outer myometrium, and the extent of this and the size of it. So we have to take time and make a chart, or an adenomyosis should be reported in this way. Added advantages nowadays, many of them with the recent advances in the technology, 3D ultrasound, 4D ultrasound, which picks up even more better accuracy compared to the 2D ultrasound in diagnosing an adenomyosis. They mainly focus on the thickened junction zone, which is the most sensitive finding in the 3D ultrasound. So junction zone more than 8 mm and zonal infiltration and distortion along with the myometric symmetry, all these are indicative of an adenomyosis. So when I was telling about fibroid and adenomyosis, yes, it is challenging to diagnose if you say in olden days with an ultrasound machine which was not as much as evolving. Now with the 3D future and everything, it is very much easier to pick up and differentiate the between the fibroid and adenomyosis. As we all know, fibroid is a well-defined border and a hypoechoic mass, where adenomyoma can be different and ill-defined mass. So there is an additional feature using Doppler, where leiomyoma, the peripheral scattered vessels can be seen, whereas in an adenomyosis, vessels will traverse between the myometrium, between the cystic space. The next widely used and most studied for diagnosing adenomyosis is the MRI. Many comparative studies are available with MRI and transvaginal ultrasound also for diagnosis of for diagnosing adenomyosis. And they use a standard criteria for diagnosing, that is a junctional zone more than 12 mm and a maximum ratio of more than 40 to 50% with a foci of high T2 signaling intensity. Where Cochrane reviewed in 2010, they commented as MRI was superior than TVS in the diagnosis, and combination of MRI and TVS has got better accuracy in specific conditions where there is coexisting conditions such as endometriosis, deep infiltrating endometriosis that can be easily picked up when we combine MRI and TVS. So HST was initially used as a first imaging tool to diagnose adenomyosis, but it is no longer used to evaluate the patient because of its low accuracy. Coming to reproductive outcome with adenomyosis, what the clinical evidence is saying. So many are commenting about the junctional zone. So how it is affecting the fertility outcome. So as I picked up, while I'm going through studies, I picked up two of these studies. Cheng et al. 1999. He found that dysfunction in the junction zone in infertile patient, and found that spontaneous abortion rate was higher and with women with a diffusely enlarged uterus compared to a normal one. And another study by Piver et al. He also diagnosed, but he diagnosed with MRI with he diagnosed adenomyosis using MRI for the evaluation of junction zone, and he said it is the best negative predictive factor of implantation failure. When there is an increase in diameter, it is inversely correlated to implantation rate. So implantation failure was found to be high when average junction zone was greater than 7 mm. So coming to ART or IVF cycle and adenomyosis, when to offer? Does it affect IVF outcome? Is medical therapy pre-IVF useful? Should ICSI be always used? If surgery is needed, which technique? So when we see this, I picked up a study done by Diaz et al. In 2000. He compared using a oocyte donation cycle with a healthy recipient and a recipient with adenomyotic uterus, where he documented their miscarriages more compared to a healthy recipient. One more study by Cospo et al. Investigated after a single cycle of IVF, reproductive outcome was compared, and there is no difference in live birth per patient between the two groups. And another study by Martinez, he said the miscarriage rate is observed higher in the adenomyosis group, and these is a different population where they compared adenomyosis and adenomyosis with endometriosis. They compared between those two groups using oocyte donation cycle. In that, they demonstrated miscarriage rate is higher in adenomyosis group and term pregnancy rate was lower in adenomyosis group. So when I studied about the other large meta-analysis study, women with adenomyosis undergoing ART have significantly lower pregnancy rate. In 2014, again, they raised a question, is adenomyosis associated with IVF ICSI outcome in terms of clinical pregnancy? And they said there is 28% likely reduction in likelihood of the reduction in the likelihood of the clinical pregnancy at ICSI IVF outcomes. when we ask about the conservative surgeries and combination treatment in infertility women with adenomyosis, also had significant benefit for not controlling the symptoms, but also there is increased pregnancy rate compared with gonadotropin, GnR channel agonist alone. So there is another interesting study which I thought to share with you. Zhang et al. 2021. He found the comparison of the pregnancy outcome who undergoes an IVF cycle following a long protocol. And he observed in adenomyosis patient had a similar number of available embryos and high quality embryos, but also there is significantly lower implantation and clinical pregnancy rate. So one more meta-analysis by Grace. This is very large one study. They had 11 comparative studies, and in those adenomyotic patients, they had untreated and treated, and they used long protocol, short protocol, antagonist protocol, and then they concluded the meta-analysis found no effect on adenomyosis in the clinical outcome of a long protocol treatment. So as we know now, adenomyosis have a detrimental effect on IVF clinical outcome. It reduces pregnancy and live birth rate and increases the miscarriage rate. But when compared to the protocols in terms of implantation and clinical pregnancy rate, it is both equally effective. However, agonist long protocol is preferred because of more M2 oocytes and embryos have been observed. So coming to GnRH agonist as a pre-treatment, so we all know it produces a reversible state of a medical menopause and very effective in also related to against the adenomyosis related pain and cause regression of uterine size. And there has also been a table column which I have put from the treatment gap and the duration of infertility followed by the achieved spontaneous pregnancy. These all studies also commented about the GnRH agonist pre-cycle therapy also reduces the NK cell activity and it gives a better result.
Excuse me, ma'am. You have 2 more minutes, ma'am.
Okay, thank you. GnRH agonist pre-treatment before starting the long agonist protocol doesn't improve the live birth rate in fresh embryo transfers. But note, when analyzing the frozen thawed embryo cycle, demonstrating greater potential to develop a successful pregnancy. So when we see about conservative surgeries, what is their aim is to reduce the symptom and raise the pregnancy rate significantly. But indications is desire for pregnancy, IVF failure, and age less than 40 years. When we see this table column in the right side, there I have put different types of surgical techniques, complete excision, partial excision, and non-excisional techniques. When we see with the evidence, no strong evidence to indicate a technique that secures the best clinical or reproductive performance, but all these have a therapeutic value. So the main aim is to maximize the amount, to reduce the amount of the, to maximize the amount of adenomyosis exercise during surgery by offering an increased area where surgical manipulation can be performed and also a better integrity. So who will benefit from an uterine sparing surgery in adenomyosis associated subfertility? This study, they underwent patients, they took a women of 1 or 2 patients and who had underwent laparoscopic myomectomy. And they found that women less than 39 and had a better pregnancy rate of 41.3%. And they also demonstrated in younger group following an IVF failure that they showed a better pregnancy rate. So I'm with conclusion, adenomyosis appears to have adverse effects on IVF results. That is in terms of clinical pregnancy rate, live birth rate, and miscarriage rate. Screening of adenomyosis must be considered before assisted reproductive treatment, both for counseling and also illustrating the prognosis. Transvaginal ultrasound has become most comfortable and most utilized apart from MRI, unless for specific situations, and moreover, selection of evidence-based ideal treatment options for adenomyosis in fertility clinic is difficult. So I thank everyone for organizers for giving me this opportunity.
Thank you, ma'am. Thank you for your elaborate talk on adenomyosis and infertility.
Thank you.
It was
thank you,
really informative. Now moving on to our next talk, I request
Can we request Reena ma'am to introduce Dr. Archana ma'am, please?
Yes, thank you so much for including me in this program. I am happy to introduce Dr. Archana Singh, Professor of Obstetrics and Gynaecology, Government Medical College, and Consultant, Yashoda Hospital, Hyderabad, Vasant Sani Hospital, Hyderabad, and Secretary, Obstetrics and Gynaecology Society of Hyderabad 2020-22, and Gold Medal in MBBS, National Award for Best Paper in MCH Care in the year 2012 AICOG Varanasi, and National Award for Best Paper in Geriatric Gynecology in 2013 AICOG Mumbai. Youth Leader Award at South Zone Yuva Foxy 2015 Mysore, and National Award for Best Paper in Geriatric Gynecology 2018 AICOG Bhubaneswar. And her areas of special interest are high-risk obstetrics, adolescent health, and minimum access gynecology. And with words, I introduce Dr. Archana Singh to the audience. Thank you so much.
Able to share my screen.
Yes, Dr. Archana.
Yes, ma'am.
First you open and minimize it.
Yeah, done, ma'am.
Yes, go to slide.
Good afternoon, everybody. First of all, I want to thank the Sampath Kumari ma'am and everybody in the, who has joined together as a team and called all the South Indian societies as a group. So today, the topic given to me was intrauterine.
Can you go to slideshow? On the left side corner, after animations, you have slideshow, no?
Yeah. Is it?
No, home, insert, design, animation, slideshow. Yes, click that.
Now is it coming?
No, ma'am.
Go to the from beginning. You go to that from beginning. The next line you have one from beginning. No, the bottom, next line.
Yes,
yes, you click that. You click that.
Okay. Is it coming, ma'am?
It's not coming. I don't know. Okay, to proceed. It is not coming on full screen.
Ma'am, you just enter double clicks.
Now?
It's not coming, Archana.
No, ma'am.
There is some problem, I think.
Partially also, is it coming or not coming?
Yes, it is coming. If you are comfortable, proceed. It is not coming in full screen. That's all. You proceed.
Yeah, ma'am. So why, when, how, and what are the complications? So we know that intrauterine insemination involves the direct transfer of the processed semen into the uterine cavity around the time of ovulation.
Archana, one
So
minute. Which slide now you are telling? First slide or fourth slide? Your slide is not moving. It is in Archana Singh. First slide itself. Or else each slide you click second, the third, and every slide.
Yeah. Now?
Is it moving? It's not moving.
Please try to reshare it, ma'am, so that.
Okay. Yeah.
Now, you please try changing the slides, ma'am, once.
Now?
Move to the second and third slide once.
Is
Okay,
it-
ma'am. Yeah, yes. Now it's moving, ma'am. You can continue.
So what is intrauterine insemination? We know that it is a direct transfer of the processed semen into the uterine cavity around the time of ovulation. And why it is used? To increase the rate of conception and increasing the chance that maximum number of healthy sperms reach the site of fertilization. So when we are supposed to do, when there is a male factor, ejaculatory factor can be there, severe hypospadias, impotence, infrequent intercourse during the fertile period, the husband or the partner is out of station, so then also rare cases, then male factor infertility, mild or moderate, and sperm cryopreservation prior to the treatment of husband for a cancer, and processed semen of HIV positive husband for HIV negative women. So, is it having role in severe male infertility? Not a candidate for IUI, but ICSI is more effective than IUI when total count is less than 10 million in severe male infertility. In females, when we are supposed to do is cervical factor infertility, when the cervical mucus hostility is there, poor cervical mucus is there, these patients are having significant improvement of conception for IUI instead of doing anything else and waiting for spontaneous conception. Then comes endometriosis, particularly mild and moderate. The previous speaker has already discussed about the role of endometriosis and infertility because of endometriosis. And yes, in these cases, it is good that we can go for with ovarian stimulation, go with IUI and increase the rate of pregnancy. What are the other reasons for going for IUI is ovulatory dysfunction, combined non-tubal infertility factors, and vaginismus. Then there are combined indications, unexplained infertility, immunological infertility, waiting for IVF, because many times they may not be having the financial or the social requirement needed for IVF, till that they can go for few cycles of IUI. And women with patent tubes and IVF is not affordable, these patients can go for IUI. So what are the advantages? It is non-invasive, inexpensive, easy to perform, training is easy, and antenatal and perinatal complications are just like pregnancy with spontaneous conception. So what are the contraindications? The cervical atresia, the endometritis, any infection is already there, either the cervix or the endometrium. The bilateral tubal obstructions, severe oligospermia and cases of amenorrhea. Here the important factor is patients who have already gone for tubal ligation. Then they will be thinking that can I go for IUI? So we are supposed to, then these cases have to be counseled that they cannot go for IUI because already there is bilateral tubal obstruction, and either they go for tubal recanalization or IVF and not IUI. So how we are supposed to do it? What are the steps? The patient selection is important, the natural cycle versus a stimulated cycle, the monitoring of follicular growth, the timing, the sperm preparation, and how to do the process itself. So how the selection is based on is basic investigations for infertility, which includes semen analysis and mid-luteal progesterone, the baseline ultrasound, and the ovarian reserve test in indicated cases, particularly in cases of endometriosis. Confidence and of husband is important. Counseling of both the partners should be done, and couples' questions and answers should be answered before going for the procedure. Then come the ovarian stimulation. To increase the number of oocytes, there can be ovarian stimulation rather than going for spontaneous ovulation. It increases the number of oocytes and it also increases the steroid production. What are the disadvantages? Ovarian hyperstimulation syndrome, the multiple pregnancy, and cost of drugs monitoring. What are the protocols we are supposed to use for before going for IUI? It can be clomiphene citrate, which is a well-known drug, can be started from 50 to up to 150, letrozole to 2 to up to 20, and clomiphene with gonadotropin or gonadotropin alone, or agonist with gonadotropin or antagonist with gonadotropin, depending upon the case. There may be certain different permutation and combination. And if the patient is say not responding for clomiphene alone, we can, or letrozole alone, we can go for clomiphene plus gonadotropin or clomiphene followed by gonadotropin. Then what are the points for monitoring the patient before going for IUI? The sonography forms the mainstay. Start monitoring the serial ultrasound after day 5 and baseline scan of stimulation, and before starting the stimulation, antral follicle count should be seen. Exclude the ovarian cyst. Accurate measurement of follicular growth is needed. Endometrial thickness has to be seen, and FSH, LH, and elevated LHFH has poor follicular response and raised LHFS, PCOS may have excessive response. These things should be kept in mind while monitoring the patient and taking care of her. What are the trigger item? What time we have to give the HCG injections if needed is at least the follicle should be more than 18 mm, endometrial thickness 8, at least 7, and IUI time 36 to 38 hours later. The rationale is viable spermatozoa should be present in the female genital tract and who have lifespan of 12 to 24 hours after ovulation. So before processing, we have to see the total count and the total sperm motility. Then can be used as a method of choice for diagnosing, and in the absence, we have to go for further follow-up. The sperm preparation is important in these cases, and it can be done by SWIMUP method or density gradient centrifugation. So sperm preparation includes collection of semen, and in this, it can be contained in the sterile container after 3 days of sexual abstinence. Avoidance of lubricant, because they are always, many times they are toxic to sperm. The container should be not very cold, not directly coming from the fridge, because it will cause cold shock and addition of culture media to the pots, particularly in cases where a few cycles have already failed. In these cases, improves the motility, there is amount of viscosity, and these cases can be improved. Then how many insemination? One insemination, if you are planning one insemination, 34 to, or 38 hours after HCG or 24 to 36 hours after urine LH search. And if you are planning, we are planning 2 insemination, then we have to go for 24 hours and 12 to 36 hours after HCG. We will be discussing about how many inseminations are needed later. Then the sperm preparation, the collection of semen in cases of impaired liquefaction, increased viscosity, inferior semen quality, obtain the split ejaculate. So what is a split ejaculate? The first ejaculate emissions are collected and 90% of the highest sperm concentration, better motility is seen. But in 10% of cases, we have seen that even the second fraction can have a good amount of success rate and highest sperm concentration. So we should not miss, and we should do in the patients who are not having success rate, we can go for split ejaculate. Then comes the how to do it. What are the equipment used? The equipment is the speculum and then 1 cc sterile syringe with blunt cannula and disposable polyethylene insemination catheter. 2 types of catheter are there, relatively rigid one and the double sheath with external flexible that will maintain a curve, and a very soft internal catheter. Ask the women if she is having acutely anteverted uterus to maintain a full bladder. We have to do in lithotomy position, the cervix is exposed, and then we should not use any betadine solution for it. The catheter is firmly connected to the cone of 1 cc tuberculin syringe, and the plunger is withdrawn slightly, and the sperm suspension then aspirated from the test tube into the catheter without any air bubble. The sperm
Excuse me, ma'am. We have 2 more minutes, ma'am.
Yeah. The catheter tip is advanced to a depth of approximately 6 to 6.5 and try not to let the catheter touch the fundus. If the catheter passes through the cervix is difficult, we can use tenaculum in some cases. And then the precaution is aseptic technique, and it should be gentle, and we have to inform the patient about post-procedure care, the increased wetness, the abdominal cramps or discomfort, or the slight bleeding or spotting can be there. luteal support only in cases which is required, particularly when primary indication is anovulatory infertility or disovulatory infertility, and micronized progesterone can be given. So infection, pain, and psychological problems can be there with the patients who are going for IUI, and this has to be explained. And what are the IUI guidelines? It can be is indicated as empiric treatment for all categories of unexplained infertility. In the treatment of unexplained infertility, we can use it routinely as well as, but we have to see that other options have been discussed with the patient. I'm not going through all these slides with a lack of time, but I will just discuss the favorable predictors of IUI outcome, which can be related to the couples and related to the therapy itself. The age, the shorter duration, the type of infertility, the primary or the secondary. The first treatment and the cause of infertility should be known, and these will be deciding the success rate. Then comes the use of clomiphene citrate or ovulation and sperm parameters having a major role in deciding the success rate of more than 10 million and 24-hour survival of more than 70%. The timing of insummation, the endometrium, the adequate thickness with trilaminar pattern is a deciding factor. Which does not affect IUI results are GnRH agonist and antagonist in unindicated cases. Double IUI, it is still having controversies, and we can go for single IUI. Luteal phase support where it is not needed, and how to improve is to increase the mild ovarian stimulation and selective follicular reduction and cycle cancellation if it is optimum size and number is not there. Then comes the timed intercourse also can be advised to the patient so that the increased chances are there. To conclude, it is least expensive, least invasive, and least stressful compared to other options for infertility. IUI alone can be used in couples with severe sexual dysfunction and cervical factor infertility. Ovulation predictor kit can be used to schedule the optimum time, and mild male factor patients can be benefited by IUI. It is very least expensive, least most cost effective, and it has least complication, and it has to be given an option to the patient before going for IVF. Thank you for your patient listening, and I want to thank organizers who have given me this opportunity for giving this talk.
Thank you, Dr. Archana. Madhumita?
Yes, ma'am. Thank you, ma'am, for your detailed talk on IUI. Now I call upon our chairperson, Dr. Shobha Shavi, to introduce our next speaker, Dr. Ashwati Kumaran.
Yeah. Good afternoon, everybody. I bring greetings from Bagalkot Society, Karnataka. It's a pleasure to introduce Dr. Ashwati Kumaran. She is a consultant reproductive medicine and head at Astra Miracle Fertility and IVF Center and Astra Why Not. Her field of expertise is in reproductive endocrinology, fertility ultrasound, recurrent ART and IVF failure, fertility rejuvenation and preservation. She is an ex-faculty and teaching excellence awardee at Kasturba Medical College, Manipal. She is first rank holder at FET and FNB. She has got FNB from prestigious Maulana Azad Medical College, New Delhi. She has been a faculty and organizer at several national and international conferences. She has contributed to ESHRE guidelines, and she's a gold medal winner and RCOG associate. I welcome you, madam. The screen is yours. Dr. Ashwati Kumaran.
Thank you. Thank you to the conveners of the conference for inviting me. Am I audible? Good evening. Am I audible?
Yes, yes, yes.
Yeah, you are
I
audible,
will try to share my screen. Are my slides seen?
Yes, ma'am, seen.
Yes, madam.
This is fine, no?
Yes, ma'am.
Yeah. Thank you. I think we are running short of time. This is actually a vast topic, so I'll just be touching the most important aspects of the problems that we face in infertility treatment, or the danger zones or the red flags in infertility treatment. At the very start, I would like to say that till last year, we didn't have any laws enforcing how we have to practice, especially in the field of assisted reproductive techniques. Now we have the act and the laws in place, and they have been notified. And I would like to say that we are supposed to follow everything that is said in the act, the rules and the regulations. Here in this talk, I will be touching more on the clinical aspects, but then some of the areas in the law are still gray. The boards are being formed, the register, the centers, the banks, all are being registered. So once everything comes into play, those are the final things. So this is not a talk on the laws. This is a talk basically on what we should look into while we are practicing infertility. Now let us go ahead. So the main red flags in infertility treatment are those that are associated with treatment and those that are associated with the treatment outcomes. Coming to the red flag areas while we are treating the patients, I will be restricting myself more to the assisted reproduction and IVF scenario, but then I will be touching into the basic practice also. This patient selection and how we start the treatment is very important. Is the slide moving? Is there a problem?
We're able to see your screen, ma'am, the patient selection and starting treatment. Other than that, the slide is blank.
Is not coming in. The animations are not coming. Is there a problem with the animation sharing?
We're not able to see that.
Okay.
Now we're able to see.
Now this is coming in, right? Who needs a fertility treatment? The patients who actually suffer from infertility. Infertility are those couples who have been trying to conceive with regular unprotected vaginal intercourse for more than 2 years and not conceiving. So there are male and female factors, and there are a good number of patients, around 40%, for whom we are not able to identify any causes. If they fit the criteria, they require infertility treatment. The age, the ovarian reserve, and the past obstetric performance, a detailed history is very important before we decide a treatment plan and investigations for the patient. And we should be treating only those who want the treatment after counseling. This is very important. We need to devise a treatment plan for these patients. We need to counsel them on all the various aspects of the treatment, what all they have to go through, what are the various options that they are having, and they have to be clear. We do not enforce anyone into treatment. We treat only those who want the treatment. This is the first thing. Avoid making wrong decisions, as in doing intrauterine inseminations, the best and inexpensive tools an infertilologist has, but don't use it where it won't work, as in a severe tubal factor where the sperm and the egg do not have any place to meet. Doing IVF just for anovulation when we haven't given the option of simple ovulation induction to the patient, that is wrong decision making, that is unethical too. IUI in severe male factor, does it really help? Not really. IUI should be done ideally when the total motile sperm count is more than 3 to 5 million. Not trying expected management when the couple are infertile, they are not insisting you for fertility treatment. They haven't really tried for conceiving, but their anxiety jumping into IVF for advanced treatments for them. It's not fair. We should try to help them make the right decision to wait for at least 2 years if they have the time and the resources and they are together. Of course, individualization is important, and unnecessary repetitions of treatments and investigations is something that we should avoid. Now, specifically, the red flags associated with assisted reproductive techniques. Again, choosing the right treatment for the right patient. We need to know our patient, the couple their problems very well and then choose the right treatment for them. The treatment should be ethically and legally acceptable, and the couple should be convinced that this is what they want to do. The psychological impact of the fertility treatment and outcomes is something that we should take into account. We should look into the side effects of the drug. Each drug is different for different patients, and again, individualizing to the need of the patient is important. We should take into account the number of painful injections that the patient may have to take, the drugs needed for luteal support. We should prevent complications like ovarian hyperstimulation syndrome. We should avoid the risks of ovarian stimulation. There are risks associated with oocyte retrieval and the other aspects. Hemorrhage and infection are some of the common complications, problems while preparing and transferring embryos. These are few of the things that we need to be very careful while going ahead with our treatment. The commissioning couple eligibility for IVF. Now, according to the recent law, the woman has to be more than 21 years and less than 50 years, the man 21 and 55 years. Doing advanced fertility treatment, IVF for couple who are 60, 70 years is no longer acceptable in India. This is something that we have to keep in mind. And they should have a viable indication for requiring assisted reproductive technique. Problems of the IVF protocol in general, especially an IVF stimulation requires daily injections, and many places they have to come to the hospital and get the shot so that they do not mess up. They may not know how to take the individual injections on their own. So if they if the clinic is easily accessible, or if the couple are educated enough to take the injections on their own, this can be solved. The injection burden can be reduced by choosing just the right amount of injection for just the right amount of days and the best protocols. The psychological health of the couple again has to be taken into account, and we have to make sure that they are compliant to the treatment so that we proceed with an expensive treatment and then the cycle goes waste because the couple are not ill prepared or fully understanding how the treatment should go on. There can be problems in oocyte pickup, like the ovaries may be difficult to access. We may have to go through the uterus. We may have to go through the bladder. So we should have enough clinical expertise on how to do the procedure, and we should know how to troubleshoot, and we should know how to improvise according to the situation. Often vaginal oocyte retrieval is done, but then in some cases where the ovaries are absolutely not accessible per vaginally, we should know how to handle it transabdominally also. Transabdominal needle aspirations can also be done, but we need to know how to do it. Ovarian hyperstimulation, I'm not going into all the aspects due to the shortage of time. Ovarian hyperstimulation is something that we should always avoid. Go for the right stimulation, go for the right controlled hyperstimulation, and this won't happen. And in case, unfortunately, due to certain genetic tendencies, some people just tend to go into hyper response even with oral stimulation. In them, we should know how to manage them safely. Problems in embryo transfer. Technically, there could be difficulties in the actual process of transfer. We can find the endometrial preparation also difficult. I saw a question in one of the chat boxes. What do we do when the endometrium is not thick enough? It is not 7 mm. We can try a few more doses of higher dose of estrogens if you're doing a hormonal preparation of the endometrium. We can try increasing the estrogen reach into the endometrium by improving the vascularity to the uterus, like adding vasodilators like sildenafil or vitamin E pentoxiflin combinations. Then there is all things like DCSF installation, such things are there. Everything needn't work for everyone, but there are different aspects to it. And provided the endometrium is more than 5 to 6 mm, good triple line and vascularity, absolute 7 mm requirement is not a cutoff, because live births have been achieved from good endometrium that is thinner also. So this is how to tackle a difficult embryo transfer. Luteal support in a hormonally prepared endometrium we generally do need to give luteal support with progesterones. And here is another issue to the patients. Injections are often given, injections are painful. So how can we do that? We can give for only oral, especially on those who are progesterone intolerant. Vaginal progesterones work well. So a combination of these two can be used instead of going for painful progesterone injections. Now, complications associated with the treatment outcome, facing the failure of a treatment cycle, multiple pregnancies, especially following IVF, pregnancies conceived after such treatment, very precious, but are in the long location, ectopic or heterotopic pregnancies, high-risk pregnancy, a person who has suffered from infertility for quite a time and becoming pregnant, invariably their pregnancies are high risk. Often there are complications. Is there risk of cancer? That is another problem. Then the risk of early menopause. Does IVF treatment induce early menopause? And recurrent failure, how do we manage? So the woman may, especially if you're doing higher number of embryo transfers, there may be multiple embryos latching on and multiple embryos, multiple pregnancies, higher order pregnancies more than 3. So go for single elective embryo transfer wherever feasible. Heterotopic, we should know the patient history. Is there history of bad tubes, dilated tubes? We need to clip before the embryo transfer. Thus, we can avoid, and in known cases of ectopic pregnancy earlier, doing sufficiently low transfers can avoid. Diagnose the ectopic pregnancy and heterotopic pregnancy early, and if conservatively managed, especially in heterotopic pregnancy, we can save the intrauterine pregnancy.
Excuse me, ma'am. We have 2 more minutes to
go.
2
more minutes. Yeah. Okay, thank you.
Yes, ma'am.
The children, are there increased risk of congenital anomalies? Not really. In reality, the background risk only prevails, although theoretically, IVF babies are supposed to have more risk. Multiple pregnancies, do lesser number of embryo transfers, and we can reduce the higher order pregnancies. Ectopic and heterotopic is something as I've already covered. Cancer risk, as you can see from the slide, no real increased risk. Early menopause, not really in IVF, because we are only recruiting the follicles that would have already been destroyed at the end of the menstrual cycle. If we are doing the IVF cycles properly, not causing any unnecessary scarring and infection to the ovaries, really early menopause is not induced. Risk of childhood cancer, there are recent studies that are coming up that excessive progesterone exposure can cause to childhood cancer. This really needs to be looked into. So then reduce the amount of hormones that are using just to the need of the patient. Perinatal outcomes, be careful so that we can avoid the morbidity. Now, these pregnancies are again high risk. We need to really counsel the patients. When to stop the treatment? By keeping the expectations of the patients realistic, by having the human touch. Do not do more than 2 cycles. Unless the patient is really insistent, we do not have the 3-cycle low. Psychological preparation is a must. The severity of infertility as high as in an HIV-infected cancer or heart disease. So we need really to have the human touch in these patients. This is the human touch slide. Ethical and legal aspects are very, very important. The ART Act has come into play. We need to follow. We should not be mixing embryos. We should not be mixing gametes of 2 individuals. Posthumous collection. Really, we need to have the consents. Confidentiality is a must. Follow the law and do ethical practice and have a consent for everything, which will save you. Document everything and do not do anything without informed consent. Summary pertain to treatment and outcomes I've mentioned, go for that. Ethical, legal treatment is what we need to offer. Psychological support is mandatory. Avoid ovarian hyperstimulation. This is the must of every infertilologist. From IVF, avoid hyperstimulation and go for a single pregnancy, not for multiple pregnancy, and make sure everything is within the guidelines. Thank you.
Thank you, madam. That was a wonderful talk. You covered most of the aspects of red flags. Thank you very much.
Thank you, ma'am, for the elaborate and detailed talk on red flags and infertility treatment. Now moving on to our next interesting session, which is a panel discussion, which is moderated by Dr. Rekha Kurian. Can I have the CV slide, please? Dr. Rekha Kurian is a director and consultant at Joseph Hospitals, Chennai. She was the past president of OXY and the vice president of FOXY in 2015. She's the managing committee member of IAGE in 2009 to 2023. She's the immediate past chairperson of South Zone AACC RCOG and the vice chairperson TN chapter IAGE. The panelists are Dr. Jamuna Devi. She is the chairperson of State Medico Legal Committee currently and the State Menopausal Society of Hyderabad. She is the treasurer for Telangana State Society and the Honorable Treasurer for Family Planning Association of India. Dr. Saravana Kumar, the next slide, please. Sir is the secretary of the Obstetrics and Gynaecological Society of Salem, Tamil Nadu, and he was the organizing secretary of FOXY South Zone Conference with UR 2022. He is a professor and HOD of OG department at Annapurna Medical College. He's the member of Practical Obstetric Committee of FOXY. Dr. Radha Madhavi, she's the founder president of Tiruvannamalai OG Society, and she's also the joint secretary and executive council member of TN-FOG. Dr. Shaijas Nair, he's the chairperson elect of Midlife Management Committee of FOXY and the chairperson of Research Committee of Kerala Federation of Obstetricians and Gynecologists. He's a South Zone coordinator of FOXY Committee for both breast disorders and for public awareness. He's currently the president of Kannur OG Society in Kerala from 2019 till 2021. Dr. Uma Shankar, he's a joint secretary of GOGS and he's also the Andra Pradesh OG Society secretary. He's the executive council member in Andhra Pradesh ISAR and the organizing secretary with 5th AP COG. Dr. Vidya Tobi, she's a chairperson of Food, Drugs and Medico-Surgical Equipment Committee of FOXY and she was also the ICOG governing council member from 2021 to 2023. She's also she's also an advisory faculty of boards of Rajiv Gandhi University of Health Sciences in Karnataka. Dr. Brajbala Tiwari, she is the president of Indore ObGyn Society and also the vice president of Indian Medical Association Indore branch. And she's a joint secretary of MP chapter of ISAR 2020 to 2022. I request Dr. Rekha Kurian to start the panel.
Rekha madam, I think Dr. Uma and Dr. Uma Shankar and Vidya Topi is not there. Remaining 5 are there. Rekha madam?
Ma'am, Dr. Cyrus is also not available. Some emergency in the hospital.
Okay, Dr.
Vidya
Jamuna.
Topi ma'am is joining now.
Dr. Jamuna, Saravana Kumar, Radha Madhavi, Brijpal Tiwari, and Vidya Topi. Yes, madam.
So I don't know if my slides are, can you hear me?
Yes, we can hear you, madam. Slides not seen.
Not yet seen.
Hope you have come out with your jet lag, Rekha.
Pardon?
You have come out of your jet lag.
Yeah, I may sleep through I hope I don't sleep through this. Anyway, let me see if I can share the screen.
How come Jamuna madam no?
Because she has put in the group that she had jet lag.
Yes.
So no questions for us. So we are going to batting like that. Last, we are in the field for the last. So we are going to win the game. Huh?
No, Jamuna madam. After that, we have one talk.
Really?
Yes.
Oh.
Okay.
Dr. Meena Mahalingam.
Okay.
Oh, okay.
For want of time, we adjusted her to last.
So is my scene, is the screen?
Yes, ma'am.
Okay. So the topic that has been given to me by Dr. Sampath is to save the uterus. I thank all of the teams who have got together to have such a wonderful meeting. And we will go on with the panel discussion now. This is my experienced and esteemed panelist here. We have Dr. Jamuna Devi from Hyderabad, whom you just now heard talking. Dr. Saravana Kumar from Salem, Dr. Radha Madhavi from Tiruvannamalai, Shaijas Nair, I think, who's been called in for an emergency. Dr. Uma Shankar also may not be there. Dr. Vidya Tobi, again, has a problem. Brijbala Tiwari from Indore is there. So welcome to all the dear panelists, and let's try and solve some of the problems, how we can save the uterus. I don't know if I can see, are all the, yeah, I can see most of them now. Because if I don't see, then I don't know if they are there or not. All right. So now.
Rekha ma'am, sorry, I'm Priya here. Dr. Vidya Dobi ma'am is joining now.
Ah, great. That is fantastic. So saving the uterus makes you an uterus-friendly gynecologist. Just as saving the earth makes you an eco-friendly person, we have become uterus-friendly gynecologists here. But is it a tightrope walk when you save the uterus? For who, the gynecologist or the patient or both? It can be a slippery path when sometimes you try to save the uterus. So we have to save the uterus, the reasons being either for reproductive function, or it may be to comply by the patient's wishes that she just wants to retain her uterus. I don't want my uterus removed. Whatever her reasons, we may have to comply by that. In either case, managing this patient and her uterus would be very tricky. We all know the management of various individual conditions, but when there are multiple burdens, how do we manage? Here he has chairs, he has mats, mattresses, and his wife to balance on the bike. This is how we sometimes are managing work and the stresses and all the problems that the woman brings to us, we have to solve for her. Oh. So, okay, what is our issue? So now we'll go on into the first case without wasting time. This is an infertile woman, which is NR, 29 years, married for 3 years, comes for infertility evaluation in 8/2011. She has very irregular cycles varying from 30 to 90 days. So obviously, she is probably a PCO patient. And we find that she has an endometrial cavity, which is filled with some sort of fibroid or some echogenic area is there. So what would we do? When this echogenic area is there, we have requested for a sonohistography in the following cycle. But she doesn't come for the next 3 months. She comes in December, however, and she says, I haven't had my periods for the past 3 months, but now I have passed a large piece of tissue. What do we do? A repeat scan shows 2 small fibroids, 2 into 3, or 2 small masses, I would say, 2 into 2 centimeters, intruding into the cavity. And the endometrium now is actually only 4 mm apart from this. So now, what do we do for her? What would you do for this patient now?
Start evaluating her. Oh, I'm sorry.
We can plan a hysteroscopic because fibroids are intracavitary and she's for fertility management. We need to go for hysteroscopic dissection of the fibroid.
Yeah. So for basically everybody agrees that she requires a hysteroscopy to see what's inside. Dr. Jamna Devi, Dr. Radha Madhavi.
Hysterolab, ideally.
Hysterolab, because you want to see if the tubes are patent. Excellent.
And puncture all those small things. If it is too much. If it is too much.
Anybody agrees on that? Dr. Jamna Devi?
Yeah, controversy of the punches is there. So
yeah, because they don't want to have a problem. That's right. Yeah, premature ovarian failure, etc., is a problem, or adhesions could be a problem. So that is the thing. That's at least hysterolab for sure.
Yes.
Yes.
So when we look in, we find that there are endometrial polyps in the uterine cavity now. So this was in January, we saw the picture. Now she's come in February, and there are multiple endometrial polyps, about 20 to 30 in number. So what do you think it could be? What do we do with this multiple? It's like a whole thing is studded with these small polyps. The pictures are taking a little long time to load. I don't know why, but it should come up now. The picture should come up. So what do we do with this?
Under GA, we should evacuate the whole cavity and biopsy it.
Yeah. So, but when you remove the whole cavity then of these polyps, don't you think you will be destroying a lot of the endometrium?
No, I mean to say not the basement membrane, at least until the follicles, only those follicles. I mean polyps.
Okay. So when you look at the polyp like this, and anyway, we've taken a biopsy and the report comes as atypical hyperplasia with areas showing well differentiated adenocarcinoma.
I thought so.
Okay, excellent. So when you suspect that it could be a malignancy, you just take a biopsy. You cannot scrape the whole endometrium because when you scrape it, you will have a lot of problems. So just take a biopsy, and again, you don't want to disseminate this malignancy.
Yes.
So, Dr. Sarvana Kumar, what would you like to do now?
Yeah, now that she has not completed her family, and the thing is, we here can give her high doses of progesterone to suppress the endometrium, but a little bit careful that she has to be in follow-up with us, so that we may not miss the invasion of the thing. So before that, we need to take an MRI whether there is any invasion into the myometrium.
Okay.
So once we know about whether there is no myometrial invasion, just the endometrium, then probably we can give a progesterone and make her complete her family as soon as possible with the infertility treatments.
Okay. So that is a plan now that we have to do something for this to suppress the malignancy. So cautiously, you have to move forward. So an oncology opinion is taken and she started on high dose progesterone for a period of 3 months with monthly follow-up for endometrial thickness. Is Dr. Vidya Thobi joined?
MRI can also be done, no, Rekha? For this
Yeah, an MRI can be done to see if there is anything.
Yes.
Yeah, just to make sure that there is no other, the endometrium, the myometrium is not
invaded.
Yeah. So after 3 months of therapy, now the endometrium is 9 mm on 5th of May 2012. So 3 months she's had therapy. Now what do you want to do? 3 months she's had. Are you happy? What would you like to do now? Dr. Brijbala Tiwari?
Now she can be taken for, because now endometrium is only 9 millimeter and she is desiring for fertility.
Yeah.
So now we should go for fertility treatment and she should be kept for follow. But we have to take proper history. Is there any family history of endometrial CA or ovarian CA? That we have to keep in mind, and along with, if she is obese, we have to advise for weight reduction and all high risk factor for this thing.
Yeah, she is not diabetic. She is normal weight. She is doing her PhD, and which is why she didn't come for 3 months. But now she promises to come regularly for follow-up. Dr. Sarvana Kumar, what would you want to do now?
So evaluate the male factor also. If everything else is normal,
male factor is normal.
Male factor is normal, then probably we can go in for a quick ovulation induction, and then probably.
Would you like to see the endometrium again?
Yes, ma'am. Endometrial evaluation again, and then go for with the.
So we went for endometrial evaluation. And histoscopy shows a small area of thickened polypoid endometrium only in the lower end of the cavity. So you can see, otherwise the whole cavity was full of this. Now only the lower end there is. So like part of it, 3/4 of it has gone away. So now what would you like to do? Dr. Jamna Devi? And now the picture is of a complex hyperplasia, but with atypia.
Okay, you have taken the biopsy during this histoscopy.
Yeah, second histoscopy also, we've taken the biopsy. It comes as complex hyperplasia with atypia. What would you like to do now? It's still there. Some of those lesions are there. Dr. Sarvana Kumar?
I think I will again go with another dose of progesterone.
Okay. So we again continued progesterone for 4 months. And endometrium is now 6 millimeters by November 2012, another 4 months later. So next, what would you like to do? Dr. Radha Madhavi?
I would have to sit and counsel her correctly because just one area is showing atypical hyperplasia. There can be invasive CA in other areas. So I will be more careful with her life rather than the unborn child. That is my opinion.
Okay. So what about anybody else? What would you now do? She is very keen. She says, I just need a baby. I have been trying for 4 years now. Please give me the baby. Of course, we
She
have to be
needs to be
careful with her.
concealed.
Pardon?
Because she is now coming complex hyperplasia, complex atypical hyperplasia. She need to be concealed along with onco person.
Yeah.
Because she is definitely a case of CA.
Okay. So Sarvana Kumar, what will we do now? 4 months we gave her.
Yes, and I'll do another histoscopy, see if there's all the lesions have disappeared, and then go ahead with the fertility treatment.
Okay, so we repeated the third histoscopy again, and now we found that there was the endometrium was completely clear of those lesions. But however, we found a small submucosal fibroid in the posterior wall. So we had to resect. So now again, we send this tissue for biopsy, and the biopsy came as complex hyperplasia with atypia, but with adenomyas and myomatous tissues, which we removed just now. So now she is all ready, and we sent her back to the oncologist, who said you can stop this treatment now and go on for IUI treatment, infertility treatment. So what would you like to do now?
You've already said that IUI.
Yeah, okay. So we looked at all her hormonal values, everything was normal, and she's okay. So now she went on into follicular study and IUI, and in the second IUI, the pregnancy became positive. At 5 days, she comes with spotting. Would you expect this?
Yes, because the adenomyosis is there. So
And
implantation failure will be there, and probability of pregnancy loss also is there.
Okay. Would you like to give her any progesterone? There's a tiny residual bleed.
Yes.
We want to give her progesterone?
Definitely progesterone.
We give her some progesterone. Especially in a case like this, I think it is indicated. All the other blood investigations are normal, and this is the picture at the early scan. The second bleeding episode occurs at 9 to 10 weeks, which is a larger bleed now. And there you can see also the subchorionic hemorrhage is there. Here there's a subchorionic hemorrhage. Apart from that, there's an echogenic band here with vascularity from right anterior to posterior, on the left side rather, and a single intrauterine pregnancy, 9 to 10 weeks. We don't know if it's a septum or a synechiae, anything to do with what we do inside, but this is there. So everybody wanted progesterone. So any other medication that we would like to give her, apart from this, other than the folic acid, anything else?
Progesterone.
We gave her some estrogen also because we expected her endometrium to be very thin, and especially the synechiae was there. Now, on the second trimester, NT was normal, echogenic band again seen, papae normal, and normal anatomy at 18-19 weeks with a thick band running anteroposteriorly towards the left. And we also find that there is a type 4 placenta previa at this stage.
Oh my God.
Yeah. So now her echo scan is normal. Any other information do we want for her?
Is she not hypertensive by now with all the stress she has had?
Right now, she's not hypertensive. She's quite all right. When do you want the next scan? I'm hypertensive though with her.
Yes.
Gynecologist would have become hypertensive.
Yes.
So when do you want the next scan for her? We've done it at 18-19 weeks, and then at 22-23 weeks, one scan is there. When do you want a next scan for this lady?
26 weeks.
26, 28 weeks.
Why do you say that she needs a scan at 26 weeks?
Anomalies.
And
we routinely do a 26 week scan, or any particular reason?
Not
because of this case.
Anything particular you want to say, Dr. Sarvana Kumar?
No, there is a band running, and I just wanted to know how the baby is growing. If is there any growth restriction happening in this child?
Now, the main reason is that, as you said, we want to look for growth restriction because she's had a large bleed in the first trimester. So that can sometimes be a reason for an IUGR baby. And therefore, it is important that we do a Doppler scan at 28 weeks. Now, again, we have placenta previa at 28 weeks. and she has actually fallen back in her growth with 5 to 10% of fetal AC and HC. Dopplers, although, are normal. Do you want to give her any steroids at this point? Yes. And why?
Yes, because we may have to interrupt in between for she may go for premature delivery.
Yeah.
UGR is another
So we have to give a steroid by this time.
If there is any problem with further growth and we have to help the baby out, then we require the steroids. And any more scans would you like for her?
28, I mean, every 15 days, I guess.
Every 2 to 3 weeks.
2 to 3 weeks. So we followed up the scan and we found that the HC was less than 5, AC was a 10th percentile, Doppler normal. Is this IUGR? Will you say it's IUGR?
Although her AC is less than 10%.
Yeah. Okay, that is IUGR, and finally we've reached third trimester. On 27th of September 2013, she's 34 weeks and 6 days. Estimated fetal weight is less than 10th percentile, and placenta previa type 4, posterior, right lateral. But no evidence of accreta. Echogenic band still continues to be there. Should we cross-match blood for this lady? She's placenta previa type 4.
Obviously, 100%.
At this point, she's just admitted, no bleeding, nothing. When do you want to deliver this lady?
Now.
Now, okay. So this is quite a good time because she's IUGR also. On top of that, today her BP has now shown as 140/90. Just as we expected, Dr. Radha Madhavi, her BP has gone up, and that was also the reason for admission. So now she's had a first trimester bleed, placenta previa, and now she's become PAIH. So what are the problems that she can come up with now? With her?
Ma'am, Jamna ma'am, shall I answer or you will answer?
Yes, please.
Okay, I will think of both the fellows, mother and child. Mother, I will be thinking first and foremost, bleeding. Intra-op, I expect, I don't know, 4th grade placenta previa. First, I'll pull that baby out and then only tackle her. I will just see that I save her and her uterus if possible.
Yeah.
And then that is what I expect. Intra-op hemorrhage.
Okay, fine. Excellent. So intra-op, or she can even get an antepartum hemorrhage, right? Because she's now become PIH as well. And also the placenta previa.
Yes.
So we anticipate this, and the emergency happens exactly on the next day. 28th September, 35 weeks, she starts bleeding. So
on a Sunday.
On a Sunday, yes, most likely. Hypertensive disease of pregnancy. And emergency cesarean section, whether GA or spinal anesthesia, you can decide because she has placenta previa. What would you prefer? Any of you particularly?
Like
this patient?
General anesthesia would be better because if we have to proceed with some other, surgeries.
Yeah, exactly. Okay. And anyway, her uterus is not so good, so you may want to do a hysterectomy for her. We don't know. Okay. So all the special preparations, putting IV lines, getting blood ready, everything is important. And you already said you anticipate that she could have bleeding. So we delivered going through the edge of the placenta, fortunately. 1.7 kg baby was delivered. And now problems galore start. Yes. On traction, the placenta comes out, the major portion, but some portion remains adherent right in the middle. So now we have the problem of adherent placenta added to all the other issues. So what would you like to do now that placenta is remaining there? Would you like to remove it, Dr. Sampath Kumar? I mean, Dr. Saravana Kumar?
Actually, when I have anticipated that the placenta might be adherent, I would definitely have a urologist with me because you told that it is adherent in the middle and maybe it may have.
Only now we know because it was not. So far, there was no accreta signs at all. So only now suddenly when I took the placenta out, there is a bit which is attached to the thing. So I don't have anybody ready.
If the institution is big, probably we can go for uterine artery embolization at that point.
No, unfortunately,
no. We can do a uterine artery ligation
for us.
Internal iliac artery ligation and then try to remove the remaining placenta.
Okay. So all the oxytoxics that you know you should use here.
Yes.
Okay, this was the year when we didn't have carbitocin, so all the others we used. And then now what else? Do you want to scratch this placenta out? What are we going to do with the placenta?
No, we can.
You want to do a
leave the
hysterectomy?
placenta if there is no active bleeding, and if
There is
we are
bleeding.
able to-
There is bleeding.
If the bleeding is there, then
Moderate PPH, not very heavy, but still she's losing quite a lot of blood. What to do with the placenta? Pardon?
Uterine devascularization. And then try to,
what to do with the placenta? We can do all the devascularization. Now, what are you going to scratch the placenta out or leave it there?
We can leave it and then we can leave it.
I will try to remove the placenta.
No, I will leave it.
We will leave it.
Dr. Jamna Devi?
See, it depends upon the situation then. If it is bleeding heavily, then we cannot leave because she will be going on bleeding. So we have to go for a hysterectomy. But if we are able to control the bleeding, then we can leave the placenta.
Dr. Brajbala, any opinion on this?
Madam, she is already a high-risk case, complex atypical hyperplasia, and it was diagnosed. So we should have taken beforehand counseling. She may end up into hysterectomy. And if with any means it's not controlling, we have to leave placenta. And in spite of that, if she is bleeding a lot, we need to go for obstetric hysterectomy.
Yes, yes.
So this that option is kept ready. But most of you, I think, agreed that if you try to scratch the placenta out, it will even cause further bleeding. It's better to leave the placenta. So we put a Bakri balloon, left the placenta that bit inside. And when do we remove the Bakri balloon?
Assess the bleeding.
Pardon?
Once you deflate and then see if there is bleeding.
Bleeding, yeah.
Yeah.
So
then
now
that bleeding and then take a decision.
Fortunately, the bleeding was controlled in the next day. And on the day 3, we just did a scan to see what was there. And we found a 6 into 4 centimeter placental tissue in the lower uterine segment. Most likely that was the place where we resected that posterior wall fibroid or adenomyoma. And that is the region where this, it is adherent. So any other medication you would now like to give her? She's day 3 post-op.
Methotrexate we can give.
Pardon?
Methotrexate.
Methotrexate. Will you give her thromboprophylaxis?
Yes.
100%, right? Preterm labor, all those issues that she has, PIH, etc. Would you want to do the beta HCG?
Yes.
Yes, we have to.
So all that was done. And we were planning, on 5th of October, we planned to discharge her. We found a retained bit of placenta. We just can't keep her in all the time. So we discharged her with the 16 to 35 retained placenta and told her to come. And in the lower segment also 49 into 35. So this whole thing was there when she went home. Now on 21st of October, she's readmitted with heavy bleeding. What shall we do now? We somehow managed to avoid a hysterectomy at that point. Now, what do you think?
Hysterectomy now.
Hysterectomy.
For sure. Okay. So that's a problem. But if we remove the baby, do a hysterectomy now, what about the baby? Baby is only 1.7 kg. We don't know the survival rate of this baby, IUGR, etc. So we were in 2 minds whether to do a hysterectomy. Again, the scan showed that there is retained placenta 43 above and 28 in the lower uterine segment. We again managed with blood transfusion. Tranexamic acid can we give her? What about methotrexate?
Yes, yes.
We have.
Will it affect her lactation?
Yes.
So we stop lactation.
Yeah, baby can be given the top feed. Anyway, baby will be in the NICU, I am assuming 1.7 kgs.
Hello.
Sitting around.
Pardon, Sarvana Kumar?
I would go ahead probably with the hysterectomy because I don't know, this patient may again come back with this much of placental tissue again with her. She can land up again with bleeding, heavy bleeding.
Yeah, so we have to have surveillance for this patient. We gave her depo-progesterone again. That is basically to suppress it any further. Beta HCG has now come down to 227 from about 400, and in a month, by November, it has come down to 95, and 8th of November, 43, but still the placental tissue is there, but regressed compared to the previous scan. Now 2 months postpartum, again she's admitted with menorrhagia. So this is the problem when you leave the placenta, you would get periods of time when they're waking you up at night and saying she's come again with menorrhagia. So again, the question is, should we now do a hysterectomy? So at each point, we have to keep this option. But as far as possible, we try to avoid hysterectomy unless it is essential. So again, managed with Trapic, Methogen tablets, etc. Bleeding. Now after that, 1 month later, she has a bleeding episode. Now it is more like just periods. Endometrium is 5 mm. We need to think now of contraception because now she has sort of settled down. So what are the options for contraception now? We have to give her contraception, right? You agree or not?
Yes.
Because
Condoms.
We can put Mirena now.
No. Why not condoms?
No, we want 100%. Condoms
Mirena
are
will-
only 60%, 70% effective.
Mirena, I think would be difficult because there is placenta there, and as you put it in, it may start bleeding.
I think oral contraceptive pills would be better.
Oral contraceptive is again estrogen, so we don't want that for her endometrial CA.
Depo-progesterone.
Then Depo-Provera.
So Depo-Provera we had given again a second dose. What is the long-term plan for her? Just as Dr. Sarvana Kumar said, when do you want to remove her uterus? You want to wait for the baby to reach a particular age and survive in case the baby doesn't survive. Because whatever it is, it's a small baby. It will at least his first birthday, we need to be careful, I guess. Or would any of you want to go in and do the hysterectomy? Because her bleeding and all her problems because of the retained placenta has stopped. Would you plan to retain the uterus?
We can follow up with ultrasound and if she has any hysteroscopy,
Exactly. Our endometrium is remaining quite thin and no other masses seen. So a year and a half later, she reports with 10 months amenorrhea. We had to give her Novilon to get her periods because it had got so suppressed with repeated dose of Depo-Provera. So when do we want to do the hysterectomy now? So now we have to advise her. All this time she's only worried about the baby. Now we have to make her understand that, as you said, you had counseled her earlier itself that she requires removal of the uterus. So now we try to push home the fact that she has to go for a hysterectomy. Each time we say hysterectomy, she will run away for 2 months and then come back. So now does she require pelvic node dissection in this case?
No need. I think it's a simple hysterectomy may be enough because it probably is still in the endometrium itself. If it was crossed the endometrium and reached the myometrium, then probably pelvic node dissection is essential.
So what are the investigations you will do prior to this planned hysterectomy?
MRI.
MRI. Anything else?
PET scan.
Would you like to do a hysteroscopy biopsy before we?
Yes, hysteroscopy with biopsy.
I think we should do a hysteroscopic biopsy. Anyway, we did a hysteroscopy and the biopsy came as proliferative endometrium now. All this repeated high doses of progesterone, I think it has suppressed it and it's become proliferative endometrium. So would you still like to go ahead with the hysterectomy?
No.
No.
No need. If she's not bleeding.
She's ready to come for follow-up. I'll just leave her to come for follow-up.
So basically, but she's had a malignancy. The next time she comes, we cannot ignore her. Now her basic need to have a child is over. So I advised her to go ahead with the hysterectomy. So we saved her uterus. But the question is whether we should remove the ovaries now. Because ovaries again produce the estrogen. So, but remember it is only proliferative endometrium. So could we just get away with a hysterectomy? At least her ovaries can be with her. What do you say, Dr. Prajbala?
She's quite 32 years old and there is no any family history, so we can say we can
try to do any other test for her.
BRCA.
Okay, so we did a BRCA and even a Lynch we have to look for because one of these things can be there in the. But she has no family history basically. But I think we should do that and then take a decision, because later on, if she comes back with an ovarian cancer, that would be a problem as well. It came negative for her, and then we did a hysterectomy. So the hysterectomy was a little difficult because the uterus was all adherent to the anterior abdominal wall. And finally, the report came as proliferative endometrium with adenomyosis, chronic cervicitis, and the tubes were normal. So you can see the procedure going on, and that is the end of the procedure. I'll just fast forward because we don't want to watch the hysterectomy. So that is the end of hysterectomy. So right now, the uterus has been rightly sacrificed at the right time. So we tried to hold on to the uterus as far as possible. One, because the woman also is upset if the uterus goes off, and now the child is about 2 years old and the uterus was removed. And I see her every year on the child's birthday, and she's doing good. So here our 7 panelists here have become infertility, oncologist 1, endoscopist, fetal-maternal, laborist, emergency doctors, and general gynec. And finally, we'll have to go into menopause for this lady. So we as gynecologists have to do the multiple roles and support her during this period.
Only one thing we have all become psychiatrists also.
No, but I appreciate that patient was, with you for so many
Yeah.
years.
The second time she bleeds, she may not.
Yeah, that is the
not
problem.
come to us, and then she will go to some other
back
doctor.
for follow-up. Yeah.
So compliance of the patient was excellent.
Yeah.
Patient compliance was excellent, ma'am.
Yeah.
But that
Which is an
goes with
educated,
the
which is an
patient,
educated patient.
Yes. And I think counseling and gaining the confidence of that patient was equally important, so that she continued with.
Exactly. That's very important. And I mean, she's still to date, I'm monitoring her ovaries, etc., and that has to go on. So now we have a second case. Mrs. NM, 21 years, unmarried girl in July of 2015. She comes with a report of mass abdomen and symptoms of pain. On examination, she has a 24 to 28 week mass in the abdomen, and the scan report shares multiple fibroids. And what are the sizes of these fibroids? Intramural 8x7 at the fundus, anterior wall 6x5, 2x2, 3x3, posterior wall 4x4, 2x2, 7x7. Both tubes normal, ovaries enlarged and polycystic. What do you want to do for her? She's just unmarried, a 21-year-old girl, finishing college, and she comes with this huge mass. What would you want to do for her? Radha Madhavi?
She came to me for pain. So I'll just, what to do with her? She's unmarried, 21 years. She has come with pain. I'll just relieve her pain and not hyper fibroids now. Then she'll not marry at all.
But she's, it's a 24 to 28 week mass. Huge mass. Dr. Saravana Kumar?
Actually, after proper counseling with the patient, because we need to tell her about the reproductive outcome also for the patient. Suppose if I am doing a myomectomy for the patient, because depending upon the location of the fibroid, I put an incision. This probably will be an open myomectomy only for me because of the expertise. And so if I plan for myomectomy for the patient, I have to tell about the reproductive outcome. And I think she is very young with her AMH levels being normal. She can conceive. The only thing is that she shouldn't be losing the pregnancies. So all those things, complications, I would counsel her, and I would probably go ahead with the myomectomy.
Okay. Dr. Brajbala, would you like to add what would you do for her?
Yes, madam, because she is having multiple fibroid and it is causing pressure effect and pain. So we need good counseling, proper follow-up. Sometimes we may need to do myomectomy for big fibroids, and we need to keep her follow.
Yeah. Dr. Jamna Devi, you agree with this?
Yes, I think we can give an option for even laparoscopic myomectomy also.
Yeah, laparoscopy also could be done, but we have 2 large fibroids, and would you counsel her that at this myomectomy, there is a possibility that we could have to go ahead with a hysterectomy if she bleeds too much?
Yes.
And what are the precautions? Would you counsel her that?
We have to counsel her for all the complications what we
Kumar?
face.
Yes, madam. Definitely, I would counsel for a hysterectomy, but we will take all the precautions to avoid hysterectomy.
So, I mean, you have to tell them that will the uterus be removed? Generally, not 99% no, but there could be a rare thing where we may have to. I think it's important that we tell the patients many of these things. They are accepting of that. It's not that they will not want the surgery. It's just that you have to tell them before you proceed. And then, of course, we take all the precautions. How do we proceed? What are the options? You said about the counseling, which is very good. Would you like to do medical management for her? But Radha Madhavi was not happy about surgery.
Yes. Now that ulipristal and all has come, no? And I don't know how to talk to her parents in the first place. It is so difficult to counsel a mother that your daughter is having such a problem. Her uterus will go, means she will leave us and go in the first place.
Yeah. No, they won't leave you and go. As long as you counsel them properly, they need help. So we need to be standing by them during these problems. And medical management, what are the other things you feel about medical management?
If it's one or two fibroids, probably I can go for a medical management, but multiple fibroids, I will not get a proper plane to dissect out the fibroids. And the other thing is I may miss some fibroids also, which may regrow afterwards. So I wouldn't go with the medical management. I would take precautions during surgery.
Yeah. Okay. So just as you said, we have to plan for surgery. And the risks have to be explained, preparations for the blood transfusion, etc. She's not bleeding profusely, so she's not anemic. So what incision over the uterus? On the abdomen, what incision will you take? On the abdomen, what incision? Dr. Jamna Devi, we are doing an abdominal hysterectomy, as Dr. Sarvana Kumar said. It was quite big. We could attempt laparoscopy.
Vertical would be better in this case because it is 28 weeks, 24 to 28 weeks.
So vertical low incision was made, and over the uterus, you have any particular preference for the myomectomy?
Transverse is better than vertical.
Midline vertical over the anterior wall. If there is a fibroid there, I put the incision over there, remove the fibroid, and then go tunneling, try to find out as many fibroids as possible. And then probably I can open up the cavity also and remove the posterior fibroids if they are there.
Yeah, posterior, we can always move the uterus forward and try and deal with it. So laparotomy with midline vertical incision, myomas enucleated, cavity not entered. Can you be sure you removed all the fibroids?
No,
Intraoperative ultrasound.
Do any of you have intraoperative ultrasound?
No, I have seen once. That's all. I've seen once when I went for a laparoscopic.
Generally, it's not there, but we don't. I mean, it's very difficult. But all you can do is palpate and see and try and remove as maximum as possible. And would you like to check for tubal patency?
Yes.
Yes, of course.
Yes.
She is unmarried.
No.
Okay.
No, because chances of blocking by ourselves is more than patent tubes can get blocked because of our handling.
Dr. Brajbala?
No, madam, not.
No. So some of us will not do. Most of us, as you said, probably we will just leave tubal patency. She's unmarried and 21 only. Any medication post-surgery?
Now we can give some medications like ulipristal or mifepristone because
Ulipristal is prevention. Ulipristal gives prevention.
Now, if there are few fibroids are left because she was having 2-3 big fibroids and we may not be able to remove all, or we have intentionally left few to avoid cavity.
Yeah. So would you like to give Dr. Sarvana Kumar your opinion?
No, but I have no experience in giving medical management for a fibroid.
So yeah, ulipristal at that moment was available, but I didn't give her. And how do we follow up this patient now? Any particular follow-up schedule you want for her, or if she is comfortable, we leave her alone?
Ask her to get married quickly.
Okay, that's a good idea. I mean, that's important information that we have to tell. because many of them will be career oriented and decide to finish their career at 29 only they will think of pregnancy. So I think that's a good idea to say. But again, to find the correct person is not easy. It may take many years. So now she is getting married as per Dr. Jamna's advice. In September 2018, 3 years later, she comes saying she's getting married in November 2018. Now she's 25 years. What is the advice you want to give her now?
Again, uterus is
She will-
28 weeks.
Pardon?
Uterus is 28 weeks again?
Yeah, she's just come to tell you she's going to get married, and then you examine her, you find the uterus is now again 26 to 28 weeks in the span of 3 years.
You have recurring problems in all your patients.
Yes, I think I'm specializing in that.
So again, she has fibroids.
Yes, multiple fibroids. And it again shows a large intramural. Now it's almost 10 centimeter, 1, 6 into 5. And some with cystic degeneration, anterior wall above the cervix 1, posterior wall again, some fibroids. So what do we do with her now? Shall we just tell her, take this uterus out? We don't want it anymore. Are we going to save the uterus? She's going to get married. What is the advice for her?
Probably you have to save the uterus. Again, we have to repeat the same thing and
Repeat the same
explain
thing.
all the complications and everything. If she is ready, we can always try for myomectomy and then ask her to go for fertility treatment as soon as possible.
So, so the counseling, you have to think of that. And what are the complications you will tell her for during surgery?
Again, bleeding. And
Bleeding.
Anything else?
And again, tubal damage.
Anything else?
Tubal damage.
Chances of hysterectomy.
Chances of hysterectomy. Also, because of her previous laparotomy, she can have adhesions, bowel adhesions.
Ah, that also.
Yeah, so we have to counsel. When we are counseling all these things, we have to tell her that you're going to be careful, but you could have the problems of all these things. Medical management, I think all of us are not for it. And preparations for surgery, as you said. So this time we tried laparoscopic myomectomy. We removed the large fundal one and 2 of the anterior wall fibroids we managed to remove. But then the adhesions became very difficult and the multiplicity of, pardon?
Sorry, there are 5 more minutes, ma'am.
Yeah. So we converted into an abdominal myomectomy with adhesiolysis, fibroids enucleated, sutured in 3 layers. And in the posterior wall, we did with 2 layers. So this was the second repeat myomectomy, which was open for this time. I mean, we tried laparoscopy and had to convert. Cavity was not entered. Peritubal adhesions were there. Of course, just as you said, there are adhesions. So those had to be removed. We this time put interseed, 1 posterior and 1 anterior to cover the whole uterus. And would you like to do bilateral uterine artery ligation or coagulation in the hope that it will prevent further fibroid formation?
No.
No. Yeah,
We
because
have fertility and we are not having many literatures regarding this women who are planning for fertility. So I think, but we will do tubal patency this time.
Exactly. So tubal patency can be checked. And any advice, any meds, because now she's going to get married in a month's time because she needs to conceive. At this point, tubal patency was important. And so no other medication, none of you want any medical management. And now the saving of the uterus ended up in a pregnancy in a very short time. She is now pregnant in Singapore. LMP is 17th May 2019. So at 7 weeks, 5 days, beta HCG is 37,233 on 8/9/2019. Are you happy?
No, it's very high.
It's very high. Yeah, so the success was short-lived. They did a scan on the same day and she came out with a cornual ectopic with fetal pole of 4 mm FH+. She comes away to India and comes back to you and says, "Doctor, what should I do?" What will you do now?
Cornual ectopic.
Pardon?
Cornual ectopic it is.
Yeah, they have said in Singapore, cornual ectopic with fetal pole 4 mm and FH+.
You have to re-evaluate and then see exactly where it is.
Yeah.
And then
So this is
admit her in the hospital.
Admit her in the hospital and evaluate her. She's asymptomatic basically. So would you like to give injection methotrexate?
Yes, we can.
Do you think it will work?
Beta HCG is very high for
very
high for methotrexate.
So no point in giving methotrexate or any point in giving methotrexate.
And if the corneal ectopic ruptures, it bleeds very heavily. That's another problem with the corneal ectopic.
Yeah, but methotrexate will not make it rupture, right?
Yes.
Yes, methotrexate I think will make it less vascular, in fact.
Less vascular. So that may help us. So we gave methotrexate and also FH was plus. So we thought for that reason. And beta HCG on then 2 days later was 55,000. So obviously we decided.
Lap.
Yeah.
Lap.
So we examined her. You forgot about the fibroids now. Uterus is now 22 weeks when we examine her. And the scan says cornual ectopic with multiple fibroids again. So what is your plan now? Do you want to go in open laparoscopy? What method would you like to do? Because she has 22 week size uterus and it's not 28 now, but it's less. 2 centimeter multiple fibroids all over the place, 2 to 3 centimeter.
Because earlier we have tried with the lap and we had to open it up.
Yeah.
So there's no point in going for a lap. So it is better we go straight away for open.
Open, but open will actually make give her more adhesions, more problems. So should we get rid of this uterus now? Anybody in planning to remove this uterus? Because the 3rd time she's come up with multiple fibroids and all sorts of problems. Anyway, as usual, the patient doesn't want and we comply. Endoscopic management, we tried. Would endoscopic management or hysteroscopy of this cornual ectopic be possible? Can a cornual ectopic be removed by hysteroscopic attempt?
I don't know.
Dr. Brijbala?
Can be done, but with proper counseling, because we may not succeed in doing this. So we have to take proper counseling. All the consent.
Okay. Yeah. So we will do a hysteroscopy, attempt it. And if it's not, then we have to go for laparoscopy. So this is the thickened endometrium that she had. And the cavity is absolutely normal. No sac you can see anywhere here. Both the ostia you can see quite clearly. The cavity is adequate. And you can see also that there is a subseptate area in the middle between the 2 cornua. But this is the cornua which has the ectopic. So this is a small septum which is there. Nothing is done for that. And then we go on and try and remove this cornual ectopic. Will you plan to do myomectomy along with this?
No.
You are inside anyway, laparoscopically.
I don't want to do
I can see she's very vascular right now. Not correct.
If you inject vasopressin, the vascularity reduces. You can see the ectopic here, and you can see one ovary is here. The tube is hidden behind the ovary. So she requires not only myomectomy now, she requires edesholysis if she is to conceive after this.
Yes.
You can see the bowel is adherent to the posterior wall here, as well as bowel adherent to the ovary. But below that, it seems to be quite clean. And edesholysis was done for her. And also we had to remove the cornual ectopic. So this edesholysis is also important if you are removing fibroids and the ectopic. I think we have to do edesholysis so that the tube is released now. The fallopian tube is stuck inside with the ovary here. So any surgery, as we know, this lady has shown us that she has a propensity of producing more and more fibroids and more adhesions. So you can see now, this is the, how would you like to treat this cornual ectopic laparoscopically? Anybody wants to say? Or even open surgery, how will you deal with a cornual ectopic? Because as you said, it can bleed heavily. Now we have given vasopressin, of course. So what would you like to do? That's the tube on that side, which seems normal. But of course, with the cornual ectopic, she's going to lose that tube. All of you agree that she's going to lose that tube?
Yes, sure.
Yeah, for sure. So how do we do this? Any plans, Dr. Sarvana Kumar?
I would probably resect it along with the uterine myometrium and resuture it.
Okay. So I'm putting a lasso-like loop, rotor loop around it to reduce the bleeding. And then, oh, sorry. Okay, it's gone. So we put a rotor loop around it, squeezed it tight, and then made an incision over it and removed the ectopic mass. And then she also had multiple fibroids. The largest was 3x4 in the posterior wall. Both the ovaries were densely adherent in the lateral uterine wall, so the ovaries had to be released. Right tube was edematous, and of course it was lost. And the left tube was buried in adhesion. This tube was also released.
Excuse me, ma'am. Sorry, ma'am. Sorry, ma'am. We're running short of time.
Yeah. I'll just go. I think that the thing is not moving. That's the once it moves, just finish it off. So now we finished this, and this is in July 2019. And then, of course, she was advised to conceive. When will you like her to conceive after this corneal ectopic? Just 2 minutes.
Go for IVF instead of conceiving spontaneously.
Yeah, but her tube we checked was slow. There was slow leak on one side. The other side was, of course, absolutely not possible.
Because and there were a lot of adhesions, and ovaries were also adherent.
Yeah. So what has happened now is then of course Corona years came. She never came up back for follow up, and she didn't conceive in that meantime. And now in 2022 March she comes again with an 18-week uterus with multiple fibroids. So what will you do now? This is the 4th time she's come back with the same problem. I mean, this is what happened. Huh?
She got a lot of patience than us.
So now in March, again, we had to go in for a lap myomectomy. And now she is on the IVF cycle to conceive. So we saved her uterus, and let's hope she succeeds.
Yes.
I'd like to know the result.
Yeah. She's just going to start IVF cycle this month. Yeah. I hope she conceives. And then we have to also think that if she conceives, her problems at delivery, she will have myomas at delivery. We'll have to do a cesarean myomectomy. So the problems don't stop with this. So if she keeps coming back to me, then I'll have to send her to one of you.
Abnormal placentation also is one problem.
Yeah. Sorry, I think. Yeah,
both the cases were excellent, madam. Both the cases were excellent.
Yeah.
Only one point, madam.
Yeah.
I will insure myself for 10 crores and keep myself.
All of us do that, Radha.
Yeah, this is it. Yeah. So this one, just to finish it now, it's come on. So all this was done. 7 fibroids were removed at that sitting in July 2019. 3rd myomectomy. Hopefully end of story, but she comes back, and again she has this 22-week size uterus, multiple fibroids. Again, myomectomy or hysterectomy, we have to advise her. So that was the end of it. And in that one, we did a septum resection also, so that if we are going to do IVF, that would be beneficial for her. Cavity was entered at this time, and that was the advice. So again, she's come back with fibroids, but not so big now, 3 centimeter fibroids, and she's going for IVF. So I think we will stop. I had 2 more cases, not very long cases, but she's a 38-year-old, previous to cesarean with 8 centimeter single fibroid. Will you remove the fibroid in a 38-year-old, or would you do a hysterectomy for her? Just one question everybody can answer.
Remove the fibroid.
No, yes.
How about you? Anybody want hysterectomy?
I would like to, just remove the fibroid because she's just that.
All want to remove only the fibroid?
Only the fibroid.
Yes.
That is actually, in fact, easier.
Also at the same time.
Okay. So this one also, I'll just leave it because we are short of time. It was an interesting case. But anyway, I thank all the panelists for active participation. And the uterus also is very happy that we have saved the uterus as far as possible. So it says, thank you for saving me. I thank you to Sampath and all the others, Dr. Anjalakshi, Dr. Vijay Lakshmi, Ranyana Shekhar, and everybody. Thanks TCOG, AP, OGS, KFOG, KSOGA, and TNFOG for this wonderful session. Thank you very much.
Thank you, madam. Like everyone should save the
Very
uterus.
excellent cases.
Thank you, Rekha, ma'am.
But madam.
Thank you, Rekha, madam. All of you should save the uterus.
Yes,
Thank you.
Basically, we have to try and save the uterus as far as possible.
As far as possible.
Yeah.
I think Foxy, along with Bayer, is now coming out with the Save the Uterus campaign, right?
Oh, yeah, exactly.
Thank you, madam. Thank you. Wonderful panel. Thank you, moderator and the panelists.
Sorry for going over time, Sampath.
Yes, no
For the
problem. madam.
opportunity,
Last
madam.
talk we have. Wonderful cases. We will, this is the last session. Dr. Madhumita.
Yes, ma'am. Moving on to the last talk of the day. It's my privilege to introduce Dr. Meena Mahalingam, who's the Senior Assistant Professor, Department of ObGyn at Government Kasturibai Gandhi Hospital for Women and Children, Triplicane, Chennai. She's an instructor of Basic Newborn Care and Resuscitation Program under IAP, and she also has 8 publications, including 5 original articles to her name. Over to you, ma'am.
We will be talking on ring pessary. Dr. Meena.
Meena, ma'am.
Yes, ma'am. Am I audible, ma'am?
Yes, audible. You share your screen.
Ma'am, can you see my screen, ma'am?
இல்ல தெரியல நீ மட்டும் தான் தெரியற.
Just a minute, ma'am. Sharing. Ma'am, is it visible now?
Yes, ma'am. Can you come on full screen, ma'am?
Yes, ma'am. Ma'am, is it on full screen now?
Yes, ma'am.
Okay. Shall I start, ma'am?
Yes, ma'am, sure.
Good evening to all the dignitaries. I thank TNFOG and all the team for having given this opportunity to me, especially Sampath ma'am and Anjalakshi ma'am. So I would be taking through a video session of ring pessary. So thanks for also changing my time because of my family function. So in the historical perspective, we had pomegranate and wood apple being used as a pessary and also leg binders and astringents. Evidence says the few literature-based reviews and reports recommend pessaries as the first line in women with pelvic organ prolapse. They are mechanical devices used in the conservative management of pelvic organ prolapse. And there is little consensus regarding choice of pessary and management. Most of the information on pessary use is derived primarily from descriptive studies, retrospective studies, and relatively small prospective series, manufacturers' recommendations, anecdotal experience, and the Cochrane review in 2020 says pessary and pelvic floor muscle exercise yield better results for the management of pelvic organ prolapse, the conservative line. So how do they act? They mainly provide pelvic organ support within the vaginal vault. We do have the type of pessaries like support pessaries and the space occupying pessary. So my topic is ring pessary, which is mainly for stage 1 and 2 and can also be used for stage 3 and 4. And we do have the gel on pessary, which is mainly for stage 3 and 4. So there are different types of pessaries. We do use them for uterine prolapse, first and second degree or third degree, cystocele, rectocele, or a cystocele with stress incontinence, or a simple stress incontinence, or for a mild prolapse, or incompetent cervix. These are the different types of pessaries which are in use. So I would be taking you through the ring pessary. We do have different materials from which the pessary is prepared, the latex, the silicone, the plastic, that is the PVC, and the red rubber. These are the silicone ring pessaries which are of different sizes, varying from 2 inches, 2.5 inches, and 3 inches. And the PVC pessary also available in different sizes, and the thickness is around 1.25 centimeters. Silicone pessary, mainly it is a longer duration of longer durability, autoclavable, does not absorb the secretions and odor. It's an inert material. So as we all know, indications of pessary is women who have medical conditions which prevent them from having a surgery or desire to avoid surgery, or there is a significant degree of prolapse that makes other non-surgical approaches
feasible, pregnancy-related prolapse or puerperal prolapse and incontinence in elderly women. So as we already know about the uses, the uterine prolapse, prosidentia, cystocele, rectocele, urethrocoele, stress urinary incontinence or a retroverted uterus. First thing in any procedure is educating the patient and counseling the patient. We need to discuss the condition, explaining the risk factors and the choice of the pessary, follow-up recommendations about discussing the sexual activity and need for change of the pessary. And the successful users, according to the evidence, is when the woman is very old and where there is a medical comorbidity and the woman is sexually active. Unsuccessful users, when the vaginal introitus is less than or equal to 6 centimeter or a wide vaginal introitus, stress incontinence, stage 3-4 posterior compartment prolapse, or women who desirous of having a surgery at the first visit. So coming to method of the insertion. So first, after counseling, we need to know what is the size of the pessary which we have to use by doing a digital examination and measuring the size by the distance from the lower edge of the symphysis pubis to the posterior fornix. We need to reduce the prolapse and assess the size. The type is based on the patient's needs and the activity, the sexual activity level. For any procedure, we do take strict aseptic precautions, washing the hands, tearing the pessary from a sterile cover, and it is important to do a folding or compressing of the pessary and need to apply a water-based lubricant so that it does not cause any friction on application, and explaining the women and making her lie down in the couch in the lithotomy position after emptying the bladder, standing on the right side of the patient. The non-dominant hand separates the parts of the labia. The dominant hand introduces the pessary to lie exactly in the posterior fornix posteriorly and at the lower edge of the symphysis pubis anteriorly. So now I have taken some videos using the mannequin, and I have also taken consent from few patients and I've taken this recording. So in this mannequin, I'm going to show how we are going to measure the size. It is a trial and error method. So here we can see in the mannequin, I'm going to introduce the gloved sterile hand into the vagina and make a measurement of the lower edge of the symphysis pubis to the posterior fornix. This exactly makes the measurement for the diameter of the pessary. So in this, I'm applying a red rubber pessary, applying a lubricant over the red rubber pessary, and gently applying the water lubricant jelly over the pessary and compressing it, making the pessary go into the anterior posterior area and then making it to lie behind the posterior part of the urethra, that is above the pubic symphysis, and also posteriorly it just lies touching the sacral promontory, that is the posterior fornix. And then make sure that one finger runs between the vaginal epithelium and the pessary, so it is not too tight. And once also we need to demonstrate about removing the pessary after the follow-up is done, and if the patient is coming for a removal of the pessary, we do removal of the pessary by hooking using the index finger. No need any anesthesia, just bring it down. No need to compress it as we do in the time of insertion. So this is shown in the mannequin. Now I've taken this stage 1 to 2 prolapse, wherein I've tried inserting the same pessary, which is a smaller size. This is again determined by the trial and error method. Here we can see, play the video. Yeah. So I've applied the water-based lubricant jelly and compressing it, trying to take the pessary anterior to posterior, and then pushing the pessary up to lie between the behind the urethra, behind the symphysis pubis, and posteriorly to lie in the posterior fornix or the sacral promontory. So again, after reducing the mass, we try to reduce the mass and then try to insert the pessary so that it lies behind the symphysis and also at the level of the sacral promontory, so that it supports the pelvic organs from prolapsing down, and small rim of the pessary may be seen And at the time of removal, we just need to hook the pessary and then bring it out. No need to, really compress. So this is a PVC pessary, and it is also cost effective. Again, I would show in the mannequin and then go through one of a patient which we have a stage 3 to 4 prolapse. Here we can see in the mannequin, I'm demonstrating by applying a water-based lubricant jelly and compressing the pessary and trying to insert. The same time, the non-dominant hand parts the labia and the dominant hand tries to push the pessary inside so that it is placed posteriorly supporting the sacral promontory and anteriorly retracting the fat behind the pubic symphysis. And running a finger so that there is no pressure over the pelvic area. There should be a finger freely moving between the pessary and the vaginal epithelium. So this is how the pessary is introduced. And again, demonstrating the removal of the pessary in the mannequin, introducing the 2 fingers of the gloved hand, informing the patient, and trying to remove by gently hooking the pessary and bringing the pessary outside. So this is a PVC pessary. There's not much of pain when removing the pessary as well as during application. So now coming to a stage 3 or stage 4 pelvic organ prolapse, where the woman is not desirous of having a surgery. Here I would be taking the same PVC pessary, the plastic one. Here trying to reduce the prolapse before inserting the pessary. So gently asking the patient to loosen her pelvic area and trying to reduce the prolapse. The huge prolapse has gone inside, and then taking the PVC pessary and then applying the water-based lubricant jelly, compressing the pessary and inserting it anterior posteriorly so that it is taken posteriorly to the posterior fornix and anteriorly behind the pubic symphysis. And again, a finger is run through to see if there is no compression on the vaginal epithelium. So the whole prolapse is on the inside, and I'm able to insinuate the finger between the vaginal epithelium as well the pessary. And again, on removing, just gently need to hook and bring the pessary outside. So after insertion, what is to be done? So as we all know how to insert a pessary, after inserting the pessary, we need to ask the women to stand, sit, perform Valsalva, ask her to pass urine, void, cough, see whether the pessary is retained or has fallen. Assess to ensure it is providing the desired support and leakage control if it has been used for stress urinary incontinence. The patient should be able to void freely, and proper size, we should be able to seat the index finger between the pessary and the vaginal wall, and patient should feel comfortable with the pessary in place. She should not feel any pain. Insertion of the pessary will be eased by using a water-soluble lubricant and folding the pessary to reduce its size. It can be compressed with one hand. When it is inside the vagina, pushing it high up behind the pubic symphysis and inserting the device more posteriorly to avoid any injury. Instruction for insertion and removal. Either the patient can herself introduce by standing or in the supine position, depending on the dexterity. If the patient is right-handed, she can place the right leg over a stool and keeping the left leg over the stool and inserting the pessary with the right hand. And if she is left-handed, she can place the right leg over the stool and introduce using the left hand. So she'll get used to once she's trained. And the complications, as we all know, any pessary, any foreign body inside can cause a vaginal discharge and odor, failure to retain the pessary, excoriation or irritation with large pessary use with reduction of vaginal prolapse. De novo or increased stress urinary incontinence may occur as a new symptom, which we need to talk to the patient. More severe complications are rare, like vesicovaginal fistula, small bowel entrapment, hydronephrosis, and urosepsis. Contraindications mainly latex allergy, genital infection, or undiagnosed CA of the vagina.
Excuse me, ma'am. We have 2 more minutes, ma'am. 2 more minutes.
I'm finishing. One more slide.
Thank you,
Placement and management. Thank you. Pessary placement involves consideration of a number of issues, primarily the patient's desire and motivation to continue the use. Typically, if she has had previous surgery or strongly desires to avoid surgery. Other issues include current sexual function status, type, and during whether she does exercise in which the patient engages, and the status of the vagina and the cervix. In hypoestrogenic women, treatment of the vagina with estrogen creams, maintenance of the intravaginal estrogen treatment is recommended. Follow-up, we need to make sure that the patient is kept in follow-up, either the first follow-up 1 to 2 weeks and later 4 to 6 weeks. After this initial follow-up, 6 to 12 months interval if the patient needs to continue using it, and also 4 to 12-week intervals are appropriate. On follow-up visits, proper placement of the pessary and support as well as continence efficacy should be assured. Because pessaries are fit by trial and error, it is not uncommon to change the size or type. The pessary's integrity should be checked, the tissue evaluated for irritation, pressure source, ulceration, and lubrication. Removal, as I've explained detailed in my previous slides, does not require anesthesia. Just hooking and removing. Difficulty encountered in incarcerated pessary may require help in examination in theatre. How long can it be kept? The observational study says continuous use recommended for 2 years in hysterectomized women and 4 years for non-hysterectomized women if no complications. To sum up, I would like to conclude by saying ring pessaries are easier to insert and remove. Short learning curve, trial and error in choosing the size determined by vaginal examination, and follow up at regular intervals to keep in mind forgotten pessaries. I would like to thank Sampath Kumari ma'am, Anjalakshi ma'am, and the entire team for giving me this opportunity of presenting this video session on ring pessary. Thank you, ma'am.
Thank you, Meena ma'am, for the detailed and interesting talk on ring pessaries. Coming to the end of the session, I request Dr. Sampath Kumari ma'am to give the vote of thanks.
Yes. Thank you, Madhumita. So we had the wonderful conference for the past 2 days. I take the pleasure in delivering the vote of thanks. I thank the chief guest, the president, Dr. Shanta Kumari, guest of honors, Dr. Madhini madam, Dr. Vindhya madam, and the special guest, Dr. Faisal Louis, Dr. Anjalakshi madam, Dr. Ganga madam, Dr. Kasturi madam, and Dr. Sarina Gilvis madam, and all the president and secretaries of 79 societies, and the Secretary of Federation, Dr. Jamuna, Dr. Uma Shankar, Dr. Bharti Rajshekar, Dr. Venugopal, and me. And I thank all the national and international faculties and speakers, including chairpersons, moderators, panelists, and the keynote address speakers, and my coordinators, Dr. Kalpana, Dr. Priya, and Dr. Madhumita. She was there from morning to end today. And the recap doctors, Dr. Priya Kannappan and Dr. Kirtika. And I thank Dr. Priya, the event manager. She was the backbone of this program, and Shield Pharma for the wonderful support. And event that Sahita, this is the Sri events. She is a Dr. Priya, the event manager for Sri events. So I thank everyone for the wonderful conference for the past 2 days, and delegates. Already I have informed the delegates. We had 2,197 delegates, I think. Definitely it was a wonderful conference. If I have missed anyone, please excuse me. Thank you once again. I thank.
Thank you, ma'am. Very nice. Very nice. Thank you, ma'am.
Thank you. Rekha madam, thank you. Yes, thank you. All of us can have that.